Hi everyone, very good afternoon guys, and before I start, congratulations for having finished the NEET PG 2025 after all the struggles, obstacles, postponements, etc. that happened. At least one side of it you have passed, and that is you're on the other side, which we had promised that we would meet very soon. So congratulations on that. And this is of course not an exact recall because I think it's just been over 2 hours or so since the exam got over. So we don't even want to bother you too much by asking you too many questions and options. But whatever we have been able to gather from the students up till now on different social media platforms and by the team, we are discussing that. But I think before I get on to questions right away, what I have gathered from the students, let me share that with you, and I want you to add on to it. The question paper has been considerably previous year topics. They have been asked. It's not a complete wipe off. Definitely, many previous year topics have been included. What I felt, while the topics have been pretty easy that were asked, it's not something totally rare or some kind of a discovery that was asked in the paper. They were pretty doable topics, but then there are some questions where the language of the question and the language of the options has been tricky. I mean, there are some subjects where the language has been pretty simple also, but then there are places where I felt student might feel that, oh, this question and this topic I had read so many times, but the language that was given by the examiner did make you think over it. And that is a basic thing that I got as a feedback in the very short time that we had right now, that ma'am, while we saw the question and we could see the buzzwords, but when we started reading the language and the length of the questions, we started doubting ourselves, even if the question was appearing very simple. Coming on to my subjects, that is path and micro, I have got a feedback that it was pretty doable and students have been happy with whatever questions have been asked. Whatever I have received up till now, I also believe that you would have been, having been with you in this journey over the past many months, I think we have discussed it multiple times, from rapid revision to LRR, images, one-liners. I mean, we did what not to remember all of that information. So I think path micro, at least from my side, I believe was good. But if you have made some silly mistakes, which is a very natural thing to happen as a human being, don't be too harsh on yourself, because that's just, even if you tell me to sit in that exam pressure and attempt path and micro, as a human being, I would also make one or two silly mistakes. And if you've done that, it's perfectly fine, because every student has their own set of silly mistakes. Someone will have it in pathology, someone in anatomy, so on and so forth. So I think if you found your silly error after coming from the exam, just laugh it off for the time being. Anyway, you can't go back and correct it. So might as well wait for the others to realize that they have also made those silly mistakes, which everyone will realize, because these questions will keep coming back to you in your sleep, in your dreams, on YouTube, on so many things. So my advice to you right now is that at least for the next 1 to 2 weeks, once you're done with this entire recall mania, as I call it, once you're done with all of it, just shut off all the academic platforms that you had, because you've already been very loyal to them. But I think now you need time for yourself, your family and friends, which you're going to do. So now, of course, I don't have the exact set of questions, but since the past 2.5 hours, after having discussed it with a lot of students, I've tried my level best to extract what I can. And the rest is going to be with the help of you guys in this live chat that will be. So I'll start with pathology. That got more questions. Although many students told me that ma'am, micro se bahut zyada questions aaye, but when I started gathering questions from them, still what I have received is pathology is more. And I did see a couple of FMG topics, the exam that was recently conducted on 26th. I saw a lot of questions were repeated from them as well. If you want me to overall rate this paper, I would definitely say it is a moderate paper. Some of you did come out initially and say, ma'am, bahut easy tha, but that was a very initial reaction. Yes, there were easy questions, easy topics and PYTs, but as I started discussing all the questions with students, I realized the language and the options did make it a moderate. And in some, subjects, it's gone to the difficult side, but definitely not a very easy paper. But yes, I do believe that the cutoff would be slightly higher in comparison to the last year. So now let's quickly scan through whatever best I could, and of course, open to discussion. This is going to be an entire marathon, which means that we are going to have all 19 subjects discussed today itself, and all the educators are making sure that everyone's online, one after the other. Everyone's going to come to you and discuss the questions, and I think that will at least help you calm your nerves post exam also. Starting off with the first question that I received from the students, it was about caspase is used in. So I think everyone knows it is apoptosis and it is pyroptosis. You got multiple combinations, I believe, and that's what I've received as a recall. So apoptosis, yes. Pyroptosis, yes. Apoptosis was 8. 9, 10, and 3 and 6, which we had 3, 6, 7, and pyroptosis is 1, 4, 5, 11. I know you're not in a mood of discussing, but apoptosis and pyroptosis, not necroptosis, because we had done it a million times that necroptosis is caspase independent programmed cell death. That was the definition. So please, I hope you've not marked necroptosis. It is apoptosis and pyroptosis. The last option, someone is saying that apoptosis and ferroptosis was the option. Ferroptosis, again, we don't study about caspases here. The answer is definitely apoptosis and pyroptosis. Moving on to the next question. The next question that we have is about AML M3. They said faggot cells ka image diya hua tha. I don't know the exact image, but this is what I have taught you in all your video lectures about faggot cells. And faggot cells is seen in AML M3. You know that AML M3, I always told you, when in doubt, the leukemia given to you will be AML M3. And they asked you probably for the chromosomal translocation. So that was 15, 17. Someone said 60 plus. So okay, that is okay. See, sometimes just by looking at the age, you cannot come down to the leukemia diagnosis. If a photo is staring at you and you've got faggot cells, then you will have to go by what the pathology, that is why it's a diagnosis branch, right? You make the diagnosis not by looking at the age, but by looking at the image given to you. So this is AML M3 translocation 15, 17. Many of you said that, ma'am, there were some NPM1 mutation was also there. That is okay. But as long as faggot cells were there, I will still go for either 15, 17 or PML RARA. Whatever was there, you will be discussing that. Okay, moving on to the next question over here was something to do with follicular lymphoma, because students told me that BCL2 and CD10 were mentioned as positive. And then they had asked you, was it something like this, that BCL2 was positive, CD10 was positive, and they asked you the chromosomal translocation. And okay, so yes, okay. So for follicular lymphoma, it is going to be, remember the friendly lymphoma, two teenagers tend to be friends, and that is going to be translocation 14 and 18, the two teenagers. Was this a simple single translocation question, or was it like match the following, ke mantle cell ko match karo with the 11, 14, and then match the follicular? What everyone told me, okay, someone is saying cyclin D and SOX, so wo to alag hoga. Cyclin D and SOX would go in favor of mantle cell. They can't give both the things together. Either they've given this for follicular or they've given cyclin D and SOX. Simple option tha. I think most students told me follicular lymphoma. Moving on to the next, same question came, not same, but the same topic and the same pattern of question came in the FMG exam and similar in the NEET PG, where they gave you a history of Marfan's and they asked you about the gene mutation. What all history I have received up till now is that it was a tall patient. There were some visual problems. Probably this was also mentioned, was some dislocation of lens or subluxation of lens, or ectopia lentis means the same. Any of this thing mentioned, and Marfan syndrome, you know, it is fibrillin 1 gene present on chromosome 15, which is the clear-cut answer over here. So, okay, this is also settled, done. Subluxation was the word. Either ways means the same. Perfect. Moving on to the next. This is another question which students told me कि seminoma का histopathology दिया था. Means they gave you the classical fried egg appearance, and after that fried egg, was there a microscopic image given? या फिर वो gross photo दिया था cut potato वाला? Students told me fried egg दिया था, and ऐसे मैम lymphocytes वाला infiltration was also there. And then along with that, the testicular mass. So we went in for an answer of seminoma, which was given. Okay. Previous question में एक confusion अभी भी चल रहा है. Some of you are saying, ma'am, cyclin D1 was positive. That I will have to think over now, because I will have to ask more students. If cyclin D is mentioned, then I will go in favor of mantle cell. But since no one else told me, and they said that, ma'am, that was not there, hence I thought of follicular. So let's keep that as a question mark and ask more students on what everyone recalls. Okay, gross photo was also given. Acha, no image. Someone said gross nahi tha. ठीक है. Cutout microscopic image tha. Some said image ही नहीं था. See, now that is something which you will only be able to guide me. But at least this much I know कि सबने fried egg appearance अगर लिखा हुआ था या image में देखा seminoma के अलावा, this is not something that you would have marked over there. So I think this is settled over here, right? Done. Right. Okay. Meanwhile, cyclin D1 ka I've got my confirmation. It was not there. Histopath was given. Thought so. Kuch to dena padega na. Either a tumor marker or microscopy or gross. One thing they will have to give you. So microscopy was there, and okay, this is settled. Moving on to the next. And as I said, this is not something that is the final recall. Final recall will come on the app. This is just to ease your nerves so that now for the next 2 weeks, you're just not running after recalls. You're done and dusted today, and you finish off and wrap up this chapter and move on with a fresh life from tomorrow. At least least till when your exam comes. Moving on to the next, although I expected an image-based question to come on this, student said, ma'am, one line, not one-liner, but text mein likha hua tha. Something to do with antennae A and B was mentioned, and as soon as you read antennae A and B, I don't know if verruca body was also mentioned. Either ways, mentioned tha ya nahi. As long as antennae A and B were there, students said the very first option was only a schwannoma, so yeah, that is going to be settled. And usually they gave neurofibromatosis too and whatnot, but they decided to keep it simple over there, and I think that made the day for us at least. Moving on to another, so a lot of brain tumors came, but not the usual brain tumors like glioblastoma, etc. They gave one schwannoma, and then students told me one craniopharyngioma was there, where suprasellar and wet keratin. So till now in this short 2-hour duration, what I've tried to gather ke buzzwords aapko kya kya mile question mein. So you had a child with some visual disturbances with a suprasellar mass, that was location given, and wet keratin. Classical craniopharyngioma. Many of you are saying, ma'am, in many of questions, the correct answer was option A. So Khushi, when that situation arises, that is also sometimes a problem, because you always tend to doubt yourself if you find the answer too easily in the very first option. Then you try to read and you overthink, and that can also turn against you at times, because that is what we've always seen in GTs, right? That when option A is the answer, there is something that I am missing in B, C, and D, which I haven't read. So sometimes that can turn out to be another headache in the exam. But I hope all of you did not overthink and didn't change, because questions like this, where wet keratin, suprasellar mass is there, somehow जब recall में देखते हो ना, वो question बहुत ultra easy लगने लग जाता है. The same question I put on the computer screen in that stressful situation of NEET PG exam, the same question can look a little overwhelming also, because the entire environment is a lot different. यहाँ आके this is something कि, oh, this, someone else, someone who's not appeared for the exam will say, oh, this is the easiest paper, why are you crying over this? It is only a person who sat in that exam knows what happened there. Okay, so Rathke's pouch was also mentioned. Then Acha, okay, you said Rathke cleft cyst was there, but then when wet keratin and suprasellar mass is mentioned, wet keratin will go in favor of craniopharyngioma only. So yes, that can be cystic as well. So either ways, it is craniopharyngioma. Moving on to the next question. This was always expected, and it came where everyone told me, I hope you got the age right. This was 16-year-old boy, something to do with the hemolytic anemia, and they said father also had a similar illness. क्या इसमें सीरोसाइट का फोटो दिया था या नहीं दिया था, that you will have to tell me. So here we had something to do with hemolytic anemia, and under that father also had it, probably autosomal dominant. Was this mentioned that MCHC is high, because that something should have been there? No image of HS was given. Something regarding MCHC was given. So yes, I think previous question में सबको doubt है कि why not Rathke's cyst? Because Rathke's cysts, firstly, usually, I'm not saying always, but usually इतना बड़ा size नहीं होता that it causes visual disturbances. Secondly, guys, wet keratin that was mentioned goes in favor of craniopharyngioma only, and not the Rathke's cyst. Okay, MCHC high was given. Classical, guys, with father or someone in the family having it, autosomal dominant. I always told you ना कि अगर spherocytosis से related कुछ आया, अगर family history आया तो you mark HS, family history नहीं आया then you mark the most common cause AIHA. I think we discussed this way too many times. I'm hoping you got this right. Moving on to this question, CD markers के ऊपर I got a lot of variation. एक question था या दो थे that you will tell me. One question that everyone told me was कि they just asked you कि अगर आपको CD marker measure करना है, which is the technique that you are going to use, and that everyone told me was going to be something to do with flow cytometry. So we got flow cytometry. Did they also mention another question about CLL? Because CLL के CD markers, that is CD5 and CD23 positivity, अगर वो भी लिखा था, then also you will be doing flow cytometry only. This is a question where I am still trying to gather what information came. अगर CLL के point of view से आया था, then also CD markers के लिए you will be doing flow cytometry only. Okay, so best to diagnose. Yes, most of you have given me a thumbs up on that. No CLL, ठीक है. Then if this was the question, then either ways, guys, ये discussion बाद में. As long as CD marker का कुछ question था, measure करने का तरीका has to be for flow cytometry. Moving on to the next question. So I'll cut out 2 questions on this. Only 1 question came. Moving on to thyroid tumor. So many times we had discussed that as soon as some neuroendocrine marker will be given, in the lungs we used to study small cell carcinoma lung. In the thyroid we used to study medullary carcinoma. So if they mentioned synaptophysin, chromogranin, and all of these neuroendocrine markers, plus they mentioned amyloid, वो नहीं भी समझ आया अमाइलॉइड पे तो हैड टू मार्क इट एज मेड्यूलरी कार्सिनोमा थायराइड, यू हैव स्टडीड ए कैल वाला अमाइलॉइड, तो अमाइलॉइड देख के तो मैम वैसे ही बाकी सब बिकम्स इट्स नॉट इम्पोर्टेंट फॉर मी, आई एम मार्किंग the medullary carcinoma. Moving on to the next question is about this. Many students thought that this was actually an ortho question, and this was something which I was recording the latest version of version X ka videos. So when we were doing even last year, when we were doing the rapid revision and all, I thought that this was something from orthopedics that had to be included within the rapid revision. So if you go back to rapid revision and see the last chapter, I have included the difference between gout and pseudo gout, because in ortho it is important. Here you had everything going in favor of pseudo gout because number one, there was a knee joint relation history given, then positively birefringent and rhomboid shaped crystals. This is exactly what was given, the CPPD crystals of photo nahi tha. I know photo I have added just to give you a visual impact, but otherwise exam mein photo nahi tha, that I definitely know. Exam mein described tha na positively, photo hota to that would have been a problem. Photo identify karna zyada mushkil hai. As long as it was written positively birefringent, rhomboid shape, knee joint, you had to go in for pseudo gout. That was something which was obvious from the text itself. Moving on to the next question. One epithelium photo comes every time. Last to last time glomerulus ka normal aaya tha. This time what students have told me कि spotter aaya ma'am, and there was no history site, nothing given. They asked you for the site. Something like this was given. So when I read the options over here, esophagus ka to we know squamous epithelium hota hai. This is not looking squamous. Then we talk about small intestine, उसमें तो goblet cells होता है. I think this was the easiest to rule out. Trachea, ciliated columnar epithelium, easiest to rule out. So even if, okay, some of you said gallbladder was also there. Okay, duodenum. So maybe instead of the intestine, duodenum was the option. I take that, I add that as a correction. Gallbladder was also an option. So फिर कुछ एक तो नहीं होगा ना, something must be missing. Can't have 5. Either ways, options I will take from the live chat. But what students have told me कि मैम photo जो था वो transitional epithelium का था. Is that correct? Was it a picture of transitional epithelium or was it a picture of the gallbladder? Gallbladder cancer का अलग question था. Photo तो at least answer में what was the picture? Let's focus on the photo first because at least we should come to an answer. As long as you were seeing some cells which were in these kind of layers, and the topmost layer was looking like this umbrella. That is how in anatomy you identify the transitional epithelium. ना ऊपर वाली layer looks like an umbrella. Umbrella cells were there. Many of you have told me. तो फिर तो bladder and urinary tract से related answer होने वाला है. Okay, coming to the next one. One of the first few questions that I got as soon as students came out of the exam, anti-SCL 70. anti-SCL scleroderma. कौन से वाले scleroderma में anti-SCL होता है? Diffuse scleroderma में होता है मैम anti-SCL. And now over here they're asking you which of the following is it associated with? Many of you discussed this and said calcinosis cutis, but calcinosis is associated with CREST syndrome, and CREST syndrome is not diffuse scleroderma, that is limited scleroderma. तो उसमें तो anti-centromeric antibody होता है. So why did you mark this? Now this is not associated with any gastric antral vascular ectasia also. This is actually associated with interstitial lung disease if that was a question and an option given over here. So by ruling out, I had to come over here. Some of you couldn't identify the transitional epithelium. See, if you've got, let's assume, I've not counted, but let's assume you've got 22, 25 questions in pathology. 1 to 2 agar nahi hua, that is a very normal thing. Baki agar aa raha hai, so that is something which you should be happy about. 1 or 2 that you didn't get, that is a very normal thing to happen in the exam. Coming back, okay, coming back, CREST के अलावा, so CREST के अंदर तो anti-centromeric है ना, so over here then I will be going for ILD as the option. The answer over here shall be ILD, not calcinosis. Okay, some of you are saying कि जो fourth option था that was myositis. That is also what I've got as an input, which is great, but ILD is what I will go on for. एक और antibody वाला question था which I'm coming to, but let's move on to, पहले 13 हो चुके हैं. The 14th question, this some of you told me कि कुछ gluten का history था and then there was something to do with the skin lesion. So gluten, was this somewhere there in the question also? And yes. Was this there? Something, I don't know if immunofluorescence was there, but there was something vesicular, something that was there on gluten history. I know with celiac disease, it is dermatitis herpetiformis. Immunofluorescence diya tha. So these are the classical tip lesions that we notice. And which is the antibody causing all of them? It is going to be IgA antibody. Is that okay? Yes, immunofluorescence was given. Maybe same photo nahi hoga, thoda variation hoga. So yeah, that would be a separate thing. Okay, so is this fine, guys? Gluten. IgA was also given. That is amazing. So if IgA was given, then it further tells us that, okay, gluten bhi hai, IgA bhi hai, dermatitis herpetiformis is what we are going to go in. Dr. Rishabh, I'll be coming to the pedigree, I think right after this only it's there. Pedigree chart mein XLD to I didn't get. Students told me it was mother to all, father to none. So that means they were talking about mitochondrial inheritance over here, where it was mother to all, like you can see over here, mother to all the kids get it, then mother to all the kids get it, but father se kisi ko nahi mila. So you had to pick up the mitochondrial. I always used to tell you the one that is sounding the most weird and you've not seen in your life, that will be a mitochondrial disease. Kearns-Sayre syndrome is a mitochondrial disease. Others like Duchenne's muscular dystrophies, XLR, Huntington's and Marfan's is autosomal dominant. Even by, coming to ruling out, you could have discussed that Kearns-Sayre syndrome. Someone said even Prader-Willi was in the option. So thank you for that. But again, Prader-Willi option mein hai, but answer nahi hai. Answer is Kearns-Sayre syndrome because it has to be your mother to all, father to none, matlab mitochondrial inheritance. Moving on to the next question. There was a single one-liner. This just before the session, I confirmed with all of you on Telegram that there was an one-liner on anti-mitochondrial antibody. So anti-mitochondrial antibody, abhi pura question I have not got, but I don't even know the options because I think jab theek hota hai, then no one recalls other options. But primary biliary cholangitis or primary biliary cirrhosis, that is something which is going to be the answer abhi tak. But I don't want to give you answers just without looking at the entire question. I would still wait for the question, wait for the options, but abhi jo initial information I have got, that is going to be this only. Moving on to the next, we have something to do with giant cells and stellate inclusions inside. There were two giant cell questions. एक तो micro में I will discuss, वो herpes वाला था, multinucleation, painful vesicles, that was separate. Someone said there was giant cells with stellate inclusions. या तो stellate inclusion था या फिर वो that is asteroid body, or there was something to do with calcium concretions, that was Schaumann body. I think star is what everyone told me. Plus there was a history involving the lungs and involving the lymph nodes along with granuloma. Up till now I think it was sarcoidosis. Image nahi tha, I know. Image I have got because most of you have told me is bar images nahi thi, but something like this was written that there was a giant cell with a star or an asteroid or a stellate shape inclusion is what everyone is saying. So yeah, that is something which we will still go in for, sarcoidosis only. Is that okay? Sarcoidosis का question case was given, so that very well goes. ये वो herpes वाला giant cell वाला question नहीं है, that I will come to in a while. Moving on to the next, this question I'm still waiting because I have not got. I only got from the students कुछ meningioma आया था, so that I've put a question mark. We'll see अगर आगे मिलता है. The next question that I got was to do with Sjogren syndrome, where they told me there was a history of dry eyes and dry mouth, and antibodies were mentioned, anti-Rho and anti-La, which tells me it is Sjogren syndrome. And how would you do under the pathological examination? या mechanism क्या होगा? So we know it is always simple. One liner था ना कि you do a lip biopsy to get the salivary gland, and you have to see lymphocytic infiltration within it. So this is exactly underlying pathophysiology also. This is the underlying histopathology also. Okay. अच्छा, coming back, some of you are saying कि मैम वो meningioma वाले question में dural tail sign mention था. Then तो I think I don't even need to discuss it because it's so obvious, dural tail sign. Perfect. Moving on, ये meningioma भी हो गया, Sjogren syndrome भी हो गया. Moving on to the next. Again, this is something we are waiting for. Hemosiderin-laden macrophages. If you ask me, what are we talking about? Where have we studied? Heart failure cells. Heart failure cells are seen in right-sided heart failure. That is where you see the heart failure cell. So this is something which is there. But then I had received kuch tuta-futa question which I've got up till now on Telegram is this, where they are saying that there is hemosiderin-laden macrophages and mostly there is hemoptysis, dyspnea ki history. So I thought of right-sided heart failure. All except pucha tha. So then we will have to work on this question a little more because I'm sure then these are not the options given. Some of you on Telegram told me कि मैम all except पूछा था, in which embolism was also there. So जहाँ जहाँ bleeding का history होगा वहाँ वहाँ hemosiderin होगा. So if any embolism, any hemorrhage, any venous congestion was written, वहाँ वहाँ hemosiderin will come. But अगर all except था, then there was one question which many of you were saying, protein losing enteropathy. That is not related to bleeding or any kind of hemorrhage. So all except पूछा था, then the answer is going to be protein losing enteropathy that we have. Okay with everyone? Agar all except tha, then that's the answer. Moving on to the next one, I think these are again two which path, biochem, gynae correlation, something regarding Tay-Sachs disease. At least they moved on. They always were stuck upon Gaucher's disease and crumpled tissue paper appearance. Today they moved on to another disease that is going to be the Tay-Sachs disease, and the accumulation was asked. Yes, the accumulation was asked over here, which, okay, I'm still waiting for the options. GM2. Okay, GM2 ganglioside was there in the options. Fine, we take that. And moving on, hexosaminidase deficiency, which we had studied, the cherry red spot, GM2 ganglioside. Okay. And ovarian tumor wala question, I'm yet to figure out, because what I have got is that CA 125 levels were very, very high, which tells me about a surface epithelial tumor, and I will think of a serous tumor. But at that high level, now I started looking at the ovarian mass. So I will not think of a teratoma and granulosa cell tumor. That is not there. When I think of such high levels and I see that the mass is multiloculated, the single best answer is going to be serous cyst adenocarcinoma. But was a mucinous mentioned anywhere? Although mucinous may CA 125 levels बढ़ सकते हैं, but not as much as the serous tumors. Okay, so yes, I need input from this question. I'm sure you will be discussing this in gynae as well. Serous cyst adenoma tha hi nahi options mein. Even better, photo was there. Okay, so then give me time for this. I'll also see and discuss this with Sonali ma'am, and we'll see what all images were there. So image will make it a lot better. I hope teratoma ka koi teeth, hair, all of that was not mentioned. So that would make it an altogether different story. Mucin was there. Was it mentioned? Was mucinous tumor mentioned over there? Then that is again different. But let's just not break our head over it. Let's just say that we'll keep this as a question mark. तो अभी हमने इस क्वेश्चन को, और वो meningioma although पक्का पता है, but the formation of the question needs to be done. That brings us to right now, up till now 22 questions. I believe more coming their way. Quickly in 5 minutes, let's also 5-10 minutes help me with micro questions. At least I want to ease your nerves once कि अच्छा ये मुझे आता था and this I have settled, and rest I can move on at least in life. I'm not going into the hangover of this for the next 2 days also. Right now answer will be serous cystadenocarcinoma, but 2 questions. Meningioma वाले का तो आंसर meningioma है, अगर dural tail sign mentioned था, there's no doubt about it. Ovarian वाला, let me gather more information. Let me see the gross photo that was given, because I was not aware that a photo was given. Let me have a look at that picture, and then I will obviously get back to you on Telegram about it. Okay, so coming now, the first question was something to do with the attachment of bacteria, something similar to group A streptococcus, which is causing pharyngitis in school children, and the component that is responsible for attachment. So anything that is related to, say, teichoic acid or lipoteichoic acid, ऐसा कुछ भी अगर mentioned था, so then we are going to okay, I can see a lot of questions. Mycology was in abundance. Okay, we'll come to that. Lipoteichoic acid was there. Okay, then I will go that. Teichoic, remember tikna, so that is usually for attachment. So I don't think you had to get this. Gram negative wala, Dr. Pratima, is a separate question. This was definitely gram positive streptococcus. Teichoic acid is the answer. Coming to the next one was something to do with the sewage worker, and jaundice is what students told me. Ke sewage worker tha, saath mein there was jaundice mentioned. There was renal involvement because urine output was there, and there was some element. What was the exact wording used for conjunctival redness? Because this came exactly in the last exam also, and they have somewhere repeated it. This is to do with the Weil's disease. Weil's disease is caused by, Weil's dengue hemorrhagic fever is not something I have got up till now. ये मुझे नहीं मिला था as an option. Okay. All except नहीं था इसमें, तो definitely see this goes more in favor with the sewage worker with the jaundice, decreased urine output. Basically Weil's disease का दूसरा नाम is icterohemorrhagic fever. So that ictero word is going hemorrhagic conjunctival congestion है. इसका एक और नाम है, that is hepatorenal syndrome. That is also making sense because hepato jaundice, renal urine output is less. Everything going in favor of more of Weil's disease or to do with leptospirosis. I think that would be a better answer over here. Definitely. Farmer वाला अलग question है, guys. Don't mix up. Micro में यही होता है. You get confused between positives, negatives, farmers. Anyway, let's move forward. We go on to something to do with raw milk. Anything that is raw milk or to do with the poultry. इन दोनों में से कुछ भी आएगा. So after consumption of raw milk, they are saying there are gram negative curved rods, and there are some neutrophils which are seen in the stool samples. Anything to do with raw milk or to do with poultry, undercooked or uncooked poultry, with this kind of gram negative curved rods. Curved rods always tell us that Campylobacter का वो curved एक spiral जैसा configuration होता है. तो Campylobacter is going to be the answer over here, which is definitely okay. Did this have a neural involvement was in this question or the previous question? History of bloody stool followed by what? Watery followed by bloody. That can also happen in Campylobacter jejuni, definitely. Exact a question tha. ठीक है, bloody was also there. I will add that. If curved was not there, either ways, if watery diarrhea followed by bloody along with gram-negative rods along with raw milk, Campylobacter is what I'm going for. If any neurological involvement was mentioned, then we know this can later on cause GBS also. So that would also go in favor of the same thing. Okay. Coming to the next question is perianal pruritus, our favorite. The eggs which are plano-convex. Plano-convex eggs matlab enterobius vermicularis. Someone said कि ma'am perianal pruritus तो था. Now what I need to complete in the question is कि whether the people are saying कि mother saw the worm from the child. Some complicated story was there, but right now I'm trying to gather that story, or I don't think that story is that important as of now. Because when perianal itching and these kind of plano-convex cells are mentioned, anyway, I am pretty much settled that some mother story was there, na mother saw thin worms, so we will figure out. But जब egg का photo दे दिया, तो the story becomes pretty irrelevant, and I will anyway be able to gather it that ये enterobius vermicularis है. ठीक है. Moving on to the next question is TB like history था and tuberculate macroconidia का photo था, तो मैम histoplasma हमने as it is mark करा, and I'm not discussing this. We've done this so many times. Hi darling, see you in the cave. So many times you guys have smiled over it, laughed over it. So then we are settled that हाँ, as long as TB जैसा history था, and along with that there were tuberculate ये छोटा छोटा projections, that is histoplasma, and we got that right. Then there was a question which was a gram positive filamentous organism, and the the buzzword was paraffin bait technique. Plus they said it is Zn stain positive. Everything over here is going in favor of there was gram positive filamentous bacteria, paraffin bait technique tha. Now you need to tell me कि nocardia तो हमने बना दिया. Was it to do with the history? Usually pulmonary history आता है nocardia का. Was it given as a history of brain? Was it somewhere? And modified Zn stain था even better, because nocardia के लिए तो we've been studying कि modified Zn stain term आएगा तो nocardia के लिए होगा. It was cough. Yeah, that is what I was wondering, because usually pulmonary का history आता है, but again meningitis if given was probably given to confuse you, because when you see paraffin bait technique, filamentous, Zn positive, modified, so both were there. Either ways, both bhi hoga. Nocardia is the answer. You've got very classical evidence to call it nocardia. Moving on to the next question is bronchoalveolar lavage. If this question came, then you guys were a lucky batch, because aspergillus question everyone wants कि हमें ये question आ जाए, because we've studied it so well, that you have acute angle branching and septate hyphae, and like a tree the branching occurs. That branching is referred to as the dichotomous branching. So dichotomous, septate, acute angle, bronchoalveolar lavage. So aspergillus is going to be the answer over here, and I'm not wasting any more time on it. Then comes, this was the next multinucleation wala. एक तो वो sarcoidosis वाला multinucleated cell था with asteroid stellate inclusions. This was a multinucleated cell, and they said there were some inclusions in it, but this was the buzzword, that there were painful vesicles that were present near the mouth, or facial pain. This kind of a history was telling us vesicles, painful, tells me about herpes, and we studied that 3M. 3M क्या था? Multinucleation, molding and margination. All those 3Ms, and other inclusions mentioned था. So remember those Cowdry type A inclusions that we study for herpes. This was herpes, and there's no doubt about it. Seriously, there is no there is no 1% doubt that you would have there. Moving on to the next question are these two. I first thought Neisseria से one question आया. Just 2 minutes before the session, I got to know Neisseria से 2 question आए थे. One was to do with Neisseria meningitidis, where they said that there are recurrent meningococcal infections, and one was to do with gonococcal. So I think the examiner just liked the topic Neisseria, or someone was joking that examiner ने notes में से Neisseria का page open करा, and जो उसे मिला he ended up giving us in Neisseria. So what exactly was asked regarding Neisseria over here was, this is a last year question. You need to tell me that let me first go on to, the first question over here. Neisseria meningitidis, M for M, हमेशा MAC deficiency की वजह से होता है, which is C5b 6789, that is MAC. So this was the same question that came in the last to last NEET PG exam also, came in FMGE also. So MAC deficiency, meningitis recurrent. Then someone told me gonococcal infection का DGI का history था. What is DGI? DGI means disseminated gonococcal infection. Disseminated meaning that number one, they were saying that there was a urethral discharge जो gonorrhea के लिए था. साथ में disseminated means joint involvement was also there. Means arthritis was also mentioned. even in this situation, I don't know the options as of now. But if this was something, I know these are not the options. We've really been trying to get the options for DGI, but DGI can also occur because of the same MAC deficiency. So please note that MAC deficiency can be responsible for both kind of meningitis and gonorrhea infection. But abhi we need to figure out the wordings of this question, that and if I know this was everyone said micro was all over, but till now, because we are very close to just the exam being finished, I've got only 12 to 13 questions of micro. But the amount of micro जो सबने मुझे बोला है, I'm assuming that अभी और होंगे, which we will get as the day progresses, right? Even if IgA deficiency was there, Dr. Parmar, in the question, IgA deficiency goes for more of mucosal infections like respiratory, GI infections. DGI ke liye I will still going for membrane attack complex, MAC infection. Okay, coming on to this. This was the farmer ka ulcer. Farmer hai, and then Mecfidian reaction positive jaise hi aaya, ma'am. Then I know that we were dealing with the Bacillus anthracis. So all of you who were confusing कि farmer का कहाँ था, तो farmer with the ulcerative lesion, this was to do with the Mecfidian reaction. So yeah, I think that is Mecfidian positive. Bacillus anthracis is what you are going to settle over here. Moving on to the next one, I think we have one last left which I've got. Wuchereria ka photo is what everyone told me. This is the Wuchereria photo. I hope that you could identify by the whoosh, no nuclei at the tip, and they asked you what is the reason for the limb swelling. The real question was not to identify the species. Filaria was non-sheathed. Wuchereria mentioned nahi tha, that even I am saying Wuchereria was not mentioned. It was a Filaria that was given, a sheathed Filaria. The reason I think again came out to be very simple. It was going to be lymphatic obstruction. Sheathed tha ya sheathed nahi tha. Either ways, the point is that the examiner didn't ask you to identify the name of the Filaria. The examiner asked you the reason for the limb swelling. So that is going to be lymphatic obstruction. The question that I still haven't got as of now is the mycetoma foot, because no one gave me the options. Everyone said, ma'am, ek mycetoma, you mycetoma ka question tha. Correct option पूछा था, हमने mark कर दिया, but we don't know as of now. So are there any more micro questions? Because since everyone said it was all over, so then 13 तो बहुत कम हुआ. It can't be all over. I'm sure there are others also which we have yet to gather and which we will. Okay, I've got one more that someone is saying ADA deficiency पूछा था. That of course is going to be severe combined immunodeficiency, autosomal recessive wala skid hota hai. Then some black color granules. Okay, that must, black color granules must be related to mycetoma only. That was not, I don't think that would have been a separate question. Okay, no mycetoma. Pharma se related also Neisseria came. So I think Neisseria happened to be the examiner's favorite. He ended up picking up Neisseria and just giving it in every possible way. Okay, so right, so this question I will still figure out, and two questions as a homework for me. One is this mycetoma and one is the question of the ovarian tumor in pathology. These two questions are for me to figure out with you guys, which I will keep interacting with you throughout the day on Telegram, and also beneath this video you can let me know once the session is over. Someone also told me another patho question, which would be number 23, which said that it was to do with the xeroderma pigmentosum. Okay, I'll add that. Number 23, xeroderma pigmentosum is nucleotide excision repair defect. In case that was the question, I'll have to figure that out. Microscopy of mycetoma was asked. Fine. Discharging sinuses. Okay, I will put that across. Xeroderma ka to nucleotide excision repair defect hai. One is anopheles. So anopheles ka kya? Was it like a PSM question, or was it to do with the malaria, female anopheles mosquito ya machhar ka photo identification? That was asked. What regarding anopheles was put up. So I think that will, as time will progress, Neha ma'am will also be able to take it up till the time you guys will give more options. FNH ka patho ka photo aaya tha. Okay, so focal nodular hyperplasia. Did they give any central stellate scar or something like that? Yet to receive. Okay, so 4 or 5, I will definitely figure out these. And as I said, the final is going to come up on the app, which will be there also on Telegram, on this YouTube link. We will keep on discussing, but at least, yeah, very lengthy paper, as everyone is saying, is because jab options or questions today familiar topics mein se hote hain, that is when the examiner decides that he's going to give you the the terminology and the language of the question will be such that wo aapko time waste karwayega. And that is what examiner has done over here, because he was giving a known topic, so he wanted to waste your time in some other way. So yeah, I think I'll take leave now, guys. Reason being that we have all the other faculties waiting for you as well. So now we'll have Nikita ma'am joining you for radiology. And of course, with her, you can discuss so many other things as well from so many other subjects. But yeah, she'll be taking the radiology recall. And this is going to go on for the rest of the day. We have all 19 subjects planned today. And I think since you've given a lot of inputs, the other faculties will also be able to add on to their questions meanwhile, and you will get a more accurate recall. But at least before I, sign off, thank you so much for all the messages that I've received ever since the exam got over. I think I was constantly, because I was suffering from that FOMO, and I was constantly asking students that please mujhe bhi questions kuch bata do. But everyone was like, ma'am, it was easy. At least we are relieved. At least it was not something that it was totally unheard of. Manage ho gaya. And when you come out with that kind of a response that manage ho gaya, then I know that, whatever the cutoff or whatever the final result will be, these people will sail through eventually. Right now, you might not feel confident because you're just out of an exam and you have everything jumbled up. All those questions are all jumbled up. Kisi ka farmer, kisi ka ZN stain, everything will get mixed up in the questions, which is very natural. But eventually, when you feel that suna paper tha and I was able to manage and sit through it without shedding tears, I think you've done your job well. And I think we would not be happier if you say that, we've managed ho gaya, bina roye hum bahar aa gaye. That is more than enough right now. But yeah, we'll keep in touch. We have a lot more to discuss, which we will. But I will sign off right now as the next educator is waiting. So over to Nikita ma'am now, and she'll take up the radiology recall with all of you. Thank you so much, guys.
You are live, ma'am. Hello, everyone. Happy afternoon, a very good afternoon. So here we are discussing your NEET PG 2025 paper, and I am sure that the NEET PG 2025 has treated you very well. Majority of the students are happy and satisfied with their performance. The paper overall seems to be on an easy to moderate side, with a lot of PYQs and PYTs being repeated. Right. So the best part is all of you came out from the exam hall with a smile and with a satisfaction, right? That we did well. And first of all, on behalf of the entire PrepLadder family, the faculties, I would like to thank each one of you for those wonderful messages post exam, that how all the videos, the LRRs and everything helped you in your exam. Yeah, right. So we just had pathology and microbiology recall, which was taken by Dr. Preeti. So now we are doing radiology, and the recall will go on for the entire day. So stay tuned to this YouTube channel, PrepLadder's YouTube channel, so that you get to know, the recall sessions are not meant for digging into anybody's mistakes, but just to help us learn and move ahead, right? So let's start. I know, without any further delay, let's start the discussion here. So radiology was easier this time. Last time we did have eccentric question, but this time it was easy. One image was this, which was asked. So this is an IVP image, which is there, and the options were given here. So is it invasive, non-invasive, gold standard for bladder cancer, or is it done percutaneously? Definitely the option C and D are out. Is it invasive or non-invasive procedure? If you ask me, we would put it into like minimally invasive. Right, how do we do IVP is we put the IV dye is given, and then you look at the images. So contrast filled, the urinary system is checked for the kidney, ureter, bladder. So we will put it into a non-invasive procedure, which helps you visualize the PUJ, the pelvic-ureteric junction. It is a non-invasive procedure. That is what we will go for. Okay. If there is anything that you find in the questions that the options were different, anything was different, please to let me know in the live chat so that we can modify it accordingly. Right. So this is going to be non-invasive. Yes. Next one, what is the most important confirmatory investigation? I think the clinical history was also given here. The image of achalasia cardia, this is all-time favorite. So the gold standard for achalasia cardia is going to be manometry, right? It's going to be manometry. Many students said that there was history of weight loss, so we thought it is carcinoma, so we went for upper GI endoscopy. Remember, weight loss can be there in achalasia as well if there was any specific dysphagia which was mentioned. Dysphagia more to liquids, then please to let me know that what was the exact history given in the question. Okay, so there was this history of weight loss which was given. Was any history of dysphagia, whether it was more to liquids or more to solids, anything like that was given? Okay, so in the question, they had also mentioned there is bronchiectasis like changes in the chest X-ray was also given. Okay. History of bronchiectasis. And if that was this exact same image that you were saying with the dilated esophagus and this, achalasia versus carcinoma esophagus, also remember the location for achalasia, always it is going to be the distal esophagus, the lower esophageal sphincter, that is what is affected. And in carcinoma esophagus, though it might be distal, more common is in the mid esophagus where you would see the irregular narrowing, and then you will have the proximal dilatation. If you are seeing that the distal esophagus is what showed this narrowing, then you go for achalasia, right? Exact same image. So that's definitely achalasia, and the answer is going to be manometry here. Going to the next one, what is the diagnosis? Okay, so what do we see in this image is, if the image was like this, there is this tracheal shift also that you are seeing here. There is opacity in the right upper lobe, which is limited by the horizontal fissure. The tracheal shift, the volume loss tells you that this is going to be right upper lobe collapse. The horizontal fissure, I don't know what the exact image was. If there was this obvious shift of the fissure, it is right upper lobe collapse. If there is tracheal shift, then it is going to be right upper lobe collapse as well. Okay, upper lobe collapse. Absolutely right. Lung abscess was another option. This is what is given here. Lung abscess will have air fluid level which is present, right? Air fluid level which is present. Exact this image, tracheal shift, it's going to be collapse. Earliest imaging modality to detect ankylosing spondylitis. We have discussed this, right? All the questions we have actually discussed in our classes, right? So ankylosing spondylitis, earliest is going to be MRI, SI joint. Look for the stir sequence, which helps you to pick up the bone marrow edema, right? Remember that ankylosis is a late finding, early finding bone marrow edema. To pick that up, you will go with MRI sacroiliac joint. Okay, MRI sacroiliac joint. Is this clear with everyone? History of fever was there. But if there was tracheal shift and this homogeneous opacity, you go for collapse. In this question, you guys are saying NTCCP was given in this question. History of uveitis, prolonged initial X-ray spine. What should be next done? Okay, different options is what you had here. So NTCCP was one option you are saying. What was the other thing that was there? See, NTCCP is specific for rheumatoid arthritis. X-ray was insignificant. So what do you do next to look for sacroiliitis? X-ray will not show the early changes of sacroiliitis, but MRI would show that, right? So MRI you will see it positive. Is this clear with everyone? History of uveitis was also given in this question. That is what we are seeing here. Okay, got it. What will help in early diagnosis? MRI. Okay, MRI. All right. CT scan, MRI is going to be better. Then another, this image of barium swallow was given, right? The initial phase of barium swallow. And what is the arrow pointing to in this image? This is what was asked here. So this that you are seeing here, this is the pyriform sinus. This is the vallecula. So what do you see here is this is the vallecula and this is the pyriform sinus. So if this was the same image, then it is going to be pyriform sinus. Thyroid cartilage, if it was a plain X-ray with the calcified cartilage, then it is going to be thyroid cartilage. You will see the cartilage thyroid only if it is calcified. If it was this barium swallow image where you are seeing this barium lining the hypopharynx, then it is going to be pyriform sinus, right? So yes, this is going to be pyriform sinus. ये पायरिफॉर्म साइनस होगा, ये एक्सरे नहीं, ये बेरियम स्वॉलो है, ये बेरियम है जो लाइन कर रहा है हाइपोफैरिंक्स को. ओके, दैट्स पायरिफॉर्म साइनस. Next one, yes. What is this associated with typically? This is a DSA image, common carotid artery bifurcating into two, and you see a vascular mass here at the carotid bifurcation causing the splaying called as the Lyre sign, Lyre sign. This is going to be carotid body tumor, chemodectoma, right? So this is going to be carotid body tumor, chemodectoma. Is this clear with everyone? Pulsatile mass mention किया था. Okay. AV fistula. Okay, so one option was AV fistula is what you are mentioning here. This was AV fistula. See, I need to know exactly what. Was there a radiological image which was given? Yes or no? It was just a clinical question. Okay, one option was AV fistula. One option was strawberry hemangioma, which was given. Was this image given? And you are saying that it was a collapsible swelling that was also mentioned. अगर ये सेम इमेज था, द इमेज इज अ स्पॉटर, लायर साइन, कैरोटिड बॉडी ट्यूमर. अगर इमेज नहीं था, क्लिनिकल क्वेश्चन कुछ और था, फिर देन विल हैव टू थिंक ऑफ इट. सेम इमेज, देन इट इज लायर साइन, कैरोटिड बॉडी ट्यूमर. ओके, ऑल राइट, ठीक है. Going to next one, postmenopausal female was there with bleeding, and the MRI image was given, and you were asked what is it. So this is the uterus that you are seeing here, and there is this lobulated mass that you are seeing in the uterus, right? So this is going to be fibroid. Okay, this is going to be fibroid that you are seeing here. This is not the endometrium is here. It's not endometrial hyperplasia. This is an intramural fibroid if image like this was given. Adenomyosis was in the option, but what do you see in adenomyosis is the thickening of the junctional zone, and you would see the hyperintense, those endometrial glands. That is what you would see in the myometrium. Okay, if there was a well-defined mass like this, which had like a capsule sort of thing, and it was very well defined, then it is a fibroid. For adenomyosis, there will be this thickening of the junctional zone that you are going to see. 30-year-old था, 65-year-old नहीं था, ठीक है, postmenopausal नहीं था, 30-year-old female थी. It looked like adenomyosis. Was there any image? Was it an MRI image first of all? ओके अनदर थिंग, अगर सॉल्ट पेपर ऐसा डॉट डॉट हाइपर इंटेंस एरियाज दिख रही थी अगर मायोमेट्रियम में with thickening of the junctional zone, then it will be adenomyosis. Since I have not seen the image myself, so that would be difficult to comment on. This was not the image. ठीक है. If this was not the image and majority of you are saying कि salt pepper जैसा appearance दिख रहा था and it was a 30-year-old female, was there history of dysmenorrhea, menorrhagia which was mentioned? Then it might be adenomyosis. So we'll put a question mark on this. We will try to see what was it. Okay. Okay. Going to the next one, was this given? The congenital diaphragmatic hernia, where you are seeing the bowel loops on the left side, that was given. Yes, bowel loops. This is another favorite. Abdominal pain was given. Okay. No, adenomyosis is not symmetrical. You can have a focal adenomyosis as well. Okay. Heart was not displaced and 24 hours, right? Day 1 वाला बच्चा है और respiratory discomfort है. See, it could be congenital diaphragmatic hernia or congenital CPAM. Now you need to tell me the history, whether there was history of, let's say, something like recurrent infections wala history and the child was relatively old. It was not like day 1 vagera history. If it is congenital diaphragmatic hernia, generally it is immediately after birth, day 1 wala history with respiratory discomfort. So the clinical history is also going to be a clue there. If day 1 history is there and respiratory distress is there, right, you'll go for congenital diaphragmatic hernia. Okay. ठीक है, day 1 वाला है तो उसमें करेंगे. So any other questions in radiology, guys? Do you remember? It was CDH, but the image was different. Okay. Right. The image might be different, right? Okay, I've told you how to differentiate. Any other image do you remember? Some of you mentioned that there was image of MRI, image of meningioma as well. Dural tail sign wala ek image tha, was it there? Meningioma, MRI image with dural tail sign. We have learned that meninges is dural tail sign is seen in meningioma. Okay, another favorite, majority of the questions are repeats, right? Spondylolisthesis was there. Remember spondylolisthesis, many of you said that we could not see that squatty dog, beheaded squatty dog, collar wala appearance, anything like that. That is seen in the oblique view, not in the lateral view. In the lateral view, you will just see that the vertebral malalignment is there, and that is going to be spondylolisthesis. Okay, anything else? Meningioma, spondylolisthesis. Anything else? Okay. So if there are other questions, like Perthes or renal cell carcinoma wala image, all of those will be discussed in surgery as well. Right. Central CPM का investigation of choice अगर पूछा था तो MRI होगा. You will see that on MRI, the changes in the pons, white matter that you are going to see there. Okay, guys, so that was from my side for radiology. SCFE Perthes shall be discussed in orthopedics, that mass where the gallbladder renal, that shall be discussed in surgery as well, right? So you cannot demarcate the questions per se, because radiology
Good evening to all my dear students. So, how were the exams? What are the questions that I'm looking at? It was 100% strike rate from our side, isn't it? We have discussed everything in ophthalmology that has come in exams today. So, let's discuss these questions now. Okay. So, talking about question number 1. An elderly patient is presenting with white dandruff-like deposits on the anterior lens surface. I think this was absolutely very obvious. What is the answer? Dandruff-like deposits in the anterior lens surface, slit lampe. Was this the question? I hope this was the question. So, and the picture was given. So, if you look at the image, this is what you all have also learnt with me as hoarfrost sign. So, yes, the answer would be pseudo exfoliation syndrome, which you have learnt as the most common secondary glaucoma. And this is what is we have learnt as hoarfrost sign, right? So, this was the answer. Of course, irises look very differently. We're going to discuss in detail later on. And persistent pupillary membrane, again, the look is absolutely very different, which is actually the remnant of vasculosa lentis, isn't it? Right? So these are nothing but collagen bands on the cornea, on the iris, I mean to say on the pupil, sorry. Right? So this is about your persistent pupillary membrane. If these were the options, were these the options? Dandruff like nahi likha tha. Acha. Homogeneous mass. Oh no, this is something else. Okay, what did you say? Homogeneous? Glaucoma flecken was in the option. अच्छा, this was not in the option. Okay, ठीक है. तो अगर आप glaucoma flecken क्या होता है बताओ क्या पढ़ा था glaucoma flecken? Glaucoma flecken we had learnt is after the acute congestive glaucoma. So these are necrosis of the anterior capsule का epithelial cells है ना? The epithelial cells का necrosis and that looks like glaucoma fleckens. Right? So that was after acute congestive glaucoma, which happens, isn't it? So, what were the options? Let me have a quick look at the chart. What you're saying is, yeah, so pseudo exfoliation syndrome was in the option or not? First, tell me this. Pseudo exfoliation syndrome was in the option or not? It was in the option. Was this the image or not? Glaucoma flecken was in the option. I hope now you remember what was glaucoma flecken, isn't it? Yeah. So if the image was this, exactly the same image, Shrishti? Okay. So if the image is this one, it is very typical. We are looking at pseudo exfoliation syndrome. There shouldn't be any doubt about this. Okay. So there shouldn't be any doubt that this is, maybe the options were different, but here the answer that we should mark is pseudo exfoliation syndrome. If this was the image exact. Okay? The glaucoma flecken will look like fleckens, dots. It won't give this type of picture. So phacolytic Sandhya, phacolytic glaucoma, as you know, is becoming, again, it is an open angle glaucoma where you will get a Morganian cataract, then only you can call it as a phacolytic, isn't it? We have learned this. So, yes, okay. Anterior capsular opacification, okay. Another one is anterior capsular opacification. No, we will again better mark it as pseudo exfoliation syndrome. So even if dandruff like was not given, was there any other thing, any other feature that was mentioned in the question? Tick was same, then it is this only. Yeah. Yeah, glaucoma flecken is with angle closure, acute angle closure glaucoma. Okay? Yeah. So that has a very, very different picture. Glaucoma flecken. You have seen glaucoma flecken, no? Yeah. So, yeah. So I think looking at your chart and whatever you are saying, I think the best option would be this only. We come to the next question. Which condition is treated using, was this the question? This is the image? So we are talking about intact rings. We all know it's a PMMA ring inside the corneal stroma, which we are putting to flatten the curvature of the cornea. So what would be the answer? The indication would be keratoconus. ठीक है? So कब करते हैं? Mainly in mild or moderate keratoconus and especially in eccentric cones. This is very helpful modality of treatment. We have discussed the different treatments of keratoconus in your class. Isn't it? So here we will answer keratoconus. Ye clear hai? All of you, please answer me this. Done? Okay. Then we talk about the next question. A 15-year-old female is presenting with a painless, gradually, this is what the question I've got. So if this was the image, we all know we are talking about. It is gradually increasing, lateral to the lateral canthus, presenting for a long time, mass with non-tender, slowly progressive. So what are we talking about is here dermoid cyst, isn't it? So it is a dermoid cyst. So this is a typical feature of dermoid cyst. ठीक है? Yeah. पढ़ो मत रिकॉल बता रही हूँ और क्या आप लोग का चैट पढ़ रही हूँ और कुछ नहीं पढ़ रही. Okay. Then we talk about is next is a patient is presenting with guttati. So where do you get a guttati, all of you? So this is your corneal dystrophy. कौन सी? Fuchs endothelial dystrophy. You all know that endothelial cell is mainly there to which is to maintain the cornea in a dehydrated state, isn't it? So if the endothelial cell is damaged, you can get this type of guttati lesions, which are typical of Fuchs endothelial dystrophy. And in that case, because generally the dystrophy is bilateral, it's generally genetic. So the other eye, it is saying, is already having a bullous keratopathy. That means that the endothelial cells have really got damaged here. है ना? जब endothelial cells damage होगा, then only what will happen is hydration, and an extreme hydration will lead to bullous keratopathy where there are bully formation. So one eye you're getting a bullous keratopathy and the other eye you're getting guttati lesions have already been appearing. So this is what is Fuchs endothelial dystrophy. Was it? Keratoglobus was also in the option. Okay. Dystrophy was not an option. So please let me know what the options were. This is what I've got. Question is not correct. Okay. So intact ring was there. We are back to the intact ring. Yes. So the question is not regarding this. Okay. You all can share your questions. We will be talking in detail about it. So this is what I've received. Right. So, generally we have to do it in a very mild or moderate type of keratoconus or form frosted. What is that? When you're getting some findings in your pentacam, but there are no features on eye examination or slit lamp examination. Then only we go for intact rings. I think we should answer this as this option as the answer. Okay? Okay, we come to the next question. So this one is clear. The dystrophy question is absolutely clear. Right, all of you? Okay, trachoma was an option. Okay, but still, does it make sense? Guttati lesions. As soon as you are listening about guttati, you have to talk about endothelial cells. Hai na? So we have to talk about Fuchs endothelial dystrophy. Right? Okay. Okay, Ahmed, no, but we will be talking about, so the feature, this is, guttati is mainly a feature of this condition. है ना? Yeah. Okay, थोड़ा जल्दी. Binocular single vision consists of the following components. सबको पता है ये आया था. एक में house है, एक में ये. So this is what is simultaneous perception, macular perception, and this will be fusion. So we have learned 3 grades of binocular single vision. So this should be the answer, will be this one. This is your perception and this is your fusion. Simultaneous perception is this one and this is the fusion. Right? What about the next? Which of the following is true about orbital cellulitis? So when you say orbital cellulitis, it is present anterior? No, it is present posterior to the orbital septum. Not anterior, it is posterior. Treated effectively with tropical? No. We generally go for IV antibiotics, both gram positive and gram negative, and IV anti-inflammatories. So this is again a wrong option. Presenting with proptosis, but normal pupil and extraocular movements? No. Pupil extraocular movements are again restricted due to proptosis majority of the time. It is only when it involves the cavernous sinuses that you start getting your involvement of the 3, 4, and 5 nerves. All the nerves are coming into play, isn't it? So, but in this stage generally, but still of course the movement is restricted. And if optic nerve is involved, naturally you're going to get an abnormal pupillary reaction. ठीक है? तो answer If these were the options, the answer would be, we all know that sinusitis and of course infection around structures like dacryocystitis, any infection in the teeth can lead to orbital cellulitis, but most common is this ethmoid sinusitis. Ethmoid sinusitis, yeah, it's more common in children. All age likha tha. No IV antibiotics nahi likha tha na. So it is, you are saying topical antibiotics tha. So I've just told you ki IV, correct answer hoga IV. So this is a wrong option. That's what I'm trying to convey. Okay, so actually there are many times where you cannot, of course it is more commonly in children, but again, if these were the 4 options, you can't do much, you have to answer this only. Okay? So that is very important to understand. Or kai baar most common cause har jagah is not very easily answered also. So sinusitis is most common, and among that is ethmoid. But yes, if you ask me, it is a more common occurrence in children than in adults. Right? But if these 3 were the options, these 3 are straightforward wrong options. Therefore, you can easily mark the option 4 if these were there. Preseptal. So preseptal cellulitis is in front of the orbital septum, isn't it? So it will all depend what were the other options. You understand? What were the other options mentioned there? That is very important. Okay. Topical antibiotics नहीं लिखा था, broad spectrum लिखा था. अगर broad spectrum लिखा था, topical था कि नहीं था? Mode was it topical or did they mention you? Okay. I'm not able to get that. Just broad spectrum antibiotic, then even that could be a correct option. So we will have to find out what were the options. Okay. Yeah. Okay. So this was another question. So if a 15-year-old boy with long limbs means, and there is ectopia lentis, we are talking about Marfan syndrome. And if this is a case of Marfan syndrome, it's an overlapping question. So of course, we all know we will answer fibrillin 1. That was straightforward. Yeah. So if topical was given, then this becomes a wrong option. If topical was given, this becomes a wrong option. Right? Yeah. No. So topical, we won't be like answering topical as the correct option. If topical was given, then what is the only option left for our for us to answer is this one only. Ethmoid wala statement, right? Yeah. So I think these were the these were the questions. If you all remember any other, let me know. Yeah. So this is done. Any other confusion? Okay, okay, we can just if it was given in all ages, that is one thing. But what about ABC? Were these the options and statements mentioned? Do you want to change something in ABC in this question? Okay, yes. So thank you so much. So these are the questions. Yeah, I won't take much of your time. Thank you so much. Let's discuss the next subject. Thank you.
Students, good afternoon and welcome to this session. So how was your paper? How was dermatology? So as far as I could see, I would not say ki it was very, very easy, but I would like to say that whatever topics were asked in the exam, most of them we had covered. In fact, all of them we had covered. One thing that I really noticed was the amount of clinical correlation that they were doing. It was an integrated kind of question. So most of the dermatology questions that I would be discussing would have been discussed in microbiology or pathology or pharmacology. So this is what we always tell you nowadays. The paper pattern has changed and they are trying to integrate various subjects and give you more and more of clinical questions. But if you are thorough with your base, and so I'm sure that these questions would have been easy for you. So tell me if so this is a recall paper that we have, and as you all know, these may not be the exact options questions, though we have tried really our best to match the exact question and images, but I would need your help to improve us further. Okay, so let's start with the first question. A woman presented with pruritic rash on elbows, buttocks, with recent diagnosis of gluten sensitive enteropathy. On immunofluorescence, you are seeing IgA deposition. What is the most likely diagnosis? So it was like cake in a platter. Pruritic rash on elbows and buttocks, gluten sensitive enteropathy given, immunofluorescence image given showing papillary tip microfluorescence. And so, what is the diagnosis? We know the diagnosis is dermatitis herpetiformis. Don't even need to look at the other options. So, was it the same question? If there was any confusion here, you can tell me. So, students, just relax. Don't start marking yourself. I may not be exactly right. So, this is more of a chill out session. Tell me if you had any different question or anything, and we can just discuss it in a very light manner. Perfect. So most of this was correct, so I'll not waste more time on it. Very clear-cut question. Now, this is something which was a little confusing, but maybe let's discuss it. A 20-year-old patient presents with a non-progressive hypopigmented lesion on the trunk. On Wood's lamp, there was a white accentuation. Dioscopy is negative. So what is the likely diagnosis? So first, there is two confusion here. So if the dioscopy is negative, we know we can rule out nevus anemicus, because we know that when you do a dioscopy with nevus anemicus, its borders merges and it kind of disappears. So this is out. Also, we can rule out indeterminate leprosy because it does not show any Wood's lamp fluorescence. Now, the confusion here arises between vitiligo and nevus depigmentosus, because segmental vitiligo can be non-progressive. Both of them can show Wood's lamp accentuation. So, perfect. Some of you are saying it was present since birth. It was congenital. Okay. And anything else? Lesion was big. Lesion may be big. That's okay. Give me some hints on if we can point out to a particular thing. Condition was since childhood. So most of you are saying that it was not a 20-year-old, but a congenital origin or something which was there since childhood. So I think dioscopy is not mentioned. Okay, most of you told me that dioscopy was present. Okay. Anything else? Fine. So if it was present since birth, non-progressive, and they had specifically written hypopigmented lesion, then we would go with nevus depigmentosus. Now I'll tell you what's the confusion here. Vitiligo is usually depigmented. Nevus depigmentosus is usually hypopigmented. Nevus depigmentosus is usually congenital or present since birth. And it also shows a positive Wood's lamp examination, but the accentuation is dull white. Whereas in vitiligo, it is stark white or chalky white. Both of them will be negative on dioscopy. So one lesion since childhood, hypopigmented lesion, a very faint white accentuation on Wood's lamp, dioscopy negative, I think then we would mark nevus depigmentosus as answer, because again, they're trying to give you a dioscopy positive and negative because they want you to differentiate between nevus depigmentosis and anemicus, because anemicus can also be present since birth. It is also non-progressive, and in that also, so here based on these options, and thank you so much for your input. And someone is also telling me that dull white accentuation was given. So if dull white was there, hypopigmented was there, since birth was there, then this leaves no confusion in this question, and we will mark nevus depigmentosis as the answer. Thank you so much, and this really helps us. So I hope this question is clear. Dioscopy was inconclusive. Okay, don't get confused. Even if dull white accentuation was not given, if they'd given you that it was present since birth, if they had mentioned hypopigmented, because none of you are telling me that it was depigmented. Vitiligo, I told you, is depigmented. Nevus depigmentosis is hypopigmented. So then also you can safely mark nevus depigmentosis, right? So that clarifies this question, and we can move on to the next one. So now this was a question which was sitting right on your face, but I think the options were a little difficult. So a patient presents with indurated plaque on the cheek with central atrophy. Chest X-ray shows apical calcification. Which of the following test is most appropriate to confirm the diagnosis? Now, if you ask me, the best answer should have been histopathological examination, but what I got to know, you did not have that option. So there was no option of biopsy. Am I right? Okay, so yes, so I think I'm correct that there was no option of biopsy of histopath. Now we have to look at the option and tell which will be the best test to confirm the diagnosis. Now for lupus vulgaris, though histopathology is the best test, sometimes if you want to detect the mycobacterium, PCR is the next go-to test. So after histopathology, the best test to confirm the diagnosis in a patient of lupus vulgaris would be PCR. See, slit skin smear will be negative because it's a paucibacillate. Slit skin smear is done with leprosy. Monto's test is a positive, but that's an ancillary investigation. It will tell you that patient has tuberculosis. It cannot tell you that patient has cutaneous tuberculosis. And probe test is not done these days. So the best option here would be PCR. If histopathology was given, that would have been the option. That's okay. Don't worry. Galat ho gaya. Kuch farak nahi padta. You must have done your rest of the questions right. So thank you so much. So you're right. No option of biopsy was given. So if biopsy was not given, the next best test would be PCR, okay, because it helps to detect the mycobacteria. In fact, sometimes when the histopathology is inconclusive, then we go for PCR for diagnosing of cutaneous tuberculosis, right? Okay. Now, again, another question sitting right on your face. We've done this a lot of time. Patient presents with irregular swelling over the foot with multiple discharging sinuses and black granules. So you know that this is a mycetoma. In the question, they've mentioned black granules and they've asked you what is the KOH amount going to show. Now we know mycetoma is caused by either actinomycetoma or eumycetoma. And we have studied that the granules are black in cases of eumycetoma or the mycetoma which is caused by fungal organisms. And in this case, if you do a KOH, you see septate branching hyphae. So again, a very straightforward question. Okay. Good. Great. So black granules was given. So if black granules are given, you see septate hyphae. So this was again a very clear-cut question. So look at it. In each of the questions, they're giving you images. So whenever we study dermatology, I keep focusing that you should look at the images because nowadays it's all about image-based questions. And this is how they're integrating different subjects together. Okay. So great. So I think most of you are giving me the similar options here. So let's move on to the next question. And I want to see what all did you answer for this one. Most common cause of SCC at the base of the tongue is. Now this was a little tricky, but I'm sure you answered it right. So let me see. Okay, pseudo. Okay, so there was some confusion probably in this question. Pseudo hyphae was there. Okay, fine. Okay, so as expected, most of you got confused between EBV and HPV. I was hoping examiner had not given you both the options because you're all right. SCC at the base of the tongue, or if we talk about oropharyngeal SCC, it is associated with viral infections, and EBV and HPV have both been implicated. Now, out of these two, HPV is the more commonly implicated virus. So I think this was a little tricky question, and I would not blame you if you could not answer it, right? Now, the best option would be if they had given you something like a tobacco or some tobacco chewer or something, because that would have been one of the very easy ones. But they wanted to ask you which virus is commonly associated with SCC of the oropharynx. Both HPV and EBV are associated, but HPV is much more commonly associated than EBV. So here my answer would be HPV, right? So I think this was a little, so some of you are telling me there was lateral border of the tongue which was mentioned. So, but I don't think so they had given you any image or suggestion of oral hairy leukoplakia. In that case, you would have said EBV, but the question mentions squamous cell carcinoma, right? So also if HIV was in the option, that could have also been the correct thing. Okay. So some of you are telling me that lateral border of the tongue was given. Was there an image which was given with this question? So if there was oral hairy leukoplakia, which is usually seen on the lateral border of the tongue, and which is a question which you've got a lot of times, then probably EBV would have been the answer. But this is what I got as the question, and no image was there, right base of the tongue. So we'll stick to this one. And so you are right. If there was lateral border, you could have marked EBV, and if there was oral hairy leukoplakia. But since the image was not given and SCC was mentioned, I think we'd go with HPV. Coming to the next question, again, a very straightforward question. Patient presents with history of freckles, photosensitivity, basal cell carcinomas aggravated by sun exposure. So they are talking about xeroderma pigmentosa here. Xeroderma pigmentosa, which is a genodermatosis, and this is a DNA repair defect which is caused. And what is the DNA repair defect? It is quite clear cut. There was no confusion. Nucleotide excision repair is the defect that you see in xeroderma pigmentosa. Okay, woman had some lesion in the oral mucosa. Okay, we'll come to that drug one. That question we have not discussed yet. Okay, so most of you are telling me that in the previous question it was the base of the tongue, so we'll stick to that. And cervical lymphadenopathy. So with lupus vulgaris, cervical lymphadenopathy was there. So see, if the question was asking you how to diagnose lupus vulgaris or cutaneous TB, then the best answer would be PCR, right? So I hope there is no confusion with this question. This is a clear-cut clinical case of xeroderma pigmentosa, and we know that it is caused by a defect in nucleotide excision repair. Okay? Okay, I think someone mentioned this question. A patient presents with persistent oral mucosal lesions for 6 months and a history of GERD, gastroesophageal reflux. Symptoms worsen on eating hot spicy food. Which drug is most likely responsible? Now, again, there may be some ifs and buts about this question, but if it was the kind of question, 6-month history, persistent oral lesions, symptoms worsening on eating hot spicy food, then we are probably talking about oral lichen planus. And if the question was something similar and they wanted to talk about oral lichen planus, the drug which is most likely responsible is beta blocker. Right? Now here again in this question, both beta blockers and lithium are responsible for drug-induced lichenoid eruption or drug-induced lichen planus. But if I have to answer which is the most likely responsible or most common agent, then it would be beta blocker. But let me see if there was something else. So this was a different question on metoclopramide and pantoprazole. So even if pantoprazole is in the option, it does not change anything. No clinical history, correct question. GERD not mentioned. Even if GERD is not mentioned, it does not change anything. If no image was given and they had in the history given you worsens on eating hot spicy food, then again you know it is oral lichen planus. So that is okay. No history of GERD. So I think GERD was not there. So perfect. Then probably it was the similar. Maybe they've not given you the image, but the question said it worsens on eating hot spicy food, and we know beta blockers are the drugs which are most likely responsible for drug-induced lichen planus. This is the last question I have from dermatology. A young adult presents with facial pain, painful vesicular lesions in the mouth. Zank smear reveals multinucleate giant cells. What is the most likely causative organism? This was a question which was there in FMGE also. So MNGs with vesicular lesions, there is no doubt here we are talking about herpes simplex virus. Herpes can cause vesicular lesions, pain, and on Zank smear you see multinucleate giant cells, right? So lithium in the previous question could have been right, but since beta blockers were also given, we have to mark that. Right. So HSV, this was perfect. So HSV, this was a very, very straightforward question. So if I analyze the paper, I think there were just 1 or 2 questions which are a little difficult, especially that EBV HPV one, which was difficult. Rest of them were quite straightforward, and I'm sure you all did very well. So thank you so much. If there is any question that I have missed, quickly put it in the chat box so that we can add up here. Okay. So thank you so much, and all the very, very best for your results.
Hello, dear friends. This is Dr. Jambukeshwaran, PrepLadder's orthopedic faculty for you. So just we are going on a very, very quick question analysis session. Am I audible? Yeah, crazy vlog. Hi, sir. Okay, Dinesh Reddy. Hello, are you able to hear me? Just give me a thumbs up sign so that we'll go. Good evening, sir. Okay, Mohammed Tafali. Yes. Okay. Good. Straight away, we'll move on to the first question, dear guys. According to me, some 9-10 questions have appeared in orthopedics, and very good news is all are there already. What we discussed already in our videos and in our live YouTube sessions. Okay, we'll move on to the first question. The first question: a 56-year-old female presents with chronic low back pain. A lateral lumbar X-ray spine is provided. Based on the radiological finding, which of the following is the most likely diagnosis? They are given. When I see this X-ray, you see, this is your sacrum, and this is your lumbar spine. Lumbar spine is projected outside the sacrum. You see here. So around say 25% slip is there. 25%, roughly 25% slip is there, anterior slip is there, and this condition is called spondylolisthesis. This condition is called spondylolisthesis. Okay, so spondylolisthesis should be the correct answer. Spondylitis is wrong. It is not osteosarcoma, vertebral fractures. Okay, so many. Okay, Inky Pinky, Nigariga Jaiswal. Okay, yes, sir. Almost 10 questions. Nigariga Jaiswal is giving 10 questions. And all of you had answered it right. Okay. So Anwar Chauhan, everybody have answered it right. Excellent. It is spondylolisthesis. Shall we move on to the next question? Yes, you see here. Right. You see, yes. Okay. Crush vertebra was the choice. Even they had given compression fracture. That's what? No, I had said vertebral fractures. It can be a crush vertebra, it can be compression fracture, whatever it is. Okay. So it's not the answer. The right answer is spondylolisthesis. We'll move on to the next question. Yes. A 40-year-old man presented with discomfort in one of his joints. Synovial fluid analysis was done, and the synovial fluid revealed a rhomboid shaped crystal which is positive birefringent. Everyone, we know the answer. The answer is pseudo gout. Because in pseudo gout you will get rhomboid shaped crystals. In gout we will have needle shaped crystals. The next difference, pseudo gout is positive birefringent and gout is negative birefringent. Okay, so the right answer is pseudo gout. Okay, this is the right answer. Okay, so straightforward. I think it's a straightforward cake for you. Okay, so I feel very happy. Exactly. Okay, so excellent. Okay, so good. We'll move on to the third question. Dear guys, a 20-year-old man presented with chronic back pain that is worse in the morning and improves with physical activity. Okay, so it is worse in the morning. The patient has low back pain. Okay, and it worse in the morning, improves with exercise. Second important thing in the history, yes, anterior uveitis. Anterior uveitis, low back pain, all these things are HLA-B27 related disorders. Okay, so our clinical suspicion is ankylosing spondylitis. Okay, it is ankylosing spondylitis. So, ankylosing spondylitis, what is the next appropriate investigation we look for? I want to rule out sacroiliitis. In the 4 options which I got from my students, the choice is MRI of the sacroiliac joint. This should be the most appropriate answer. Okay, so Nikki, okay, youngster, Vinay Kumar, okay, Ali Khan, Rakesh Agarwal, Dr. B, everyone has answered it correctly. So I feel so happy for you guys and girls. Okay, so this is MRI of the sacroiliac joint and the diagnosis should be ankylosing spondylitis. Okay, yes. So doctor has given instead of MRI, it is CT sacroiliac joint was the options are. So if it is CT, so whatever it is, sacroiliac joint, I want to rule out sacroiliitis. So that should be the right option. Okay, good. The X-ray was normal, then what will be the investigation confirm? See, X-ray sometimes won't give you. X-ray sometimes won't give you. That's why we are going for higher investigation like MRI of the sacroiliac joint and CT scan. Okay. Yes. Yes. Okay. So CT and the MRI both in the option. MRI is the best investigation then. MRI is the best investigation. That will even the very anti-CCP, smile doctor, anti-CCP. What's the anti-CCP? Anti-CCP is for rheumatoid arthritis, guys. Anti-CCP, he says that the smile doctor is giving one choice, anti-CCP it is given, sir. See, please stop chatting and concentrate. I will tell you a concept. Patient's complaint is low backache, chronic back pain. Anti-CCP is for rheumatoid arthritis. Rheumatoid arthritis will not cause low backache. You just watch our YouTube session. I said that rheumatoid arthritis can affect the cervical spine, not lumbar, low backache. When somebody given low backache in a guy like this improves with activity, it should be ankylosing spondylitis. So MRI sacroiliac joint is the best answer. We'll move on to the third one. A man, yes. Okay, so a man experiences shoulder pain during extension exercise at the gym. Examination reveals a tear of the long head of triceps. So this is more an anatomy question as well as an ortho question. From which of the following anatomical site does the long head of triceps originates? It should be from the infraglenoid tubercle. It's from the infraglenoid tubercle. Okay, yes, infraglenoid tubercle. Good. Then comes a 60-year-old patient presents with pain in multiple bone, a history of increased hat size. So exactly this is what in our videos I had mentioned this. Foreign people will use hat. Okay, foreign people will use hat and right. So what they will the frequent change of hat size. When somebody complains like this, one has to suspect Paget's disease. Okay, so pain in multiple bones and a history of increased hat size. On examination, some bone feels warm to touch. In Paget's disease, increased warmth will be there because the micro change that is happening in Paget's disease is micro arteriovenous fistula formation. Okay, so hyperdynamic circulation will be there and patient, it will be warm. And the most reliable one investigation, biochemical investigation is alkaline phosphatase. So alkaline phosphatase is elevated. Which is the following diagnosis? It should be Paget's disease of the bone, otherwise called osteitis deformans. Otherwise called osteitis deformans. Okay. Yes, Paget's disease. Right, good. So many of you have answered. Okay, Abhishek, Priyanshi Verma. Okay, yeah, many of you, okay, have answered it correctly. Increasing hat size, Washima Sujit. Everyone has answered it correctly. Excellent, man. We'll move on to the next question. A 25-year-old man presents to the emergency department following a motorbike accident and is found to have a closed midshaft fracture of the tibia. Okay, closed fracture. 6 hours later, he developed severe pain that is disproportionate to injury. Whenever a word severe pain disproportionate to injury, we are suspecting compartment syndrome. Okay, compartment syndrome. Okay. Compartment syndrome, and the pain gets worsened with passive dorsiflexion of the foot. So it's called stretch pain. This is called stretch pain. And the patient is not, the pain is not relieved with your routine, your painkillers, not relieved with your painkillers. And what happens? No, dorsalis pedis on the tibial pulse or the present, dorsalis pedis pulse is present, but there is no sensation over the first dorsal web space. That is, he is going for severe compartment. You all know stretch pain, pallor, okay, paresthesia. This patient has developed numbness, that is paresthesia. So the patient has developed a severe compartment syndrome. Only thing, pulse is still present. But the next, what is the next best treatment, next best management? No, you have to go for emergency fasciotomy. When you do emergency, this is a limb saving procedure, dear guys. This is a limb saving procedure. Best thing, okay, elevate the limb and observe. This stage, patient had developed numbness. Pain is not getting relieved with your routine painkillers. Better go for emergency fasciotomy, okay? So many of you, yes, faster. Many of you have answered it well. B, good. Okay, we'll move on to the next question. A male patient after sustaining road traffic accident with closed midshaft femur of the femur. Some students are given that as midshaft of the femur. Some are answering midshaft of the tibia. I don't know what is given in the history. Whatever it is, midshaft of the femur or tibia doesn't matter. It is a long bone. Okay. 2 days later, presents with breathlessness, tachycardia, petechial rash. Where is the petechial rash? Especially in the chest and the lower conjunctiva. Several times I told this is a pathognomonic sign. Okay. Pathognomonic sign. And this comes under what is called a GERD's triad. Okay, GERD's triad. The diagnosis is fat embolism syndrome. The diagnosis is fat embolism syndrome. Okay. Yes. Excellent. We'll move on to the next MCQ. A 7-year-old child presents with a painless limp. That is the history. Okay. And the options given are DDH, Perthi, Sufi, TB. 4 options they had given. And they had given an X-ray image somewhat similar to this. So, 7-year-old child, whenever somebody says painless limb, this is developmental dysplasia hip. This is developmental dysplasia hip. Okay. So this is painless limb means DDH. Then comes a male sustained eversion foot injury. Which ligament is injured? Eversion injury. The diagnosis is deltoid. Inversion, it should be anterior talofibula. So this should be the right answer. And the knee replacement, the last question, knee replacement was done 7 days before. Patient presented with dyspnea, tachycardia. What is the most diagnostic test? After 7 days, patient after total knee replacement going for tachycardia and dyspnea. Okay, what is the next most reliable next investigation? Patient had developed pulmonary embolism, so it should be CT pulmonary angiography. That completes all the ortho questions. Thank you and all the best, dear guys. Thank you so much.
Hi, everybody. So I'm so glad to be here, actually. I know the exam has just got over and we're just going to have a quick look at PSM. I heard there were a couple of questions that you had heard for the first time, but there were others as well which you might have been able to answer. So I'm just going to discuss with you the questions. Can you all hear me, everybody? Okay, I think everyone can hear me. All right. So PSM was difficult. I got to know a little bit. I did get to hear from all of you. चलो, let's not worry too much about it. एक बार देखते हैं what the question was. Now again, guys, this is purely a recall. So don't take it too much to your heart, guys. We're just trying to see were there any repeated topics, were there not, how exactly we need to, plan our study ahead. Okay, so are you with me, everybody? Not taking too much of your time, guys. What did you write for this? Now, did you find it very difficult over here? Surveillance. Surveillance is a topic that we discuss most of the times in classes. है ना? Surveillance हमने concept of health में discuss किया है, planning में discuss किया है. Now, it was clearly written that a diabetic patient with COVID-19 had died in the hospital. ठीक है? Which type of surveillance does this death report fall under? What did you write, everybody, for this one? Just a second. Yeah, what did you write for this one, guys? What did you write with this one? Now, a diabetic patient with COVID-19 has died in the hospital. What type of surveillance is this? Why would I want to do a sentinel surveillance with this? Sentinel surveillance होता है missing cases के लिए. Active surveillance होता है when you go home looking for, house to house looking for cases. This was a simple hospital-based reporting. And I would not say that it was very difficult for all of us. Hospital-based reporting, the most feasible form of surveillance it is, which is passive. Okay, patient came himself with diabetes to the hospital. तो कोई बात नहीं ना, हमने तो जाके उसको ढूंढा नहीं, right? He came to the hospital. So it's a hospital-based reporting. So this was a quick question on passive surveillance. Active is going house to house looking from cases. Sentinel and syndromic surveillance is particularly for STD. Okay? चलो, let's look at the other question. Guys, बहुत दिल से नहीं लेना है, ठीक है? अब चलो इस क्वेश्चन को किसने किया है? De facto method of census data collection. Now see, I bought this picture only because I didn't bring pictures for other questions because वो हम लोग देखते रहते हैं. अब मुझे बहुत सारे बच्चों का मैसेज आया कि मैम de facto तो कहीं पढ़ा ही नहीं है. Guys, de facto we have clearly read in our demography chapter, sources of health information. But yes, you will get it in the main videos. So I'm going to stress one fact very clearly, guys. For NEET PG, for INI-CET, we have to go through the main videos. We should, guys, if we have time. देखो इसमें clearly हमने लिखा है de facto method क्या होता है? When a person, where the person is at the time of data collection. Okay, so usual where it is location at the time of enumeration, not the usual place of residence. Usual place या permanent residence क्या होता है? Permanent residence होता है de jure method. Okay, so पहले census में before 1930 we used to rely on the de facto method, which is that wherever you will be present at the time of survey, I will take your information. But now we are relying back to the de jure method, which is your permanent residence. ठीक है? Chalo, going to the next one. Now, don't tell me you were not able to do this. It will really break my heart. Chahe online videos ho, LRRs, one-liners, everywhere we've discussed Nalgonda technique. What was the mnemonic of Nalgonda technique, guys? Lab, lime, okay, alum and bleaching powder. We knew that fluorosis is going to turn up. Excess of fluorine in water hatane ke liye technique tha developed by NEET Institute. So this was a good 1-mark question for all of you. I'm sure you got it correct. Not taking too much of your time. Moving ahead, this was the mnemonic NEET Institute developed. What are the correct sequence of steps in RCT? EPID, we have always stressed that we're going to talk about steps of cohort, steps of case control, steps of RCT. तो सबसे पहले क्या करेंगे? सबसे पहले actually protocol draw होता है, ठीक है? Randomization, manipulation, follow-up, assessment. Follow-up was the third one. Assessment obviously done by number needed to treat, number needed to harm, or absolute risk reduction and relative risk reduction. So what was this question, everybody? Relative risk reduction, randomization, manipulation, follow-up, assessment. Was this there in the exam? ठीक है, और हम लोग हमेशा बोलते गाइस एपिड के लेक्चर्स खोल के देखो. वी हैव डिस्कस दिस इज द स्टेप्स ऑफ आरसीटी. यू विल फाइंड इट एग्जैक्टली इन योर आरआर ऑल्सो. फॉर दिस आई कुड से एपिड के लिए यू कैन रिलाई ऑन आरआर्स. ओके, चलो लेट्स गो टू द नेक्स्ट वन. यू नो व्हाट दे हैव डन इन दिस क्वेश्चन. देखो, open the notes. Andhra Pradesh we have written, ठीक है? It's a classic
case of, it's a classic presentation of, guys, genu valgum. Okay, and if you open your textbook of Park also, there's a line written, patient with osteoporosis. I've brought that exact line, osteoporosis with valgum from Andhra Pradesh and Tamil Nadu. इनको क्या हो गया है? They are suffering from crippling fluorosis, guys. Okay, they are suffering from crippling fluorosis. So what is it that is not to be done? You can change the running water for drinking, provision of running surface water. All right, change the water source. We are not going to add excess of fluorine. Okay, we can do an Algonda technique, but we're not going to add excess of fluorine to water. Okay, same question, same option. Were you able to understand this? Crippling fluorosis, the buzzword was Andhra Pradesh there, bending of the lower limbs and signs of osteoporosis. ठीक है, चलो now इसको ये नहीं बोलना है कि हम लोग नहीं कर पाए. अब ये क्वेश्चन was pure maths, I would say. ठीक है, it was pure maths, guys. Were you able to do this question? I know I'm taking a little bit of your time, but were you able to do this question, guys? इसमें एक चीज याद रखनी थी, बाकी pure maths था. That I have always taught you, one urban PHC covers 50,000 population. पेन और पेपर देते नहीं है, I know नहीं देता है. ठीक है, बट अभी क्या कर सकते हैं, करना तो था. सो कविन, आई थिंक केविन हैज गॉट इट करेक्ट, अंकित हैज गॉट इट करेक्ट. गाइज, ये सबको याद था. वन अर्बन PHC 50,000 population. Now you can see that there is a population of some 70 lakh, 30% residing in urban slums. So you just had to make out that, okay, population in urban slums. Population in urban slums क्या है? 30% of 70 some this value. Okay, and this comes out to be 21,000,000. Okay, now we know that 50,000 population के लिए one urban PHC. So all we had to do it for number of PHCs, हमें क्या करना है? We had to divide this particular value by 50,000. Now if you divided, the closest you could get was to 42. I know you don't get pen and paper, but this was the way it had to be done. बस ये याद रखना था, one urban PHC 50,000 population. A golden question, ठीक है? Were you able to mark this? A study is conducted to compare mean hemoglobin, exact copy from FMG question. Exact copy from FMG exam. Now mean hemoglobin tha, so it is quantitative variable. So we will be talking about a parametric test. 2 independent group लिखा हुआ था, unpaired t-test. कोई टेंशन नहीं है इस क्वेश्चन में, ठीक है? चलो आगे बढ़ते हैं. What was the next question? Now again, there was a lot of confusion in this question, so I've brought you the exact replica of where we've taught it. Now you can see HIV started on ART, 34 weeks. ठीक है? Look at this. Her viral load is 1200 copies per ml. What is the most appropriate? Now this makes the baby a high risk infant. हमने पढ़ा हुआ है इस चीज को कि अगर more than 1000 RNA copies है and after 32 weeks the baby becomes a high risk infant. So since the baby is a high risk infant, you have to add, guys, syrup navy plus syrup zido. Now the question was that is the baby, okay, and started on ART. So what do you have to do? Syrup navy and zido. अगर exclusive breastfeeding है तो 6 weeks नहीं होता है. Exclusive breastfeeding hai, then it is 12 weeks, as we have written over here also. Exclusive breastfeeding, in that case it is given for 12 weeks. Okay, so you just had to measure up. 6 weeks के option में नहीं था, कोई बात नहीं. देखो यहाँ पे यही देखना था, viral load is more than 1000, pregnancy is beyond 32 weeks, so we have to add syrup navy and zido, and if the baby is on exclusive breastfeeding, it has to be given till 12 weeks. Moving ahead, guys. Good question, a beautiful question. I thought you have got 1 mark in this. I'm not going to take too much of time यहाँ पे, फटाफट से आंसर दे दो. Which mosquito larva has a siphon and rest has actually no siphon? Okay, the question is no siphon and rests parallel. So कोई siphon tube नहीं है. It was not an image based question, but we know it is anopheles. Siphon अगर होता है, siphon is present in culex, and that's a longer siphon, and siphon in ADs भी होता है, but that's a shorter siphon. ठीक है? Moving to the next one. Now I don't know I have got the correct question or not for this one, बट देखो अब इसमें एक ही हिंट मुझे क्वेश्चन में मिल रहा है, ठीक है, 3 year old चाइल्ड गोइंग ऑफ लेग्स, ठीक है, विटामिन डी डेफिशिएंसी है, दैट मीन्स शी इज सफरिंग फ्रॉम सम न्यूट्रिशनल डेफिशिएंसी. नाउ यू हैव टू टेल मी which government scheme addresses this under 6-year-old. Now if the word was 0 to 6 years, you know there is a program ICDS. Okay, you know there is a program ICDS. Guys, इससे कंफ्यूज मत हो. नेशनल न्यूट्रिशनल डेफिशिएंसी प्रोग्राम includes ICDS, includes midday meal, includes anemia mukt Bharat, includes national iodine control disorder control program. So it includes a lot of program. That's a very big word. Okay, nutritional deficiency disorder control program. यहाँ पे हमारा हिंट एक ही था, अंडर 6 years अगर ये था then I would go for ICDS, क्योंकि अनीमिया मुक्त भारत में विटामिन डी के बारे में बात ही नहीं हो रहा है. When we talk about midday meal, preschool children have been included nowadays, but then we have to go to the schools and getting it. So I'm going to go for your scheme was written instead of services. That's okay. ICDS is Integrated Child Development Services Scheme. Okay, let's go to the next one. Under the weekly iron folic acid supplementation, what is the composition of IFA given to 10 to 19 year? Again, a very good PYT, guys. Anemia Mukt Bharat, we had to get it. Adolescents को कितना देते हैं? 60 milligram elemental iron, 500 microgram folic acid. Everybody got this question correct, right? Iron की नीली गोली, blue tabs. So we are relying on what? Blue tabs. Moving to the next question. What did you mark for this? Again, some students messaged me that ma'am this question was out of the box, ये हमने पढ़ा नहीं. तो डाइटरी कोलेस्ट्रॉल हमेशा पढ़ते हैं 220-200 मिलीग्राम के लेवल पे, ठीक है. बट द क्वेश्चन ऑल्सो वी हैव स्टडीड गाइज. इफ यू लुक एट दिस वन, रिडक्शन ऑफ डाइटरी कोलेस्ट्रॉल below 100 grams per 1000 kilocalorie per day. This was your answer. All right. Everybody, so I thought you got this question correct. We had discussed this, so that is what we were talking about. Okay, which of the following is used to measure the degree of objective and target achievement and assess the quality of results obtained in health program? Now, was it the same type of question, everybody? I'm not very sure. Agar yahi question tha, so it's talking about evaluation, monitoring and evaluation both. It was a question from planning cycle. All right. So over here, which of the following is used to? Planning is a very big word, guys. इसमें हम लोग क्या मार्क करेंगे? Evaluation. क्योंकि इसमें क्या लिखा हुआ है? Quality of results obtained. या अगर क्वेश्चन था impact of the result, we are trying to find out evaluation. Clear? Moving to the next one. क्या किया इस क्वेश्चन में गाइज? देयर वाज अ वेरी बिग हिंट. इफ दिस वाज द क्वेश्चन, अगेन आई कीप रिपीटिंग कि अगर यही क्वेश्चन था, ठीक है, इंटरवेंशन लिख दिया. So you can't have cross-sectional, you can't have case control. Remember rapid classes. Quasi experimental क्या होता है? Natural experiments. We make use of what, guys? We make use of natural phenomena like disaster, migration, ठीक है? Atomic bombing, religious groups. Here we simply have a disease for which we have brought one community intervention. एक group को मिलेगा, एक group को नहीं मिलेगा. So what is it? It's just a RCT. Because this was your word, you had to rule out. I'm sure you ruled out cross-sectional case control. ठीक है? But it's not quasi-experimental. Remember the classes. That is natural experiment. ठीक है? Going to the next one. Again, a good question, PYT, if this was a question. Time interval between acquiring an infection and reaching the period of maximum infectivity discussed in LRRs, discussed everywhere, the videos. सबने mark सही किया? Generation time. Were you able to get this question correct, guys? ठीक है? Okay, generation time. All right. Which of the following vaccines will you use in the clinic? So, again, PYT, vaccine while monitored. Did you have this question? So you all know if the inner square is lighter than the outer circle, use karo. Inner square starts to change color but is still lighter, use karo. So good they gave this question. If this was, you will use A and B. तो PSM बहुत difficult तो नहीं कह सकते. It was a moderate paper. Okay, we did have questions that were repeated. Now we have discussed lead time bias, guys. We always take up lead time bias in the main videos, and I have written also the situation जहाँ पे exactly same thing is mentioned, that we are introducing breast cancer screening. It shows increased 5-year survival rate, but autopsy revealed no change in mortality. So it's giving you a false sense of survival. तो इसको survival bias नहीं mark करना है. This is what? This is a case of lead time bias. Okay, same question which has been discussed, but I would actually say that we've discussed this in our main videos. Going to the next one. A newly diagnosed HIV positive patient with whatever CD count test positive for active TB. Again, a direct PYT which has been picked up from FMG exams, guys. FMG exam में भी question आया था HIV और TB दोनों है. What are you going to do first? If this was the question. All right, so what do we do, guys? First, what do we do, guys? Start ATT first and then initiate ART later after 2 weeks to prevent what? Immune reconstitution syndrome. Immune reconstitution syndrome. Now, if you have any other question, now I would just take 1 more minute of your time, guys. PSM, I would not say honestly कि बहुत difficult था. NEET PG का paper है. You will expect 3 to 4 questions, 2 to 3 questions जो out of the box आ सकते हैं. You might feel कि मैम de facto method. De facto method we did discuss in our main videos, guys. Lead bias we did discuss in our main videos. Cholesterol ka exact values we did discuss in the main videos. So what I'm trying to stress upon, guys, for your NEET PG preparation, please get back to basics. Do go through the main videos. They're going to help you a lot, everybody. Okay, so relax karo. ठीक है, कटोरी question. Okay, you can send me that. Okay, rifampicin resistant. Let me tell you the answer to that as also. Sorry, I missed the rifampicin resistant. We have discussed rifampicin resistance is managed as MDR, guys. It is managed as MDR. MDR का regimen अब क्या है? BPAL-M regimen. So if BPAL-M regimen was in the option, you can go for that one. The thing is that rifampicin resistant is managed same as MDR case. Okay. Chalo, so I think whatever is left out, guys, please send me the question. We'll put it out on the app. Not taking too much of your time. Thank you so much. God bless each one of you. And don't take it too much to your heart, guys. I'm sure each one of you has done well. Thank you so much for attending the session. Keep attending the session, guys. We'll come up with more and more recalls. ठीक है, गार्डन थेरेपी 200 में कैलोरीज अगर मेंशन है ना 1000 कैलोरीज तो 100 से कम होता है. ठीक है, बाय बाय, थैंक यू सो मच.
Sir, you are live.
Hello, student. Good evening to all of you. I believe I am audible and visible at your end. So we are going to discuss the physiology questions and their probable answer. Okay. So just give me a thumbs up whether I'm audible and visible clearly or not. We'll start the session directly. Okay, perfect, perfect. Yes, yes, fine. So, thank you so much. So we are going to start the discussion directly. And in physiology, altogether, I have got around 5-6 questions I have got, right? Okay. And some other questions may be there because some students were saying there was a question related to the cardiac graph and all, action potential graph and all. But I didn't get that question exactly, so I have not kept it here. But in the course of discussion, if you could remember any extra questions, you are welcome to put it here. So with that, we can update our questions, right? Okay, very good, very good. Good luck to all of you. I hope all of you are doing going to do great. And in physiology, if you look at the questions, most of the questions are easier questions, right? One questions was a little bit tricky, but most of the questions are easier questions, and mainly the questions has been asked from the main lecture. Okay, so look at the questions. What are the questions that is asked from the physiology? Okay, so first of all, this type of question was given. I believe this was not the exact graph. There was a simplified graph in which the multiple point will be given. Like suppose this is A point, suppose this is B point, this is D point, C, and this is D point. And from this graph, the question was there that at which point on the ventilation perfusion graph, the indicate the effect of pulmonary embolism. Okay. Or some of the students are saying that, sir, this question was kind of clinical question, that a person is suffering from pulmonary embolism and one emboli has blocked the capillaries completely. So what will happen to the VQ ratio of the graph in that alveoli? So this kind of question can be given. Okay. So alveolar gas. But look at here, if this is the graph, okay, this kind of writing will not be there on the graph, I believe. Okay. So A, B, C, D, this 4 point will be there, and you have to answer that at pulmonary embolism, which point will indicate the pulmonary embolism. Now, if you follow the main lecture of mine, so what I have discussed there, that in the x-axis, this is the alveolar oxygen and this is the alveolar carbon dioxide. Whenever a person is suffering from pulmonary embolism, so what will happen to the VQ ratio? VQ ratio will be infinity, right? Because embolism means the Q is 0, that is no perfusion to that. So infinity ratio. And if a person is suffering from block at the level of the bronchial, okay, so ventilation block, then the VQ ratio will be 0. So here the embolism, the person is suffering from embolism. So what will happen? The VQ ratio is infinity. And you can see easily that whenever the VQ ratio is infinity, so what will happen? This graph will be shifted to this direction where the partial pressure of oxygen is maximum, that is near equal to, so partial pressure of oxygen will be near equal to 150 and partial pressure of carbon dioxide will be near equal to 0.3 millimeter of mercury. This I have explained in this in my main lecture classes. So the answer of this questions will be D. If this is the curve given, so your answer will be this is the answer. This is the answer. Okay, because this point indicate the VQ ratio is infinity, and whenever VQ ratio is infinity, what will happen to the oxygen partial pressure? 150, and what will happen to the carbon dioxide partial pressure? That is near equal to 0. Okay, I think this was the kind of question that has been asked. Okay, and it is a little bit tricky, but if you follow my lecture, so this was exactly I have explained in my class. Okay, very good. Okay, right. Complete block, VQ ratio, very good. Next is this one, that what is the primary mechanism does hydrochlorothiazide prevent the formation of the calcium stone? This is also an easy question because from your pharmacology knowledge, you know that hydrochlorothiazide means this will causes excretion of the more calcium. So this I have also explained in my classes, physiology also. So this is the thiazide diuretics mechanism that I explained in my classes, that it blocks the NCC transporter. Whenever you block the NCC transporter, you are blocking the sodium and chloride reabsorption in the distal tubule, and because of which what will happen, the sodium calcium exchanger pump will be hyperactive. Because the sodium calcium pump is becoming hyperactive, what will happen? More calcium will be reabsorbed from the lumen of the nephron. So that's why here the thiazide is inhibiting NCC. Because of the inhibition of the LCC, there will be decreased sodium reabsorption. Because of the decreased sodium reabsorption, NCX will be more active, because of which calcium reabsorption will be there, and by this mechanism the thiazide diuretics prevent the calcium stone formation. So answer is going to be the B, that it increases calcium reabsorption in the distal convoluted tubule, leading to decreased urinary calcium and stone formation, right? Okay, very good. Very good. So this is again a simple question. I believe you all have answered correctly. Okay. Next question was the length tension relationship of skeletal muscle. Okay. So there was a little confusion that what was the option, but look at what I believe here, that this is a kind of graph which was given in the exam, and they have marked this zone. Okay. And after marking, they asked that what is the status of actin myosin interaction at this zone. So in my lecture, I repeatedly explained that this top part of the graph, this is the exact discussion from my lecture. So here, this flat portion is marked in your MCQ. Okay. So this is the optimum length of the skeletal muscle where the length tension relationship will have maximum, right? So what is the reason for maximum length tension relationship? What is the reason for the maximum tension? The reason is that optimal overlap between actin and myosin. So if you look at the curve here, so these are the myosin heads which is interacting with the actin. Whenever the both actin are touching with one another, that is the point where the length tension relationship will be maximum. Getting my point? So so this is the thing. So if you look at this diagram, so this is the myosin, and in the first option A, okay, it is showing that myosin actin is overlapping with one another. So this is not going to be your answer. Then in the second, the actins are very, very away from one another. So this is also not going to be my answer. And here also, again in C also, the actin are very away from one another. But in the option number D image, if you look at the option number D image, here you can find out both the actin are touching with one another. So whenever both the actin are just touching with one another, this is the area where the optimum overlap is going to happen. So see here, this also is looking like a complete, maximum overlap, but this is not the maximum overlap. Some head will also be there in this zone. So that is not interacting with the actin. So I have to choose a graph where both the actin are just touching with one another. And if this is the exact diagram, then I'll go for this option number D. So option D will be the best answer to choose in this question, which is showing that optimum overlap between actin and myosin. So what you have to choose in the diagram? You have to choose where both the actins are meeting with one another. Okay. So this is option number D is the answer. Next question. A man is climbing on the mountain for trekking based on physiological response of the high altitude. What is the most acid-base balance abnormality? This is, I believe, most easiest question in physiology in this paper. Okay, this question was asked in the last FMG examination also. So you all know that whenever you ascend to the high altitude, because of the hyperventilation, what you are going to do, you are going to wash out the carbon dioxide. So alkalosis is going to happen, and that is known as the respiratory alkalosis. So you have to choose this respiratory alkalosis because of the washout of the carbon dioxide. Okay. Now the next question was the kind this. Okay, some student told me that this was another question, high altitude pulmonary edema. Could you tell me whether this question was there or not? Yes, high altitude pulmonary edema was there or high altitude cerebral edema was there? Okay, which was the question? Cerebral edema? Okay. Wrong question. Which one? This one? Cerebral edema. Okay, okay, okay. So I'll change this high altitude cerebral edema. Now you tell me the answer. So if it is high altitude pulmonary edema, then your answer will be that low CO2, low PO2 mediated vasoconstriction. B will be the answer. But because most of you are saying that this is high altitude cerebral edema, so all of you know that high altitude cerebral edema occurs because of the vasodilation, because of the cerebral vasodilation, because hypoxia is a stimulus for vasodilation. So in that cases, answer will be low partial pressure of oxygen mediated vasodilation in the cerebral vessel will leads to edema formation. Okay. Along with that, there will be autoregulatory failure. So this we also have discussed in main lecture classes. You can also see there. Okay. ठीक है. So this will be the answer. If the question was the cerebral edema, then your answer will be that low PO2 mediated vasodilation will causes cerebral edema. Okay. So this is all the question that I have got. Some students also told that there was a question regarding the cardiac action potential, but I didn't get that question correctly, so I have not kept it. So this is all about physiology. Altogether 5 questions. So 5-6 question was there, and I believe you have done it correctly. So best of luck with your result. Thank you so much.
A very good evening, all of you. So, welcome to this NEET PG paper analysis. Hope you were able to perform in this exam to the best of your expectations, right? So, how are you feeling? I hope you're feeling really light and, at least relaxed for now that the exam is over, right? So, let us discuss the pediatrics questions recalled by you that came in the exam today, right? So can you please confirm if my voice is audible and if my screen is visible? Please confirm. If my voice is audible and my screen is visible, kindly confirm. Yes, so that we can start. Yes, can you please confirm? Okay, thank you so much. Thank you. Okay, right. So we got almost 10 to 12 questions from pediatrics this time, recalled by the students till now. Maybe there are some more. So we will be discussing the topics that came today and the questions that we could get, right? If you feel that there is some addition or some modification in the questions or the options, you feel free to let us know so that we can come up with a more refined version of this recall soon, right? Okay. So starting with the first question that I've got here, a 3-year-old child. So this is a 3-year-old child who is brought to the emergency room with a generalized seizure following a high-grade fever. So you have fever along with seizures in the age group of 6 months to 5 years. So what is your diagnosis here? So yes, we are dealing with a case of febrile seizures because there is no evidence of shrill cry, neck rigidity or any meningeal signs, any altered sensorium, nothing else is there. So we are dealing with febrile seizures. Okay, somebody is telling it's a 6-year-old child. Okay, 6-year-old, still typically febrile seizure happens in the 6 months to 5 years age group. But if there are no other red flags and if it is just fever with seizures, we can still take it as febrile seizures. What is the first line drug of choice for seizure control in this acute febrile setting? So if this is a case of febrile seizure, okay, as per the case scenario that I have received till now, then you will just have to abort the seizure. And if the seizure is not continuing for a long time, no long-term antiepileptics are required. But in the acute setting, you may use rectal diazepam, or you can use midazolam nasal spray, or you can use buccal or nasal midazolam, okay, to abort the seizure, okay. Now somebody is telling that no fever is there. So if there was no fever, then the drug of choice would depend upon what type of seizure it is. If it is absent seizure, as some of you were telling, and ethosuximide was option, then you will mark it as correct, okay. So it will depend upon what exactly was the case scenario, okay, that was being asked. So some people are telling fever is there. I think majority are telling fever was present, okay, and very few, I think a couple of you said fever was not there, but everyone is telling fever was present. And ethosuximide was probably one of the options. So even if ethosuximide was one of the options, but if fever was there, seizures was there, and no other telltale signs of CNS infection, we would still consider febrile seizure as the most probable diagnosis and we would go with diazepam, okay, even if ethosuximide was one of the options, okay, right. The next question. So a 6-month-old infant presents with recurrent infections. So the child is having infections again and again. Failure to thrive, okay, 6-month-old child, recurrent infections, failure to thrive. Lab investigations reveal deficiency of adenosine deaminase. So we all know that adenosine deaminase deficiency leads to which type of immunodeficiency? So yes, it is SCID, that is severe combined immunodeficiency. And such a child will have recurrent infections, and because infections are happening again and again, the child will not gain weight adequately. So there will be failure to thrive. Okay. So ADA deficiency, SCID. Fever might be mentioned in this question because the child is having, infections, recurrent infections. So that's okay. I think we are sorted for this question, right? Okay. So T cell and B cell and NK cell defect was also there, somebody is telling. So T cell defect, whether they were separate options, T cell defect, B cell defect, NK cell defect, was it separate options or was it a single option? And B and T cells are low was present. So what was there? Can you refine the case scenario? If someone can refine the case scenario and the options, till the the preliminary things that I've got till now, the opinion of the students is that this was clear cut. If adenosine deaminase deficiency is mentioned, it is SCID, severe combined immunodeficiency. Okay, right. So probably there was one more similar question with which you're getting confused. So again, this was a very much expected question. So we've studied it in our LRR also. So it is a typical case of, Tay-Sachs disease, a child presents with neurodegeneration and a cherry red spot on fundus. Enzyme assay reveals hexosaminidase A deficiency. We know that hexosaminidase A deficiency is Tay-Sachs disease. Now, there was a twist in this question. They did not give Tay-Sachs disease as one of the options. So we all know GM2 gangliosidosis is the category to which Tay-Sachs disease belongs. GM2 gangliosidosis includes Tay-Sachs disease and Sandoff's disease, hexosaminidase A and B deficiency. So GM2 gangliosidosis is our best answer here, right? We know cherry red spot is present and there will be neurodegeneration. GM1 gangliosidosis, you also get hepatosplenomegaly in that. Niemann-Pick disease, again you can get cherry red spot, hepatosplenomegaly, you will also get pulmonary involvement. Gaucher disease, cherry red spot is not present. Okay, so they are out. Okay, so our best diagnosis here is GM2 gangliosidosis. Okay, so if anyone else, anything else that was there in the question or any other options, please let us know. Okay, right. Okay, so moving on to the next question. A child presents with developmental delay. Okay, so this is a cross-cutting question between biochemistry and pediatrics. Even the last question was. So a child presents with developmental delay. Okay, so Gaucher was not there, somebody is telling. Okay. A child presents with developmental delay and coarse facial features. Enzyme assay reveals a deficiency of alpha-L iduronidase. We all know alpha-L iduronidase is which disease? Deficiency is which disease? Hurler disease or type 1 mucopolysaccharidosis. Okay, type 1 mucopolysaccharidosis. Corneal opacity, some people said was mentioned in the question, some said it wasn't, but it was Hurler disease. So which of the substances is most likely to accumulate? So again, you must have discussed in biochemistry as well. So Hurler disease, we know there is, HD. That means heparin sulfate and dermatan sulfate get accumulated. Okay. Hurler disease, HD. So heparin and dermatan sulfate gets accumulated. So that is the best answer here. Okay. So corneal opacity was not present. Even if it was not present, if you have been given alpha-L iduronidase deficiency, it is a clear-cut case of Hurler disease. Right. Okay. Splenomegaly may be there, no problem. Okay, so this was again a pretty simple question and a very common sense type of a question. So complementary feeding is initiated for a 7-month-old infant. We know we start complementary feeding at 6 completed months using the Katori method. What is the recommended amount and frequency of food to be given in the first 24 hours? So we always start with small amounts at a time, right? So in a baby who is already being breastfed also, we start with half to 1 Katori and we give it 3 to 4 times a day. So the best answer is this, half to 1 Katori 3 to 4 times a day. Okay, right? And if the child is not breastfed, you can give up to 5 times a day. But nothing about breastfeeding is being mentioned in the question that the baby is not being breastfed or something. So we will take it as half to 1 Katori 4 times a day as the best answer. Okay. 3 times a day was also option, somebody was telling. So 3 here, so we can mark 3 also. So it is actually 3 to 4 times a day in a breastfed baby. And if it is a non-breastfed baby, it will be 5 times a day, complementary feeding. Okay, right? So 3, if option is there, 3 is fine. Because just start hi kiya na, in a 7-month-old child, you've just started complementary feeding. Okay. So an HIV positive mother with a viral load of 1200 copies per ml delivers a baby. So this HIV positive mother, viral load 1200 copies per ml, that means more than 1000 copies per ml, that means it is a high risk baby. And a mother has got a high viral load, so it is a high risk infant. What is the most appropriate antiretroviral prophylaxis for the newborn? So most appropriate antiretroviral prophylaxis, because it is a high risk infant, high risk infant with mother having high viral load, and we don't know about the treatment, whether mother is on treatment or not. So we will want to give a 2-drug prophylaxis. So we will give nevirapine and zidovudin for 6 weeks. Agar option mein 12 weeks hai, so we will go for 12 weeks. Okay, if option says 12 weeks, we will go for 12 weeks. But 2 drugs must be given here. The important thing is 2 drugs must be given. If 2 drugs with 12 weeks was an option, then we should have gone with 2 drugs and 12 weeks. Okay, right. The next question, there was this question on renal rickets, sort of a question. So a 5-year-old child with chronic kidney disease presents with bow legs. Okay, so 5-year-old child with chronic kidney disease presents with bow legs. Lab investigations reveal serum calcium of 9.1 milligram per dl, serum phosphate of 6.9 milligram per dl, alkaline phosphatase elevated, and 25 hydroxy vitamin D was low. What is the most appropriate next step in management? Right? Was this the question? Okay, so calcium plus phosphate binder is an option. So calcium supplementation plus phosphate binder, if it was an option, it makes our life easier. Because this child has got bow legs, that means he has got features with rickets. Rickets wala features hai isme. And calcium is just borderline. 9 to 11 milligram per dl is normal. Is bache ka we have 9.1 milligram per dl. So we would want to give calcium supplementation also, and we would want to give phosphate binder also, because phosphate is on a higher side. And in fact, calcium carbonate or acetate, if it is given before meals, it helps to correct hypocalcemia. If it is given with meals or just after meals, it will act as a phosphate binder as well. So the best answer would be calcium supplementation plus phosphate binder. Okay, no sun exposure was also there in the question. Okay, fine. And calcium was 7. Okay, so calcium was 7, then of course, then this is the answer. Calcium supplementation and phosphate binder, both the things need to be done. Okay, so hemodialysis was also an option, somebody is telling. So, just renal rickets is not an indication for hemodialysis. Hemodialysis would be required. So, hemodialysis, even if it was an option, hemodialysis would be required if, the child is having low urine output or fluid overload or refractory hyperkalemia, okay, or uremic encephalopathy. Those would be the indications for hemodialysis. So, hemodialysis agar option tha, to bhi we will not go with that. Okay, right? So this, again, no points in guessing this question. I'm sure each and every one of you have got this question correct. So many times in various revision sessions we've discussed this. So a 24-hour-old baby with severe respiratory distress was admitted to the ICU. A chest x-ray of the neonate is given. What is the probable diagnosis? So this was a clear-cut case of congenital diaphragmatic hernia. So can you make out that there are bowel shadows in the thorax? There is mediastinal shift, right? You can see intestinal shadows in the thorax, and you cannot make out any diaphragmatic outline. So, you cannot make out the diaphragmatic outline. Okay, you can see that you cannot make out the diaphragmatic outline. Okay, so this is congenital diaphragmatic hernia. So, I'm sure all of you have got it correct, congenital diaphragmatic hernia, right? So, CPAM was probably an option, which is confusing. So, CPAM mein you would be able to see the diaphragmatic border. Okay, diaphragm ठीक से दिखेगा. There is no diaphragmatic defect in CPAM, right? Congenital lobar emphysema, there will be of course hyperinflation of a lobe, not like this. Neonatal pneumonia also will not appear like this. It will be like infiltrates and all. Okay, so somebody is telling it look like CPAM. So if you were able to see the diaphragmatic border very clearly, it could be CPAM. It is a closed differential of congenital diaphragmatic hernia. Okay, now again, very easy question, covered multiple times. An abnormally tall baby presents with subluxation of the lens, long limbs, arachnodactyly. We all know we are dealing with a case of Marfan syndrome. Okay, Marfan syndrome. And Marfan syndrome has got autosomal dominant inheritance, and which gene? So it is the fibrillin 1 gene which is mutated in this condition. FBN1 gene which codes for fibrillin, right? So, okay, any SCID wale question and B and T cells less were given in the question. That makes our diagnosis more easy, right? So again, then this was a question on foreign body aspiration. A child accidentally aspirates a peanut, okay, and suddenly starts coughing and showing signs of respiratory distress. What is the appropriate immediate management? So if it is a child with suspected foreign body aspiration, you're going to give abdominal thrusts or Heimlich maneuver to bring the foreign body out. Now, even if the child's age was 2 years, that's fine. If the child was an infant, okay, if the child was an infant, then we would have given back slaps and chest thrusts, okay, right? Intubation was an option, but intubation immediately will not go for intubation. We will first try to bring out the foreign body with abdominal thrust or Heimlich maneuver, okay. So unconscious was also mentioned in the question, somebody is telling. So if unconscious was also mentioned, then CPR would be required. So I would like to, so please provide me with the exact question so that we can discuss on it further. So if unconsciousness was mentioned, unconscious child was mentioned, unresponsive baby was there, then of course we would need to go ahead with CPR also. So unconscious was mentioned, somebody was telling. One option was chest compression. So chest compression alone would not suffice. So usually what is done is with back slaps and chest thrusts, if the baby becomes unresponsive, then you have to start CPR. So I would need more refinement on this question before commenting on what is the best answer. So somebody is telling it is a 2-year-old child, unresponsive child, CPR was an option. Okay, right? So we'll get back to this question once we get more, insight into what exactly was asked. Abdominal thrust was not an option. Somebody is telling abdominal thrust was not an option. Endotracheal intubation was there. So please provide me with the exact question and the options so that we can dwell on it further. Okay. But if it was a child and foreign body aspiration, Heimlich's maneuver. If it was an infant, then we would give back slaps and chest thrust till the child becomes unconscious or unresponsive, and then the child would require CPR. The baby or infant would require CPR. Okay. Now this was a pedigree question where that was there, the easiest pedigree possible probably. The pedigree diagram of a family is shown below. You can see that all children of an affected mother are affected. So if this mother is affected, you can see all her children are affected. Again, if this mother is affected, you can see all her children are affected, right? Again, the other mother affected, all children are affected. So what are we dealing with? So we are dealing with a case of, what are we dealing with? So mitochondrial inheritance. Mitochondrial inheritance. And we know a typical example of mitochondrial inheritance is Kern-Sayre syndrome. So KLMNOP, right? Kern-Sayre syndrome, Leber's hereditary optic neuropathy, right? Then you have this MRF, MELAS and all that. So this pedigree diagram is shown below. Affected individual presents with progressive external ophthalmoplegia, pigmentary retinopathy and cardiac conduction defects. Based on this pedigree and clinical features, we'll go with Kern-Sayre syndrome, right? William was also an option, somebody is telling. Even if William was there in the option, this was not the answer. Okay. Right? Achondroplasia option was there, but that will not be the answer again because mitochondrial inheritance is not there. Now this was again a piece of cake. So very, very simple question. I'm sure all of you have done it correct. So this was a question about the vaccine vial monitor. Which of the following vials as shown in the image can be used for administering vaccine? So we know we can use it only if the color of the inner square is lighter than the outside circle. So you can see that in the first one and in the second one, right, the color of the inner square is lighter than the outer circle. So you can use 1 and 2, but we cannot use 3 and 4 because the color of the square is darker than the outside circle. So here, which of the following can be used? The best answer would be 1 and 2. Okay, 1 and 2 would be the best answer, right? Okay. So regarding the previous question, please provide a refined version of that question. So if it was like a child was unconscious and was brought to the casualty and in the emergency the management was being asked, then of course we would go with CPR or endotracheal intubation. But if it was the question that the child, nothing is mentioned about ICU setting or hospital and the child just had foreign body aspiration and choking and coughing, then Heimlich's maneuver would be the best option. Okay. So somebody is telling chest compression, back slaps, abdominal thrust and endotracheal intubation was there. Okay. So it will depend upon what exactly were the wordings of the question, right? So these were some around 12 questions that I've got till now. If there are any other questions from pediatrics, so Prader-Willi, somebody is telling was a question. Was there a separate question on Prader-Willi syndrome? If yes, please provide what the question was. Then we'll be able to discuss. Any other question? Yes? Any other question from pediatrics that you can remember? Okay, one question related to orange tonsils. Somebody is telling Prader-Willi was there in a question or in a pedigree. Okay, trisomy 21 also somebody is telling something was there. Okay, in the mitochondrial question, Prader-Willi was an option. Okay, right? Okay, in the pedigree question, right? So I believe these were the questions that we've been able to recall till now, but we will definitely come up with a more refined version of these questions and the options and the discussion on that once we are able to get the feedback and some more clarity on the questions that were asked. But I'm sure you've been able to answer most of the questions correctly. And please, after the mega recall session is over tonight, do spend time with your friends and family, relax, unwind, have a great time. This time is never going to come back. All the very best for your results. Waiting to hear from you once you're able to, get your results, and I'm sure you'll come out with flying colors. All the very best. God bless you.
Hello friends, OBS Gynae Recall is there with me. I'm Dr. Shonali, and I hope your exam went well. And I've had the chance of seeing your OBS Gynae questions. And I'm glad that unlike FMGE this year, this examination, even though there are, I have 24 questions set out for you, but they're mainly from your previous year topics. And a few of them are standard repeat questions that they've been asking very often. So without wasting any further time, we are going to start with the paper analysis. So we're going to see the questions, all right? And with the questions, I'll always give you some tips also regarding this paper. So let's see here, on a woman with a regular 28-day menstrual cycle, which of the following best describes the typical hormonal profile during these 21 to 25 days of the cycle? Now, again, see the menstrual cycle, that diagram, that graph we talk about, and they ask you n number of questions repeatedly somewhere related to that graph, right? So what is the answer here? We are talking about the luteal phase of the cycle. So we know that it is progesterone dominant, isn't it? So of course, low progesterone will not be there. There will be high progesterone, yes, of course, but high estrogen will not be there, right? So again, we have option number A or option B as the answer. So see here that there is going to be low LH and FSH levels are also low during this phase of the cycle, right? The surges, that LH surge that had happened, the FSH surge that had happened, these surges are subsiding in the luteal phase. So the correct answer is option number A, right? All right. Now, let's have a look at the next question. During full-term vaginal delivery, an OBS resident is seen applying counter pressure above the pubic symphysis with one hand, gentle pulling on the umbilical cord with the other. And what maneuver is being demonstrated in the image, right? So in the image, again, this is a repeat question. This image has been asked n number of times again, and this is controlled cord traction, which is also called as the modified Brand-Andrews method, right? For manual removal of placenta, which is done for retained placenta, the hand has to be introduced inside the uterus. That procedure is done under anesthesia in OT, and this controlled cord traction is something that we routinely do in our labor rooms for placental delivery as a part of active management of third stage of labor. So we know that the person is not massaging the uterus here, and this is also not bimanual uterine compression. Bimanual uterine compression or bimanual uterine tamponade is a procedure that is done when we are managing atonic PPH, right? So this is option number A. Now, some of you are saying that in the first question, the options are wrong, as it was high estrogen, high progesterone, and low FSH. See, what I'll tell you again, the recall options could a little bit be here and there. That is always the tendency with recall questions. So understand here for your, clarification that it is in the luteal phase, there's going to be high progesterone. Estrogen levels are also there. It is not that corpus luteum does not secrete estrogen. It also does that. But obviously, the levels are on the lower side as compared to what happens in the follicular phase of the cycle. Okay, and the FSH and LH levels are low. Okay, now let's have a look at this question. You're saying this image wasn't there. Agreed, this image could not, this image may not be the exact image which was there, but the image what we are getting from the recall is that the image was of control cord traction. It was basically an image on a real patient that was shown. Now, moving on. Next question. 38-week pregnant woman is in active labor with 5 centimeter cervical dilatation, and she's getting regular contractions, and she suddenly develops umbilical cord prolapse. What is the most appropriate immediate management? Right? So again, cord prolapse, clinical topic, I've discussed it with you time and again. So what would be the answer here? Yes, umbilical cord prolapse has happened. So, of course, the baby is at risk of sudden death, isn't it? So, we cannot just keep waiting and observing and doing nothing. All right. Now, vaginal packing to protect the cord is something that is not recommended, right? We cannot unnecessarily fiddle with the umbilical cord. I told this to you in the lectures also. And there is no point in administering oxytocin to expedite the labor. She's just 5 centimeters. So what needs to be done? We need to elevate the presenting part. So basically, we need to do the maneuvers to prevent cord compression and expedite delivery. Right? So here what we are going to do, manually elevate the presenting part, fill the bladder retrogradely. That is also called as Vago's technique. Okay, and this has been discussed in the main lectures also with you people, right? So fill the bladder retrogradely and meanwhile expedite the delivery, prepare and take the patient to the OT for an emergency cesarean section. Okay. Now, next question. A 46-year-old woman presents with complaints of irregular menstrual cycles and heavy vaginal bleeding for several months. So this is a case of AUB in a 46-year-old woman. That is your first keyword, right? Transvaginal ultrasound reveals endometrial thickness of 16 mm. That is another keyword, okay? What is the most appropriate next step in management? So the important thing here is her age. First of all, most important, she is more than 40 years of age. So before starting any treatment, we have to rule out endometrial hyperplasia. This is such an often repeated question. Her endometrial thickness is also more. For a reproductive age group female, more than 12 mm is considered a higher endometrial thickness. So most appropriate next step in management would be to perform an endometrial biopsy, right? So no going for a hysterectomy straight away. We know that for benign conditions, hysterectomy, we are moving away from hysterectomy. It will not be your answer. And before starting any treatment, whether pills are required, whether progesterone therapy is required, it is important to rule out endometrial hyperplasia, right? And that is why observe and reassess after a few months will not also be the correct answer in this situation. Okay. Now, next question. Again, this is also a repeat question. Right now, again, but this has come with a clinical profile. That's the only difference. So you would spend more time reading the question. So 36 weeks pregnant woman, she has preeclampsia. In all, they are asking you, according to the Pritchard regimen, what is the total loading dose of magnesium sulfate, right? So 4 gram is IV loading dose, plus we give 10 gram intramuscularly, right? So you may get confused regarding 4th, 10th, 14th. Total dose is 14 grams. Total dose is 14 grams. Now, some of you are saying in the previous question, the age of the woman was 65. Even if the age of the woman was 65, it won't change your answer. Even if it was a postmenopausal woman, you would perform an endometrial biopsy for her. You have to make a diagnosis first before resorting to any sort of treatment, right? So, coming back to the next question. Now, woman develops atonic postpartum hemorrhage after vaginal delivery that does not respond to the initial medical management, right? So this is in summary. Maybe they had in the question probably given you information like IV fluids were given and, uterotonics were given or oxytocin was given. So maybe they had provided you this information that the initial management using oxytocin, uterotonics, IV fluids, all that was given. So that part of medical management has been done. What is the next step in managing her condition, right? So again, I am a little skeptic about this recall of this question, because again, I find that maybe some important information in the stem of the question could have been missing. But anyways, immediate hysterectomy is definitely not the answer, and devascularization surgery is also something that is not going to be very effective in managing, they're saying, atonic PPH, right? So for atonic PPH, the next step that can be done, especially since they're talking about after vaginal delivery, we can go for a Bakri balloon tamponade. Bakri balloon tamponade can be done. So the balloon tamponade will help us potentially avoid a laparotomy, right? So she has delivered vaginally. Okay, for applying compression sutures. What are compression sutures? Compression sutures are like B-Lynch sutures. Okay, so for applying compression sutures, we'll have to do a laparotomy, perform a laparotomy. So the balloon tamponade is a procedure which will help us potentially avoid a laparotomy, because if we are able to have a successful balloon tamponade, bleeding will stop. So that is the logic, right? So that is the answer here. Okay, Bakri balloon tamponade. And let me also tell you, see, this is how they play with your questions, these examiners. A recent FMG also gave a very similar kind of question, all right? And they had said that the woman was having PPH during a cesarean section. So when PPH is happening during a cesarean section, let's say, for example, and the patient is already open, she's in the OT, we're doing a cesarean section and atonic PPH is happening, it is not responding to uterotonics, then patient is already under laparotomy. So we go for compression sutures. Then it makes sense to directly go for compression sutures and not a balloon tamponade. So the situation can be different. Okay, right? Now, ideally, yes, the balloon tamponade should be done in the OT, but it could be done in the labor room also. Ideally, yes, it should be done in the OT, so that in case it doesn't work, patient is already in the OT, one can proceed with the laparotomy. If they had mentioned, like you people are saying, if they had mentioned that what is the next step in the labor room, okay, if they had mentioned in the labor room, then obviously it is balloon tamponade. The rest of the things cannot be done in labor room, right? So not much in this question. Next, a laboring woman is found to have fetal bradycardia on fetal monitoring along with maternal tachycardia. What is the most appropriate immediate management, right? So, yes, what is the most appropriate immediate management? Let's think about this. Again, this is a very logical and a common sense based question, right? There's fetal bradycardia, there's maternal tachy. Why would there be maternal tachy? Maternal tachy could be because of maternal blood loss. Maternal tachycardia could be because of maternal fever, infection whatsoever. And along with these things, there can be fetal bradycardia also. So what is the most appropriate management? To directly go ahead and do a cesarean section, all right, or to just keep waiting and watching and do nothing. So we do realize that waiting and watching is definitely not the option, right? Now, starting oxytocin infusion, they have not mentioned anything about the contractions, or maybe they had in the question and maybe the recall is correct. So I don't know what they're talking about, the contractions. So doesn't matter about the contractions also. For that matter, it won't change the answer of the question. The thing is that if you give oxytocin infusion and if you increase the contractions, right, you're increasing the potential of fetal bradycardia, right? So starting oxytocin infusion is also not the right choice. So choosing between emergency cesarean section and ARM, just think about it. You know the answer, right? Now, we will need possibly to expedite delivery. Okay, possibly the need may be that we have to quickly deliver the patient. How we will deliver the patient is another matter, whether we will do cesarean or whether she's already fully dilated, maybe she is qualifying for an instrumental vaginal delivery, and safely an instrumental vaginal delivery can be done for fetal distress in this situation. We don't know. All that information is not there. That will come later. First, we can do artificial rupture of membrane. So in this question, answer would be artificial rupture of membranes. Doing ARM will help us how? During ARM will help us how? We may find meconium stained liquor, and that may explain the situation. Okay, we may find blood stained liquor, and we may find that, oh, this is abruption. Okay, so these are the things that could be found, right? And we will have a diagnosis also. And while we are doing ARM also, we are doing PV. We will have the PV findings also. And then we will decide how we are going to deliver. Whether or not she deserves an emergency cesarean section or by instrumental vaginal delivery could be attempted. So that is why, if this is the question, okay, understand by the logic of the question. The obstetric questions, whenever they're asking you clinical questions, I keep telling you again and again, they are more about common sense and logic and concepts. All right. So again, like I said, that this question is more conceptual than mugging up and theoretical. So most keywords in the question have come. It may have had a longer stem, but for you people, the clear keywords were fetal bradycardia, maternal tachy. Okay, and for that, first of all, artificial rupture of membranes could be done. Now, next question. 65-year-old postmenopausal woman presents with painless vaginal bleeding. She has no history of hormone replacement therapy. So when there is a postmenopausal woman with vaginal bleeding, this is postmenopausal bleeding, and they're saying there's no history of hormone replacement therapy. So why is she having postmenopausal bleeding? There could be so many causes. There could be cancer cervix, there could be endometrial hyperplasia, endometrial cancer. Now, the answer to this question is option number A, endometrial cancer, because she is, again, age 65. So older age, postmenopausal, puts her at more risk of endometrial cancer rather than the other conditions, which are more conditions of reproductive age group women. And we know that fibroid and adenomyosis, these are conditions that kind of, and endometriosis also, these are conditions that potentially improve after menopause, right? Next question. In a cardiotocography tracing, the fetal heart rate shows 1 acceleration in 20 minutes with no decelerations, but no fetal movements are detected. What is the most appropriate next step, right? So the clinical profile to this question, potentially, they may have mentioned that the woman is coming with complaint of decreased fetal movement. So maybe they gave this clinical perspective and then a CTG was done. Right. Now, there's 1 acceleration in 20 minutes. So this is not a reactive NST. At least you can say that for reactive NST, it would mean 2 accelerations in 20 minutes. Right? There are no fetal movement, but there are no decelerations also. So what is the most appropriate management? It is to repeat the CTG for full 40 minutes before labeling it as non-reactive and acting upon it. Okay, so waiting and watching is not the answer, and immediate cesarean section is also not the answer. We can still repeat it for full 40 minutes before labeling it as non-reactive and acting upon it. Next question. A 32-year-old G2P1 woman with the previous cesarean section is undergoing trial of vaginal delivery at 39 weeks. So previous cesarean section, one keyword, she's in active labor, 8 centimeter station. Keyword is she's in active labor. Fetal brady, maternal pulse 110. So what is it? Impending rupture. Impending rupture. The most consistent sign is fetal heart rate decelerations, and she's previous cesarean section. So there is no question of performing anything else other than cesarean section. Next question. A cut section of the uterus shows a growth arising from the endometrium. Which of the following is the most likely diagnosis? So when they are mentioning growth arising from the endometrium, clear cut, it is carcinoma endometrium. There is no growth in adenomyosis. Okay, there is no growth in endometriosis or even fibroid. There are tumors, tumor, the world appearance of tumors in fibroid uterus. Next question. In managing shoulder dystocia during vaginal delivery, which of the following is the correct sequence of maneuver? So the first maneuver that is done is McRobert maneuver, right? We don't even need to read the other options. This is the answer. McRobert is the first maneuver, right? Then the rotational maneuvers, which are Rubin and Wood's corkscrew. Gaskins is all 4. Woman is kept on all 4, and the same set of maneuvers are repeated. And Zavanelli is the maneuver of last resort. So answer is option number B. Okay. And yes, the person medico is mentioning head -1 not relevant. No, with impending rupture, head -1 and +1 or whatever is not relevant. When it's impending rupture, it's cesarean section. During a clinical examination, senior resident asks in turn. Again, see, lengthy reads and simple question. That's why I always tell you when you have a lengthy read, read the last line. So let's just read the last line. How many arteries and veins are normally present in a healthy umbilical cord? So we all know it is 1 vein and 2 arteries. Left umbilical vein is left. Next question. In the repair of mediolateral episiotomy, what is the correct order of tissue closure? All of you have seen how episiotomy is repaired in your labor rooms, right? So what is the sequence of the repair? Vaginal mucosa, then muscle, and then skin. Okay, skin is the last. Next question. There's a 42-year-old woman who presents with chronic lower abdominal pain and dysmenorrhea. They may have mentioned abnormal uterine bleeding pattern also. MRI is shown, most likely diagnosis. So MRI is showing this increased junctional zone thickness, right? So this is adenomyosis, right? So they had asked you a question on the MRI image of adenomyosis. This we had discussed in the image-based recall, image-based session also. Next question. A 62-year-old postmenopausal woman with history of hypertension. Now, this is postmenopausal history of hypertension. She has vaginal bleeding. Again, question postmenopausal bleeding. Her blood pressure is 170/100. What's the most appropriate next step? You can't reassure that this is normal for her age. Now, of course not, right? You will obviously do an immediate pelvic examination, take a pap smear and perform and, recommend a transvaginal sonography for her. Of course, one would like to refer her for a cardiology workup also, considering her age and her blood pressure. But since she has come to you in the OPD, it is not like you will tell her that go to cardiologist first, then I will do your examination. So complete your examination, because the potential is that she could be having a case of CS cervix, or she could be having another cancer, gynae cancer, right? So this and this are out. Answer is option number B. Next question. A 36-year-old woman presents with secondary amenorrhea for the past 6 months. Lab investigation, so FSH of 36. So FSH of 36 is on the higher side. It's not crossed 40, but it is on the higher side. It is more than 20. And AMH of 0.05. This is low AMH, right? So high FSH, low AMH. This is premature ovarian insufficiency, POI. In hypothalamic amenorrhea, FSH is going to be low. There is nothing going in favor of PCOS or hyperprolactinemia in this woman. So answer is POI. Next question. A woman presents for her first antenatal visits and reports that her LMP was approximately 2 months ago. Which ultrasound parameter is the most accurate for dating the pregnancy at this stage? So 2 months ago, 8 weeks. So she's in the first trimester. The most accurate is crown rump length measurement. That is your answer for this question. All right. Now, next question. A woman is diagnosed with a pituitary microadenoma. She has elevated prolactin levels. Again, a lengthy read, but what they're asking you is basically very simple. Why is there symptoms in this woman because of hyperprolactinemia, right? So secondary amenorrhea is a symptom, infertility is a symptom. Again, a repeat question. Now wrapped in a clinical profile, right? So we know that increased prolactin, excess prolactin causes decrease in GnRH secretion, inhibits the pulsatile secretion of GnRH from the hypothalamus, right? Now, next question. A woman was diagnosed with cervical cancer, is found to have unilateral hydroureteronephrosis on imaging due to tumor invasion. What is the FIGO stage? So irrespective of the size of the cervical cancer, if there is hydroureteronephrosis, that means the pelvic side wall has been involved. So correct answer is stage 3B. Okay. Now, next question. An elderly woman presents with abdominal pain and is significantly elevated CA 125 levels of 1035. The resected specimen is shown. Which of the following is most likely diagnosis? So they had given you a question with this gross image of the ovarian tumor. And they're also mentioning that there is raised CA 125 levels, right? And raised CA 125 levels is a marker for epithelial ovarian cancer, right? So the keywords in this question were raised CA 125 level. The image was showing an enlarged ovarian mass. So therefore, the answer to this question is serous cyst adenocarcinoma. Now, I'm looking at a lot of feedback that the questions are not appropriately recalled. Well, that potential is always there since these are recall-based questions and the recalls are coming from the students themselves, right? So maybe we can give your comments in the chat box where you can help us correctly recall the questions and more appropriately recall the options. And then at a later point in time, always we can have the option of going back and correcting. Next question. Now, there's a pregnant woman who's undergoing vaginal breech delivery, and they mentioned that after delivering the baby's body up to the umbilicus, the obstetrician notices winging of the baby's scapula. So I think that they had asked you an image-based question. I think this was an image-based question also. And they had asked or probably mentioned that to facilitate safe delivery of baby's shoulders and head, which of the following maneuvers is most appropriate? So when they say winging of the baby's scapula, they mean that the arms are extended. Okay. So I think that they had given you an image-based question on Lovset's maneuver. Okay. So again, we'll have to see that whether this question had come with the clinical profile, as you guys recalled, or image-based question directly was asked. Nonetheless, the answer would have been Lovset's maneuver. Next question, a woman comes to the clinic with breast tenderness, presence of linea nigra on her abdomen, and bluish discoloration of the cervix, right? Now, bluish discoloration of the cervix, recall that this is Chadwick's sign. Okay, now what is the most likely clinical interpretation of these findings? So, normal menstrual cycle is not the answer, and these signs do not confirm pregnancy. In menopause, there is an atrophic cervix and there is a pale looking cervix and a pale looking vagina. So menopause is not the answer. These are probable signs of pregnancy. So when we talk about these signs like Chadwick's sign, Hagar's sign, and all of these signs, they are mainly the probable signs. They are the probable signs, right? So this is probably pregnancy. Okay. Next question. I don't know if the exact stem of the question was in this format, but what they had asked about was mainly DVT prophylaxis. They had asked about DVT prophylaxis. in a woman who was obese and was undergoing a cesarean section. Okay, I think this was the clinical profile of the patient. So all in all, they were talking about DVT prophylaxis in a delivered woman, in a postnatal woman. So here we give low molecular weight heparin. So for DVT prophylaxis in obstetrics, we have the drug of choice, which is low molecular weight heparin, right? Do not get confused when we talk about warfarin as prophylaxis for thrombosis. That is very specific and unique to heart disease patients, okay? Not in this particular case. So this is low molecular weight heparin. All right. So this is the recall of the 25 questions. All right. Any other doubts and any other questions that you feel that have not been covered, you can mention in the chat box. Okay. And I'm now looking at your chat box also. Any other question that has been mentioned which was not there, which has not been taken up? Or similar looking question? Yes. All right. So again, there is a lot of discussion in the chat box regarding the recall of the questions and regarding the recall of the options, right? Now, what we have got as the recall portion of these questions is again the recall that has been provided by you people, provided by our students, right? Now, again, with lengthy questions, what happens is sometimes the questions can get mixed and the recalls may not be 100% accurate. That is the thing with recall questions, right? But most of it, the gist of the question remains the same. All right. So we're going to probably have a look at the recall also again at a later point in time if we get the feedback that the recall options need to be looked into. Thank you so much.
आंसर लाइव है
सर लाइव है गो लाइव So very good evening, everyone. Good evening, everyone. Hope I'm audible and visible to all. Let me know in the chat box. A very good evening and welcome to the psychiatry recall of the NEET PG 2025 exam. Again, one very important message. You've worked really hard for this exam. It's time to relax and unwind yourself. A very good evening. So the purpose of this session is to get as close as possible to the questions which were asked in the exam, so that we could use it for the future examinees. So let's start with the recall session. A very good evening. So let's see first the analysis. So up till now, we have got around 7 questions of psychiatry. In fact, again, if you look at the topics from which the questions have been asked, you will see they have repeated the topics. So in fact, there is question from the basics, and also there's a question in the schizophrenia topic from the EPS, again a repeatedly asked question. Also, we have been seeing again question from this topic of trauma and stress related disorder. Also question from personality disorder was there. Again, in the last NEET PG exam also there was a question on personality disorder. So they've repeated this topic. A question on dissociative disorder, a very similar question. In fact, this question which was asked in NEET PG, a very similar question was asked in the recently conducted FMGE exam. In fact, we have discussed this in the LRR session, that, again, a lot of questions are getting interchanged, and 2 questions I'll discuss. You'll also discuss these questions in forensic psychiatry. So 2 questions I'll also discuss. So it was more of a, we'll just come back. Right. So again, let's start. So again, yes, I'm sure you must be tired. So we'll be very quick in the discussion. So these were the topics which we have got. Let me know if there is any correction. So let's start with the first question. See the first question. A patient with schizophrenia is responding well with haloperidol for 2 years. So they've given patient is on antipsychotic for 2 years. So they've given he's been on antipsychotic for long term and now has presented with orofacial dyskinesia. There is coriform tick-like movement and possible dystonia. So just tell me if this was the question. The question is, what is the likely diagnosis and the treatment? So tell me if this is the question which was asked in the exam. So let me know if this is the question and the options. I'm sure all of you would be able to answer this question. The patient is having some movement, dyskinetic movements, and there is a long-term use of antipsychotic. So what is the right answer? Yes, the question was same. Yes, so it is tardive dyskinesia and the drug is VMAT2 inhibitor, valbenazine. In fact, we have discussed this in LRR. We have talked about the EPS with the mnemonic DP at night. So remember T for tardive. Tardive means long-term use. So person may have dyskinetic movements like lip smacking, chewing movements. So perioral movements may be there, tongue protrusion, coriform movements. Such movements can be there. And the treatment is dopamine depleters, VMAT2 inhibitors like valbenazine, deutetrabenazine. I hope this is clear to everyone. Yes. So I would say a fairly doable question this was. Let's come to the next question. See this question. Again, try to answer this question. A 21-year-old female presents in the emergency complaints of amnesia of events for the past 2 weeks. I always say in psychiatry, duration is very important. It's a key word. So they've mentioned 2 weeks since she lost her father in a road traffic accident. So there is also a major stressor which has been mentioned in the question. She is also having flashbacks of the event. So what is the right answer? I'm very happy that all of you are answering it correctly. Yes. So we've discussed when there is a major stressor, and we have discussed the symptoms with the mnemonic MAHI. So remember this, we have discussed with the symptoms, the mnemonic MAHI. So here they have mentioned that patient is having flashbacks. There is intrusion symptoms. So what is the right answer here? Is it PTSD or acute stress disorder? Very good. All of you are marking correctly. It is acute stress disorder. I hope there is no doubt in this question. Right. Again, fairly doable question. So we have talked about this in the LRR also, and we have talked about in the main videos as well. So the answer is acute stress disorder. Very good. Now let's see the next question. Please try to answer this question. First, see the language of the question and the options. So this we could get from the students. A friend of Mr. K reports that Mr. K is very much obsessed with his schedule. He is very rigid about perfection. He keeps on managing everything systematically. He has been doing this since adolescence. So they've also mentioned he's doing it for a long duration. So symptoms have been present since adolescence. Mr. K does not agree with his friend and he does not seek for any therapy. What is the probable diagnosis? So I hope the question is clear again. Very good. So it is again, you must be very happy seeing this question in the exam. Yes, this is obsessive compulsive personality disorder. Yes, very good. So we have talked about this even in LRR. We discussed that, yes, it's an important topic because it was previously also asked. So here the person is having obsessive compulsive personality disorder. And we know here the person is preoccupied with rules, details, organization, wants to do everything with perfectionism. Very important. Just one point, please remember how to differentiate this from OCD. In OCD, patient has obsessions, compulsions. In OCD, we have talked about that OCD is ego dystonic. Here, the patient is not able to accept his thoughts. While in OCPD, the person is having egosyntonic symptoms. So person thinks whatever I'm thinking is right. So that is why in the question also it has been mentioned that he does not agree with his friend that there is any problem and does not seek for any therapy. So the answer is yes. So the answer is obsessive compulsive personality disorder. I hope this is clear to everyone. Right. Let's see the next question. Now, this, in fact, is a question, a very similar question was asked in the recently conducted FMG exam also. But just try to see the question and try to tell me that whether this was the question and also see the options. A patient is brought to hospital with bizarre presentation by a social worker. Social worker is reporting that he has been living in his town and actually he belongs to a nearby town. So he's living somewhere else, but he is now in his town. Just after a recent earthquake hit, he was brought here. He doesn't remember his identity and how did he reach 110 kilometers far from his home. There is no history of any substance abuse. Family members are concerned about this condition. What is the likely diagnosis? Okay, yes. So this also, was an option we were getting. Yes, global amnesia was there. I think possibly depression was not there. So global amnesia was there in the option. Okay. Psychogenic non-epileptic seizure was there in the question. So this is again psychogenic non-epileptic seizure means they're talking about conversion disorder, pseudo seizures. Was this also given in the option? Yes. Transient global amnesia, that I've taken input from all of you. Very good. Thank you so much. Yes. Right. I hope this is clear to everyone. Right. So transient global amnesia was there. So what is the right answer here? Now, can you appreciate he has traveled? He's traveled far and possibly he is not able to remember things of the past. What is this? This is dissociative fugue. Please remember this is dissociative fugue. Very good. Yes, this is dissociative fugue. We have talked about this in the video lectures as well. There is sudden unexpected travel away from home, workplace. Person may not be able to recall the past and may assume a new identity. And in fact, we have discussed this example that someone, had a financial loss and he travels, to a new city and does not remember the past and has a new identity. So this is dissociative fugue. I hope this is clear to everyone. Right. So just see again. So yes, I've taken your input. One of the option was transient global amnesia. Tell me if psychogenic non-epileptic seizure was there in the option and dissociative identity disorder, were any of these in the options? Right. The answer, I'm sure, even if there were other options, the answer, I'm sure all of you are clear. It is dissociative fugue. I hope this is clear. Right. Great. So yes, I've been seeing, yes. No, here other things he's doing. He is not able to remember the things of the past, maybe there is a trauma, and after that, the symptoms have started. Usually I've discussed in dissociative disorder that usually after trauma, the symptoms may begin. I hope this is clear to everyone. Let's see the next question. See this question again, an interesting question. Also, just try to tell me the options also. The question is, a young male comes to the psychiatry OPD and he says that when he sees the bird's wing flapping or flying outside, he believes that these movements of the bird is telling him to move in a different direction, and he do it. He thinks that it is God's way of telling him through the bird for him to be safe. What is the likely phenomena? Now just see this question, also see the options. Very interesting options. Delusional perception. See, it is delusional perception, not delusion of persecution. Sudden delusional idea, visual hallucination, primary delusion. Also tell me, was delusional memory in the option? Was delusional memory in the option? Yes, there was a history of travel. Yes, thank you, Dr. Amita. Yes, we have discussed. There was a history of travel. So that is why we are marking it as dissociative fugue. Right. So tell me, are these options correct? Are these options correct in this question? Let's come back to this question. Yes, delusional memory was there. Was primary delusion there? Okay, yes, delusional memory was there in the option. Yes. So I'll be fast. I'm just trying to gather. The sudden delusional idea was there. Delusional perception was there. I think visual hallucination was also there. Primary delusion most likely was not there. So tell me, what is the answer? No, I always say, even if some of the options you don't know, you still will be able to answer, because again, we talk about this when we discuss history of schizophrenia. Can you tell me what is this phenomena? Yes, options are correct. Thank you, Dr. Live. Yes. So the here answer is delusional perception. Let's understand. So we have discussed this, under Schneider's first rank symptom, delusional perception. So I always say, try to just remember things from the name. Delusional perception means that person gives a delusional meaning to a normal perception. We have discussed this with, various example also in the video. That person sees a spoon with a crown over it, and there is a delusion which develops that I am the king of the world. Delusion of grandiosity develops. Again, another example we have discussed, person sees his wife in a red sari, red means danger, starts believing my wife wants to kill me. So can you appreciate here? He sees there is a normal perception here. There is a normal perception to which the person gives a delusional meaning. So what is the right answer here? What is the right answer here? I hope this is clear to everyone. I hope this is clear to everyone. What is the right answer? Please remember, in the fugue question, most likely it is fugue because they're mentioning it, that there is a travel. Sometimes he may have, amnesia also. But remember, fugue may, very important, they have given you a history of unexpected travel. Okay, that is very important. Okay, yes. So the answer here is, I hope this is clear, this is delusional perception. In fact, delusional perception, sudden delusional idea, and even delusional memory, these are primary delusions. In fact, we have discussed this. These are, in fact, we have discussed what is primary delusion when it results, directly from the underlying disorder. So that means it is not explained by the mood state of the person, or it cannot be explained by the cultural background of the patient. So delusional perception is a type of primary delusion. Similarly, just remember that even sudden delusional idea is also a primary delusion. Sudden delusional idea means suddenly, out of nowhere, out of the blue, a full form delusion occurs in the person. Delusional memory means patient has a past memory and patient then makes or there is a delusion in his mind based on this memory. So that is delusional memory. So remember, here it is delusional perception. I hope all of you were able to got it correctly right. So yes, let's move on to the next question. So 2 questions were also from forensic psychiatry. Let's just discuss. Even in forensic, you will discuss these questions. So tell me, but in dissociative amnesia, better answer would be dissociative fugue. If both options are given, because there is they have mentioned history of travel, so better answer would be dissociative fugue. So if you have to choose between amnesia and fugue, then better answer would be dissociative fugue. I hope that is correct. Great. Now tell me, a person hurt or killed his colleague, and on evaluation, he said that he was getting instructions from voices that colleagues was about to kill him. So they're trying to tell you that there is some psychiatric, symptoms that has led to the crime. He has disheveled appearance. So they're trying to tell you that there may be some psychiatric illness. What is the next legal step? Can you tell me? What is the next legal step here? Yes, very good. So here, basically, we're talking about criminal responsibility. Very good. So you will first take a psychiatric evaluation. Yes, you will refer the patient for psychiatric evaluation. In fact, section 84 of IPC that, embodies McNaughton rules. In fact, now, it is replaced by Bharati Nyaya Sanhita, section 22. We have discussed, in the videos as well, that nothing is an offense which is done by a person who at the time of doing it, by reason of unsoundness of mind, is incapable of knowing the nature of the act, or what he is doing, what is either wrong or contrary to the law. So if this is proven, that he will not be criminally responsible for the act. So yes, a psychiatric evaluation is important. I hope this is clear to everyone. So the right answer to this question is take a psychiatric evaluation. Yes. So let's discuss the last question again. You will discuss this in forensic as well. What is covered under POCSO Act 2012? Now this, I'm sure, would be a fairly easy question. Tell me, what is the answer here? What is covered in POCSO Act? So again, we have also discussed, briefly in the videos, it is Protection of Children from Sexual Offense Act 2012. So basically, it provides a framework for protection of children. So please remember, it's a gender neutral act. It involves both, male and female. So what is the right answer here? This act. So children less than 18, yes, all children under 18 years of age. So that is the correct answer. So many questions, in fact, in the past have been asked from POCSO Act. So remember, here also a question was asked. I hope it is clear to everyone. Right. So again, these were the questions which we could get. Any changes, any newer questions, if you are able to remember, just message under this video. I'll see the comments, and if there is any possible changes, we'll let you know. So again, thank you so much. So this is the time, to relax, do things which you have been, waiting to do for so many time. So all the very best for the results. And again, as I always say, keep smiling, keep moving forward. Thank you so much. Thank you.
Good evening, everyone. Dr. Azam here, your anatomy faculty at PrepLadder. And now we are going to see the question that has been asked in the NEET PG 2025. And now we are going to see all the questions which has been asked in that one so that you will get an insight into the questions asked and what will be the answers for that one, sir. Fine. So let's get started with the very first question here. The image below highlights the jugular foramen. Which of the following does not pass through this foramen? So we have learned in detail about the jugular foramen, my dear friends. The nerve which are going to pass through the jugular foramen here will be the 9th, 10th and 11th nerve. 9th, 10th and 11th nerve is going to pass from here. So the 9th nerve here, the glossopharyngeal nerve is going to pass from here, and then the vagus nerve here, as well as the accessory nerve is going to pass from here, but not the hypoglossal nerve. So this will be the answer here. Hypoglossal nerve is not going to pass from here. It is going to pass through a separate canal, and that canal will be the hypoglossal canal. Hypoglossal canal. Now, apart from this, we also have learned in the jugular foramen that inferior petrosal sinus as well as sigmoid sinus are also going to pass from there. Fine. So you got to remember all the structures in order. First, there will be inferior petrosal sinus, then the 9th nerve, 10th nerve, and 11th nerve, and then you'll be having the sigmoid sinus. So except which one here? Yes, you can clearly see that it is hypoglossal nerves. Then after that, moving on to the next question, my dear friends, the image shows a congenital cardiac defect. Abnormal development of which branch of the aortic arch will lead to this defect? Development of the arch arteries, and in that arch arteries, we have seen that there will be like totally 6 arch arteries on either side. Now, first of all, if you look at this image, what is the defect here? The defect here will be actually the, yes, patent ductus arteriosus. Patent ductus arteriosus. Now, the ductus arteriosus is going to be derived from 6th arch artery, and that to the left one. The left 6th arch artery is the one which is going to form your ductus arteriosus. Now, if it is going to remain patent over here, yes, of course, it is the defect of the left 6th arch artery. The left 6th arch artery there. Fine. Then after that, the next one here, which is the correct nerve supply to the muscles labeled as A and B over here. Now, in this diagram, if you observe both the muscles here, they are the digastric muscles. The anterior belly of the digastric and the posterior belly of the digastric here, sir. So this B here will be the anterior belly of the digastric, whereas the A here, this one here will be the posterior belly of digastric. Fine. Now, what will be the nerve supply of this one? The best way to answer this one, try to recall in embryology when we learn about the pharyngeal arches. Pharyngeal arches. There are totally 6 pharyngeal arches. Out of that, the 5th one will degenerate. Fine. Now, for this pharyngeal arches, the nerve supply to that one, the nerve supply to the pharyngeal arches will be remembering that as like 5, 7, 9, 10. 5, 7, 9, 10. Yes, during our videos, I have told you the nerve supply to the pharyngeal arches will be 5, 7, 9, 10. So therefore, the first pharyngeal arch will be actually supplied by mandibular nerve, and 5, 3. That is the mandibular nerve over there. And my dear doctors, please remember that the first arch is the one from where the anterior belly of digastric. The anterior belly of digastric will be, yes, derived from there. And the second arch is the one from where the posterior belly of digastric will be derived from where. So therefore, what is going to happen? The anterior belly of digastric, this one will be supplied by the mandibular nerve. So B has to be supplied by the mandibular nerve. Whereas the posterior belly of digastric has to be supplied by the facial nerve. So here, the third option is actually correct, but we just need to do it like vice versa here. This is actually the, yes, anterior belly of digastric will be supplied by what, sir? It will be supplied by mandibular nerve, whereas the posterior belly of digastric, that will be supplied by the facial nerve, sir. Take it now. Then the next one here, a patient presents with the meralgia paresthetica. Based on the diagram, identify the nerve involved in this condition. We have seen in the image how to identify the nerves, guys. Okay. Now in this image, whatever nerve which is going to begin from the the nerve which is going to begin from the L1 here, this one will be the ilio-hypogastric and ilio-inguinal nerve over here. Fine. So ilio-hypogastric nerve, then the ilio-inguinal nerve. Then the B here, which is coming from L1 and L2, this is the genitofemoral nerve here. And then finally this C here, this one which is coming from L2 and L3 here, that is actually the lateral cutaneous nerve of the thigh. And yes, the nerve which is marked D here, that is a femoral nerve. Now here, the one which is coming from L2 and L3, that is your lateral cutaneous nerve of the thigh. That is the one which will be compressed beneath the inguinal ligament, leading to meralgia paresthetica. Meralgia paresthetica. So therefore, according to the options given here, it will be the C here, sir. Okay. Fine, sir. Next one. A patient presents with the ankle pain and the swelling after a forceful eversion injury here. Okay. Mandibular was not in the option. Okay, we'll look into that one. Just please drop the message. A patient presents with the ankle pain and swelling after a forceful eversion injury. There is an eversion injury there. And based on the mechanism of the injury, which ligament is mostly likely to be damaged here? So near the ankle joint, you know that there will be a medial ligament and then there will be the lateral ligament. And on the medial side, we'll be having the deltoid ligament. Yes, of course, the deltoid ligament will be involved here. And even you can actually eliminate the options from here. If you look at the other options, all of them are actually having the talofibular here, calcaneofibular here, and the posterior talofibular. That means these are the ligaments which are belonging to the lateral ligament of the ankle joint. Lateral ligament, which is also referred to as collateral ligament. So that is actually belonging to the lateral ligament that is not involved here. During the eversion injury, remember the deltoid ligament is the one which is actually involved here, my dear friends. Okay. Now moving on to the next one. During hyperextension, the long head of the triceps get detached from the site. Yes, what is the site here? If you remember, when we learned about the muscles of the arm, anterior compartment and the posterior compartment, I told you very clearly, suppose if this is the glenoid cavity, there will be a supraglenoid tubercle and then there will be infraglenoid tubercle. Now from both the glenoid tubercle, there will be the long head originating. From the supraglenoid tubercle, it will be the long head of biceps, and from the infraglenoid tubercle, you'll be actually having the long head of triceps. So if long head of triceps is getting detached from here, that is obviously from the infraglenoid tubercle here. So it can't be supraglenoid tubercle. Why? Because यहाँ से कौन सा वाला originate होता है? Long head of biceps will originate from here. Shaft of humerus, it can't be that one. Why? Because from here, it will be the medial and lateral head of triceps originating from there. Olecranon process पर तो क्या होता है? Triceps का insertion होता है. तो अगर यहाँ पर hyper extension में, in the hyper extension, if there is long head of triceps getting detached, that will be definitely the infraglenoid tubercles. Then the next one, a structure passing deep to the submandibular gland and curving around the inferior border of the mandible and is encountered during the neck dissection. Which of the following structure is most likely to be the one? Okay. So first of all, you have to remember two hints here. Number one hint here is that it is the structure passing deep to submandibular gland. And number two, that it is going to curve around the inferior border of the mandible. Now, out of the options which are given here, yes, my dear friend. Yes, many of you are answering B here. Next one, sir. Now, in this one, first of all, you can easily eliminate two options here. Trigeminal nerve, it cannot be the trigeminal nerve over here. Why? Because trigeminal nerve is way away from this one, submandibular gland and all, and it cannot be the labial artery. If you remember, when we learned about the facial artery is the one which is going to move obliquely in the face here, and then while going up, it is giving the branches to the lips here, superior labial and the inferior labial artery. Okay, so labial artery is also away from here, according to the question which is given here. Now, out of these two options, remember the better option here. Yes, out of these two, the better option here will be the facial artery here, sir, not the marginal mandibular nerve. Okay. Now, facial artery, we know that it will be lying in the submandibular region here. Okay. And then it is going to take a turn around the base of the mandible here. Base of the mandible, यहाँ पर turn होता है near the antero-inferior border of the masseter. So, according to this one, it will be actually the facial one, sir. Fine. Hypoglossal nerve was given in the option. Okay, I'll just make a note of this one. We'll try to correct it. Okay, 12th nerve was also given there. And there was an image given here. Fine, fine. Okay. There was an image given there. Fine. So I'll be including the image also. We'll be coming up, of course, with the exact questions here in the recall session. Fine, don't worry about that one. So image and then hypoglossal nerve was given in the option there. Fine. Achha, facial artery was not there. Dr. Javid is telling facial artery was not at all there in that person. Okay, fine. You just try to drop me the exact image which was given. I hope it is cadaveric image given. Okay, fine. It was not the artery, it was nerve. Fine. So we'll actually rectify this question. Don't worry about that one. I think there's so many changes required and we will be coming up with the exact question over there. Okay, ji. Fine. Thank you, Dr. Chaitanya. Cadaveric image was given there. Thank you. ठीक है. Artery was not there. Okay, fine. We'll totally eliminate those options then. Now, according to the options which were given here, it has to be like this one here. Otherwise, fine. No problem. I'll make this the changes required and I'll come back to that one. Fine. Now, which of the following best described as the normal vascular composition of the umbilical cord? This is like one of the easiest question, I think so. In umbilical cord, you'll be actually having the two arteries, both a right and left umbilical artery will be there. But when it comes to the vein, only left umbilical vein will be there. We have learned in embryology that there'll be two umbilical veins initially, right umbilical vein as well as the left umbilical vein, but the right will regress. It will be gone and only left is remaining. So we'll be having like two arteries and then there will be like one vein, sir. तो umbilical cord में दो arteries होती हैं and then one vein होता है. Facial artery was there. Okay, fine. Oh my God. So Dr. Madhya is telling that facial artery was there, but someone is telling facial artery was not there. Okay. Hypoglossal nerve was definitely there in the option. Dr. Zuhair. Fine. We'll include that one, sir. ये post surgical image था. Fine, thank you. Fine, thank you. We'll include that one. So fine. If you find like appropriate image there, please try to drop that one. We'll try to include in this one. Fine. चलिए sir. Now, which of the following organs does this epithelium most likely belong to? I think this is the most easiest question that you will come across. In NEET PG, when it comes to histology, mainly they'll be giving the questions from epithelium. We have learned this many times. अगर आप ये epithelium यहाँ पर देखोगे ध्यान से, you will be able to find like big cells here, which are resembling like, umbrella shaped cells, which are going to cover like multiple cells beneath that one. Multiple cells beneath that one here. So ये देखते ही आप identify कर सकते हो कि this one here will be the, yes, urothelium. It is actually the urothelium, the characteristic feature of that one. Fine. So therefore, my dear friends, it will be present in the ureter. Urothelium कहाँ पर होता है? Ureter, urinary bladder, they will be having the urothelium. Now in the gallbladder, trachea and intestine, yes, you don't find this epithelium over there. In the gallbladder, you'll be actually having that columnar epithelium with the microvilli. And then in the trachea, you'll be having pseudo-stratified ciliated epithelium. And again, in the intestine also, you'll be having the columnar epithelium, but not this one. So urothelium, definitely it will be there in the ureter here, sir. Fine. The image with the facial artery. Okay, there's a big debate on this, on that question. We'll come back with the exact question, sir. So by the way, my dear friends, these are all the questions which were given from the anatomy. I think this is the easiest paper of the NEET PG which was given. The feedback that we got from many of the students, and anatomy questions were like damn easy to solve with. And it's all like expected PYQs only. Pharyngeal arch artery se jahan se question aaya tha, one epithelium, one and all those things. I think you have answered this very well. God bless you all with a lot of success, my dear friends. All the best. Thank you all. Thank you.
Hello guys, how are you? I hope a burden on your shoulder have been relieved of. So this year the paper was very easy. No, I'll not say very easy, but it was easy. And all the questions were simple repeats, which we have already discussed in LRR. So the student who have read LRR, they were able to answer, I think, 100% of the question. And I hope this year you will get your dream branch as well. Yes, that's great. That's great. So without wasting your time, let's start. So remember, right now there is a disclaimer written that right now it is just a very short span. We have gathered the recall question. Some might be wrong, some might be right. So I need the help of all of you lovely students. Help me so that we can frame the correct answer so that in future your friends or your juniors can also be benefited from this session. Okay. So benralizumab, a direct question. It's a monoclonal antibody used in asthma, and benralizumab, it blocks interleukin-5 receptor. Interleukin-4 receptor is blocked by dupilumab, which we have discussed. Interleukin-1 receptor is blocked by anakinra, which is not used in asthma. It is used in rheumatoid arthritis. And TNF-alpha blocker are like infliximab, certolizumab. They are also given in rheumatoid arthritis. So next question, a woman underwent emergency LSCS. What is the drug of choice to prevent venous thrombosis? So yes, after surgery, the patient is not moving. There could be deposition of fibrin in leg veins and the female can develop DVT. Okay. Any question change was there? I think the language is almost same. So remember, after the delivery of a child, you can use any anticoagulant drug. During pregnancy, yes, heparins are the drug of choice. After delivery, you can use any of the following drug, but still, even in postpartum period, remember, the drug of choice is lower molecular weight heparin. But remember, warfarin can also be given. Aspirin and clopidogrel are antiplatelet drug. Antiplatelet drug are not given for DVT. They are rather given for MI and stroke. Okay, so the answer is good. A woman is diagnosed with migraine. That's great. Migraine topic. And she has a family history of heart disease or coronary artery disease. So migraine with some heart disease. Which drug you will go with? So previously she has been treated with sumatriptan. What is the drug of choice for migraine prevention? Remember, we have discussed propranolol is always the drug of choice for prophylaxis of migraine. And why this will be the drug of choice? Because the patient is having coronary artery disease. In coronary artery disease like angina and MI, we give beta blocker. They will have additional benefit in preventing coronary artery disease. So both migraine and coronary artery disease always go with propranolol or beta blocker. Great. Now, topiramate can be given, but propranolol is a better drug. Ergotamine is absolutely contraindicated. First, in coronary artery disease, sumatriptan or naratriptan, they are always contraindicated in coronary artery disease. Why? Because they produce vasoconstriction. It will further precipitate coronary artery disease. And these drugs are only given for acute attack of migraine. Remember, they are never given for prevention. Here, the question is asking you prophylaxis of migraine. So yes, it's a very simple question. Great. So chest tightness was given instead of coronary artery disease. Your point well noted down. Chest tightness. Okay. Instead of coronary artery disease, chest tightness was written. Okay. So next is a patient of tumor lysis syndrome. When tumor cells die, their purines, pyrimidines, and DNA, they come into the blood. And that purines gets converted into uric acid and the patient suffers from gout. We all know this point. That is why the patient is having elevated uric acid level. So we have given a drug pegloticase. I think this was a question. And we have discussed pegloticase and another drug was ruspuricase. These are the enzymes. And these enzymes we have discussed, they were known as uric acid oxidase enzyme. This is a straightforward question from our LRR. And uric acid oxidase enzyme converts this uric acid into a harmless molecule allantoin. Allantoin cannot deposit in joints. It cannot precipitate gout. So we have discussed the answer should be, see the name beta, see the name. Uric acid oxidase enzyme is the name. So what answer you should go with? Hydrolysis was there. Okay. Let's say there is an option of hydrolysis. Beta, my question from you student is oxidation of uric acid given in the option? Is oxidation of uric acid given in the option? Is this option given? Oxidizes uric acid? Because the enzyme name is oxidase enzyme. Was it given? Yes. Then the end of controversy is here. So go with it oxidizes uric acid because the name of the enzyme is uric acid oxidase enzyme. Great. So we are done. Urate inhibition is by probenecid, uricose, uric agents. We have discussed xanthine oxidase inhibitor, allopurinol, febuxostat. Okay, simple question, but it's a very repetitive question. A 12-year-old boy with a chronic kidney disease, CKD, with anemia. So we all know. So this question came 6 days back in FMGE exam also, and same options were there. So chronic kidney disease, we know there is deficiency of erythropoietin. Deficiency of erythropoietin will lead to anemia. So we have to give erythropoietin or any drug which ends with the word poietin like darbepoetin alpha. Okay, that was a direct FMGE question, which was asked 7 days before. That's great. Next question. Amiodarone primarily acts on which phase of cardiac action potential? Now, I want to tell you beta one thing. Remember, even the examiner questions. The reason is the answer of this question is very straightforward, but examiners sometimes have to read more sometimes. Okay, I'll tell you the reason shortly. So we know amiodarone is an antiarrhythmic drug and it's a potassium channel blocker. है ना? Class 3 drug, potassium channel blocker. And on action potential, remember this potassium channel, it mainly acts on phase 3 because here the potassium efflux happens. So if you give potassium channel blocker, what will happen? The heart will take more time to repolarize. So they will increase APD, action potential duration. So the answer of this question was, the answer of this question should be phase 3. But beta, in truth, we have discussed that amiodarone also blocks sodium channel. We have discussed it's a multi-ion channel blocker. It also blocks sodium channel. Remember, it will also affect phase 0. It will also affect phase 0. But it's a very wrongly framed question. But the answer should be phase 3. Okay, answer should be phase 3. Okay, because we keep under a group of potassium channel blocker. Next is a patient of GERD, gastroesophageal reflux disease. Again, a direct question from our revision LRR and RR session. Which drug helps in maintaining contraction or closure of lower esophageal sphincter and increases gastric emptying? We know these kind of drugs are known as prokinetic drug. Prokinetic means the drug which will increase, kinetic means motility of GIT. So yes, it's a very simple question. The answer was metoclopramide. Another drug I have already told you was domperidone. That is why when you go into the market, you find pantoprazole, domperidone, etc. Okay. This is a proton pump inhibitor. Pantoprazole. Vonoprazan is also a new drug similar to proton pump inhibitor. Sodium alginate makes a neutral covering over acid, and it is also used in GID, but here the answer is metoclopramide. Okay. So next is, what is the drug of choice for febrile seizure? My question from you, lovely student, is, beta, do you think the framing of question, the language of question was like this only? Or there was something written as child with high grade fever, something was written like this? Child with fever, because child with fever will lead to febrile seizure. Oh, okay. So what was the question, beta? A 6-year-old child. Okay. So I'll add all the points you will tell me. A 6-year-old child with high grade fever, was the child having any any convulsion, scissors, or body movement also in the question? Okay, scissor was given. Okay, scissor was given. So this was the language of the question. So yes, it points out to be febrile scissors. Yes. So the question is, yes, the examiner is asking about febrile scissor. And beta, the answer is very simple. In febrile scissor, either we give rectal diazepam or we give intranasal midazolam, two drugs we have discussed. Many times we have discussed. Great. Great. Rectal diazepam or intranasal midazolam. Direct question, no controversy. Next we have is a patient presents with following lesions, burning sensation eating spicy food. Which of the following drug is responsible for this condition? The answer is lithium. Remember, lithium is excreted in sweat, or sorry, saliva. And lithium can cause oral ulcers. Okay. So answer of this question is lithium. So hypertensive patient. Oral ulcer, I think image was given. Some oral ulcer image was given in this question. Okay. A hypertensive patient developed renal stone. Any type of beta renal stone was mentioned. Which type of renal stone? Dharma ma'am said beta blocker. I'll ask with the ma'am, but the answer is very well known side effect of lithium is oral ulcer. Because lithium, just like sodium, it's a younger brother of sodium, it is excreted out in saliva. So, okay. Okay. Now he was started on thiazide diuretic. We know thiazides are given in the treatment of calcium stone. And what is the reason why thiazides are given in the treatment of renal stone? Because they absorb calcium, they prevent excretion of calcium. So the answer is very simple, decrease excretion of calcium. Fine. Okay, can you tell me what was 3 months later he developed renal stones? Increase in citrate level. So it is increase in citrate level. No, they will not increase citrate level. Okay, he was already on hydrochlorothiazide and he developed stone. No, beta, hydrochlorothiazide, I don't think it will lead to calcium stone. It can be loop diuretics which can cause calcium stones, because loop loses calcium. It increases the risk of calcium stones. I don't think thiazide should be there. Okay. So citrate stone bhi nahi ho sakta. Thiazide, they don't increase citrate excretion. It reduces calcium excretion and increases blood calcium level. So the question was asking that is thiazide beneficial in the treatment of renal stones? Something was written like this. Or they were asking you, ये पूछ रहे थे कि thiazide से calcium stone हुआ है? नहीं, I agree. Patient is already on thiazide. Have they asked कि thiazide की वजह से calcium stone हुआ है? क्योंकि वो तो possible नहीं है. Okay, so the question I framed is correct. Okay, that's great. Chalo, let's move forward. So don't worry, we will ask other students also. We'll get back to you. अगर थाइजाइड पे कैल्शियम स्टोन हुआ है तो बेटा थाइजाइड तो कंटिन्यू रखना ही है आपने. थाइजाइड सिट्रेट का भी एक्सक्रीशन कम करता है, तो सिट्रेट स्टोन भी नहीं होगा. ऑक्सलेट का भी एक्सक्रीशन कम करता है, ऑक्सलेट स्टोन भी नहीं होगा. कैल्शियम का भी एक्सक्रीशन कम करता है, कैल्शियम स्टोन भी नहीं होगा. ओके, नो. So what is the drug of choice for prophylaxis of meningococcal meningitis? Yes, we have discussed. The overall drug of choice is ciprofloxacin. So if ciprofloxacin is not in the option, go with the answer rifampicin. So the direct question was rifampicin. Okay, we will get to that question. A patient presented with bowing of legs. So most common cause of bowing of leg, I think child was given, is rickets. And serum shows calcium जो है 7.2 है, that means calcium is low and phosphate is very high. Agreed? And elevated PTH मतलब patient is having hyperparathyroidism. Okay. So if a patient is having hyperparathyroidism, always give vitamin D supplementation, because we discussed vitamin D, it reduces PTH production. इट रिड्यूस पीटीएच प्रोडक्शन, और कैल्शियम सप्लीमेंट तो देना ही है बिकॉज कैल्शियम इज लो. So the answer out here is reduce PTH. Okay. CKD वाला बेटा question is different. We will come. We have already discussed. Okay. अच्छा CKD भी था. Yes, CKD can lead to hyperparathyroidism. We all know. Okay. Okay. CKD can lead to hyperparathyroidism. Which is the drug which is very simple question, many times discussed, preoperative and intraoperative management of pheochromocytoma. So we know in pheochromocytoma hypertension is there. Phe वाला ही ड्रग हमें ढूंढना है. Phe वाला कौन सा ड्रग होता है? फिनॉक्सीबेंजामीन. ओके. नो बेटा, गिव विटामिन डी. फॉस्फेट बाइंडर तो जीआईटी एब्जॉर्प्शन कम करते हैं ना. गिव विटामिन डी सप्लीमेंटेशन. नो डाउट इन दैट बेटा. ओके. A patient with HIV developed tuberculosis. When ART should be initiated? ऐसा कोई क्वेश्चन आया? फॉस्फेट बाइंडर दे सकते हो बेटा, बट पहले आपने विटामिन डी देना है. यू हैव, बिकॉज विटामिन डी रिड्यूसेस hyperparathyroidism, it reduces PTH secretion. Okay, no, better answer will be vitamin D, no doubt in that beta. Don't get confused. If you have marked by mistake phosphate binder, then it is a different thing, but the answer is vitamin D. Okay. So HIV तो सबसे पहले ATT स्टार्ट करना है. आफ्टर अ गैप ऑफ 2 वीक यू विल स्टार्ट ART, एंटी रेट्रोवायरल थेरेपी. वाई गैप क्यों होना चाहिए बेटा 2 वीक्स का? टू प्रिवेंट आइरिस सिंड्रोम. आइरिस होता था ना, इम्यून रिकॉन्स्टिट्यूशन, इन्फ्लामेटरी सिंड्रोम हो जाएगा अगर हमने दोनों ही इजी स्टार्ट कर दिए. सो इट वाज अ वेरी सिंपल क्वेश्चन, मेनी टाइम्स डिस्कस्ड. Okay, welcome back to that question. So another question of HIV with TB. HIV with multi-drug resistant TB. तो बेटा आज की डेट में वी हैव डिस्कस द ट्रीटमेंट ऑफ MDR TB एंड रिफैम्पिसिन रेजिस्टेंट TB हैज बिकम B-PAL रेजिमेन, है ना. B-PAL रेजिमेन. बेटा CKD में B-PAL रेजिमेन होना चाहिए, तो B-PAL M रेजिमेन हम देंगे. और मॉनिटर फॉर आइरिस, अगर ये एडिशनल वर्ड लिखा हुआ है तो ठीक है, नहीं भी लिखा तो भी ठीक है. सो द आंसर शुड बी A. ओके. ओके. Okay, even in rifampicin resistant TB बेटा we start B-PAL M regimen, क्योंकि आइसोनियाजिड हो या ना हो, सिर्फ रिफैम्पिसिन रेजिस्टेंट पे हम MDR TB का ट्रीटमेंट स्टार्ट कर देते हैं. वी हैव डिस्कस्ड दिस पॉइंट. ओके, दैट इज फाइन. Even if it is MDR or only rifampicin resistant TB, no problem. Answer will be same. B-PAL M stat. Okay. Next is a diabetic patient है. ये तो बड़ा सिंपल है, बार बार रिपीट हो रहा है सवाल तो, है ना. पिछले 5 साल से हर बार आ रहा है और बड़ा सिंपल सवाल है. अब मेटफॉर्मिन इंक्रिटिन बेस्ड ड्रग है, डायग्नोस्ड है उसे हार्ट फेलियर. तो कौन सा ड्रग देना है? तो हार्ट फेलियर में हम कौन सा ड्रग देते हैं? डायबिटीज वाला जो अप्रूव्ड है, SGLT2 इनहिबिटर. इन ड्रग के एंड में फ्लोजिन वर्ड आता है. सो द आंसर शुड बी एम्पाग्लिफ्लोजिन. वेरी सिंपल, नो कंट्रोवर्सी आउट हियर. ओके. देन अ पेशेंट ऑफ एट्रियल फिब्रिलेशन, ठीक है, हार्ट पे ऊपर एट्रियल फिब्रिलेशन हो रहा है. मिट्रल स्टेनोसिस है, ठीक है, मिट्रल वॉल्व भी बंद है. विद इन 4 आवर ऑफ सिम्टम ऑनसेट पेशेंट स्टेबल है. अगर पेशेंट अनस्टेबल होता तो कार्डियोवर्जन करते, ठीक है, सिंक्रोनाइज कार्डियोवर्जन. बट पेशेंट क्या है? स्टेबल है. तो हमें क्या करना है? AF को VF ना हो जाए, इसको प्रिवेंट करना है. सो इस केस में अब हमें लॉन्ग टर्म क्या ड्रग देना है? ऐसा ड्रग देना है जो AV नोड को ब्लॉक करे. और AV नोड को कौन से ड्रग ब्लॉक करते हैं? ABC, एडिनोसिन बीटा ब्लॉकर और कैल्शियम चैनल ब्लॉकर, है ना. सो वी हैव टू कंट्रोल वेंट्रिकुलर रेट बाय गिविंग बीटा ब्लॉकर या फिर वेरापामिल देना है हमें. सो द आंसर इज, सबसे पहले क्या करना है? वेंट्रिकुलर रेट को प्रिवेंट करना है, क्योंकि VF हो गया तो पेशेंट की सडन डेथ हो जाएगी. ओके, फाइन. फाइन. Okay, Naveen ji, I'll get back to your question. A patient with paroxysmal PSVT required treatment for prevention. ऐसा कोई क्वेश्चन था? बेटा, I'm seeing your comments. I'm seeing your comments. LA thrombus was also given ना? No problem बेटा. सबसे पहले आपको वेंट्रिकुलर रेट कम करना है और उसके बाद आपने पेशेंट को एंटीकोगुलेंट ड्रग देने हैं लाइक वॉरफरिन. पहले वेंट्रिकुलर रेट कम करना है, उसके बाद आपने पेशेंट को वॉरफरिन देना है, क्योंकि फिब्रिन डिपोजिशन हो सकता है. ओके, I'll better check with the other faculties why they are telling you about the phosphate binders, okay? Because I have got a question of hyperparathyroidism. मुझे CKD नहीं मिला. मेरे question में student have told me patient is having hyperparathyroidism. अगर hyperparathyroidism word है, then you will go with vitamin D. Then you will always go with vitamin D. If the question is having CKD, then the options might change, okay? CKD था, then I'll get back with the right options. एक बार फिर मैं consider करूंगा कि क्या question था. Fine. Hyperparathyroidism है, then go with first vitamin D always. Now एक patient है PSVT का treatment के लिए remember adenosine तो हम acute attack of PSVT में देते हैं. प्रिवेंशन में क्या देते हैं? या तो बीटा ब्लॉकर या कैल्शियम चैनल ब्लॉकर. सो कौन सा आंसर होगा इसका? यस, द आंसर शुड बी वेरापामिल फॉर दिस. ओके, वेरापामिल वाज द आंसर. इसका एडिनोसिन नहीं है बेटा, एडिनोसिन एक्यूट अटैक में देते हैं. नाउ नेक्स्ट इज अ पेशेंट ऑन हेलोपेरिडोल एंटीसाइकोटिक ड्रग है. 2 साल के बाद आफ्टर 2 years ही डेवलप्ड ओरोफेशियल डिस्काइनेसिया, मतलब एक्सेसिव मूवमेंट हो रही है. सो मैंने आपको बताया था जो एक्स्ट्रा पिरामिडल सिम्टम लास्ट में आता है, लास्ट का मतलब होता है टार्डिव. टार्डिव मींस लास्ट टू अपीयर. और एक्सेसिव मूवमेंट डिस्काइनेसिया, डिस्काइनेसिया है ना, एक्सेसिव मूवमेंट. सो आंसर इज वेलबेनाजीन हम ट्रीटमेंट में देते थे जो डोपामिन का लेवल कम करता था. सो वी हैव डिस्कस दिस क्वेश्चन मेनी टाइम्स. ओके, नेक्स्ट इज अ पेशेंट ऑन सैल्ब्यूटामॉल एंड इप्राट्रोपियम. ये दोनों ड्रग तो हम एक्यूट अटैक ऑफ एस्थमा में देते हैं. एक शॉर्ट एक्टिंग बीटा 2 एगोनिस्ट है, एक शॉर्ट एक्टिंग मस्करीनिक एंटागोनिस्ट है. पर अब भी पेशेंट को क्या हो रहे हैं? रात को एस्थमा के अटैक पड़ रहे हैं. सो डोंट यू थिंक यू हैव टू स्टार्ट अ ड्रग फॉर प्रिवेंशन ऑफ एस्थमा, ताकि रात को उनको एस्थमा का अटैक ना पड़े? तो बताओ आंसर क्या है? लीवोसैल्ब्यूटामॉल था, ठीक है, नोटेड डाउन बेटा. लीवोसैल्ब्यूटामॉल था, सैल्ब्यूटामॉल नहीं था. Okay, Dr. Diksha, I'll come back to that question. CKD with hyperparathyroidism. Let me finish all the question first. Okay. So inhalational corticosteroid था. Yes. Inhalational corticosteroid था ऑप्शन में. Yes. और लाबा लॉन्ग एक्टिंग बीटा 2 एगनिस्ट था ऑप्शन में. Yes. So we have discussed they are the drug of choice for. Yes, दिन में एक अटैक तो पड़ ही रहा है, तो पेशेंट को मॉडरेट वेराइटी ऑफ क्रॉनिक एस्थमा हो गया. मॉडरेट वेराइटी ऑफ क्रॉनिक एस्थमा है तो इनहेलेशनल कॉर्टिकोस्टेरॉइड प्लस लाबा हमें देना ही देना है. ठीक है, सो द आंसर इज बी. वेरी गुड. अ पेशेंट वाज गिवन अ मसल रिलैक्सेंट आफ्टर विच ही डेवलप्ड एरिथमिया, फ्लशिंग फेस, डिक्रीज ब्लड प्रेशर. क्यों हो रहा है बेटा? हिस्टामिन रिलीज हो रहा है, इसलिए हो रहा है. हिस्टामिन से एलर्जी और वेजोडाइलेशन होती है. Yes, beta Diksha, you are absolutely right. LABA with ICS option was there. That was a correct answer as we have marked it also. So which drug is most likely to be responsible? So answer we all know is एट्राक्यूरियम, क्योंकि एट्राक्यूरियम से हिस्टामिन रिलीज होता है, सिस एट्राक्यूरियम से नहीं होता. ठीक है. Next we have is a HIV positive mother diagnosed in the 3rd trimester. She has a viral load of 1200. ये हमने डिस्कस किया LRR में. रिमेंबर, अगर फीमेल को वायरल लोड 12,000 से ज्यादा होता है, ओके, पैनक्यूरोनियम वाज देयर. ओके, इंस्टेड ऑफ दैट पैनक्यूरोनियम वाज देयर, नो प्रॉब्लम. फाइन, नोटेड डाउन बेटा. सो वायरल लोड अगर 1000 से ज्यादा होता है, हमने LRR में डिस्कस किया है, तो ये हाई रिस्क इन्फेंट है. और हाई रिस्क इन्फेंट में हम क्या देते हैं? नेविरापीन तो देते ही हैं, साथ में जिडोविडीन भी दे देते हैं. सो आंसर तो ये हो गया. बट हमें एक बात याद रखनी है, हमें कब तक देना है जिडोविडीन और नेविरापीन? नॉर्मली हम 6 वीक्स तक देते हैं. इफ द फीमेल इज हैविंग नो ब्रेस्ट फीडिंग, अगर फीमेल ब्रेस्ट फीडिंग नहीं कर रही बच्चों में, तो 6 वीक्स तक देना है जिडोविडीन नेविरापीन. बट अगर फीमेल मदर एक्सक्लूसिव ब्रेस्ट फीडिंग कर रही है, तो हमें 12 वीक्स तक देना है. सो द आंसर इज जिडोविडीन प्लस नेविरापीन. स्मोलॉल बेटा हम प्रिवेंशन के लिए नहीं दे सकते पीएसवीटी में. स्मोलॉल बहुत ही शॉर्ट एक्टिंग बीटा ब्लॉकर है, वो सिर्फ 10-15 सेकंड के लिए, मतलब 10-15 मिनट के लिए काम करते हैं. उसे हम इमरजेंसी में ही देते हैं, लॉन्ग टर्म प्रिवेंशन में नहीं देते हम स्मोलॉल. ओके, आई होप इट इज फाइन. So this is all about our pharma question. So I'll get back with the question of CKD and hyperparathyroidism. Remember, if only hyperparathyroidism was there, then go with vitamin D and calcium. And if CKD is there, then you will go with first calcium with phosphate binders. If that option is not there, then go with calcium with vitamin D. I hope the controversy is solved. Okay, controversy is solved. Beta, malignant hyperthermia tha ek option mein. Just give me 1 second more. So here malignant hyperthermia was also there, but it is not the feature of malignant hyperthermia. बिकॉज मैलिग्नेंट हाइपरथर्मिया में तो क्या होगा, बॉडी टेम्परेचर रेस्ट होगा, कोला कलर्ड यूरिन होगा, मायोग्लोबिन मिल रहा होगा, एक्सट्रीम रिजिडिटी होगी. आंसर यही रहेगा बेटा, डिस्काइनेसिया है ना, और 2 साल के बाद हो रहा है, तो टार्ड मींस 2 साल के बाद. ओके, सो क्या है बेटा, एडिसन्स डिजीज पे भी सवाल है कोई? अच्छा, देयर वाज अनदर क्वेश्चन ऑफ मैलिग्नेंट हाइपरथर्मिया. कैन एनी स्टूडेंट हु कैन रिकॉल मी? क्या था क्वेश्चन बेटा मैलिग्नेंट हाइपरथर्मिया पे? मैलिग्नेंट हाइपरथर्मिया का कोई ड्रग दिया हुआ था, सक्सिनाइल कोलिन, हेलोथेन, एट्रोपिन या लिग्नोकेन. ट्रीटमेंट में तो हम क्या देते हैं, डेंट्रोलिन सोडियम देते हैं, मसल रिलैक्सेंट. ओके, दिस वाज अ स्ट्रेट फॉरवर्ड क्वेश्चन. यस, सो थैंक यू वेरी मच. सो द नेक्स्ट, ओके, गुड बाय. नाउ रिलैक्स फॉर अ मोमेंट. थोड़े दिन रिलैक्स करो, इंट्रोस्पेक्ट करो, बिकॉज अभी आपका जो माइंड है बस क्वेश्चन 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 ही चल रहे होंगे. अपने आप को रिलैक्स करिए and leave, rest everything to your Almighty. Whatever the result will be, don't be afraid, don't be very happy. Just keep your mind very calm. Okay, so best wishes always.
Sir, you are live.
So hello friends. So we are having now a forensic medicine discussion for NEET PG. Hello everyone. How was the exam? Yes. Okay. So now we are live with forensic medicine. Okay. Fast. Don't worry. Now the first question was this: a patient is brought to the emergency department with acute onset of severe abdominal pain. Yes, everyone. Throat pain, throat irritation, vomiting and purging that contain blood and bile and diarrhea that initially appeared bloody but later becomes colorless, odorless and rice watery stool. Yes, without any doubt, it is none other than, yes, my dear friend, acute arsenic poisoning. It is acute arsenic poisoning. This I discussed. Everything was directly from my notes, my dear friend. Yes. So this was a clear-cut picture of acute arsenic poisoning. I mentioned here we have the rice watery stool, which resembles the cholera. And there's a throat pain, vomiting and purging. This was given exact, my dear friend. Yes, it was given exactly in the PrepLadder notes. Yes. Okay, the second question. A 16-year-old girl and a 20-year-old boy undergo medical examination following allegation of rape made by girl's parents. The girl states the sexual act was consensual and no injury are found on examination. According to the law, what is the legal status of consent in the case? Yes, consent is invalid, my dear friend, because the girl is below 18. That's a 16 year of age. Yes. So it is a statutory rape. And friends, what I'm telling you, every question ke baad I'm attaching my slide of the PrepLadder also. That's why we can see all the questions were directly from notes. Okay. So this was the slide. You can see it is a 63 BNS and it is a statutory rape. What is a statutory rape? With consent, if your age is below 18, it is a statutory rape. So anyone who is below 18, doesn't matter consent is taken or not, it will be a statutory rape. So here answer is consent is invalid. Yes, very good. Yes. Now the protection of child from sexual offense, the POCSO Act covers which of the following group? Girls below 18, all children below 18, girls below 16, all children below 16. This was given as it is, my dear friend. This was a PrepLadder slide. You can see in the notes it was given. The POCSO Act, the protection of child against sexual offense, is for all children below 18. So here answer will be all children below 18. That's a B answer. Yes. Yes. It was B answer. All children below 18. Third question done. So this was a POCSO Act. This was given as it is in my PrepLadder slide. Yes, my dear friend. Okay. Now, sir, during autopsy, yes, a body shows curved scratch mark over the right angle of mandible and the 3 group bruises on the left side of the neck below the thyroid cartilage. Additional bruises over the head, posterior shoulder, back of the trunk and the hip crest. That's the iliac crest was given. Fracture of the superior thyroid was there. Here answer is none other than throttling. Yes. And even if you see the notes, which is crystal clear, this was the picture of PrepLadder notes in the throttling. You can see the abrasion, which is crescentric and fingernail. Yes. You can see the multiple bruises. You can see the petechial hemorrhages. The face is congested. Yes. Wow, my dear friend. Beautifully done. So this was none other than throttling. Yes. So this picture is given in the PrepLadder notes. Yes. It's a 6 penny bruise or multiple bruises are explained in this one. That is very simple. Yes. What is the Jasko phenomena? Anyone give me this answer? What is the Jasko phenomena? Anyone give me this answer? Yes, anyone? What is the Jasko phenomena, which I explained in the PrepLadder notes? Pura बढ़िया से explain किया है. Anyone? Anyone? What is the Jasko phenomena? A, B, C, D. Tendon reflex, seeping of the blood, clotting of blood after death, gapping of wound along skin tension line. Yes. Yes, Thriller absolutely right. Muller absolutely right, beta. बहुत अच्छा beta. It is a tendon reflex. It is a tendon reflex occurring after death. Or this was also well explained in this PrepLadder notes. You can see this is Jasko phenomena. It's a tendon reaction. It is striking the lower 1/3 of the quadriceps femoris, causes movement of the patella upward. That is a Jasko phenomena. And this is PrepLadder notes. The question number 5 directly coming from the PrepLadder notes. Yes. Okay, Jasko phenomena. Yes, 5th is done. An adult patient is involved in the high-speed road traffic accident at a normal CT scan. Now, Doctor, here the catchy point is normal CT scan on admission, but died within 3 hours. Autopsy reveals retraction ball. This is a catchy point. Retraction ball, which is given in the PrepLadder notes with petechial hemorrhage in the corpus callosum. What is the most likely diagnosis? Here it is a option are diffuse vascular injury, countergroup cerebral contusion, intracerebral hemorrhage, or someone says like diffuse brain injuries are given. But here answer is diffuse axonal injury. Here answer is diffuse axonal injury. And Dr. You will see the catchy point, my dear friend. You will see the catchy point. This is the diffuse axonal injury, my dear friend. This is given in the PrepLadder notes with retraction bulb or retraction ball, which is a transected axon. Every line is directly, my dear friend, every line is directly from PrepLadder notes, my dear friend. Every line, मैं फिर बोल रहा हूँ, हर line PrepLadder के notes से directly आई है. आठों के आठों सवाल. Yes. The next one. This was a little bit catchy question or tricky question, I would say. A man kills his office colleague and later claims that he was experiencing delusion of persecution and other psychotic feature at the time of act. He now asserts that he is not guilty by reason of insanity. What is the most appropriate next step under medico-legal protocol? Now, sir, if he claims, yes, if he claims that he is experiencing delusion of persecution, the best answer will be refer him for psychiatric evaluation. Refer him for psychiatric evaluation. But if you get a catchy point, he was having or he was diagnosed to have paranoid delusion or disorganized speech, then he should be declared not to be guilty and released immediately according to McNaughton rule. According to McNaughton rule, which is 22 BNS. Again, I'm telling you, my dear friend, what is the catchy point here? If only he claims he was experiencing delusion of persecution and other psychotic feature, and he was not diagnosed, then the answer should be refer to psychiatric evaluation to assess if he is fit for trial. But if he was having a disease of paranoid delusion or disorganized speech, the answer will be according to McNaughton rule. He is not responsible, to declare him not guilty and release immediately. So these are two important catchy points. Just be careful, my dear friend. Is it clear, beta? Is it clear? So just see this one. This is a very, very important catchy point. Yes or no, my dear friends? Okay. Again, I'm telling you, if he claims he was experiencing delusion of persecution and other psychotic feature at the time of the act, the answer should be refer for psychiatric evaluation to assess if he is fit for trial. But if he is diagnosed to have paranoid delusion and disorganized speech, he should be declared not guilty. That says 22 BNS. Okay. No, anyways. So here, this is McNaughton rule. McNaughton, how would you remember? Mac naughty. You become naughty at the age of 22. So insane is not responsible. Yes, no diagnosis was given. If no diagnosis was given, then you have to refer it to the psychiatric assessment. Okay. But if the diagnosis was given, the answer will be the fourth one. That is, he is not guilty. Okay. Okay. I told you both the scenario. Now, sir, this is the question. The last one. A 68-year-old female present with breathlessness, declining health, and is found to have multiple metastases. She is awake, alert, and visibly anxious. The medical team assesses that aggressively chemotherapy, radiotherapy, ICU care, and mechanical ventilation would not improve her condition and may cause harm. मतलब कुल मिला के सब कुछ कर लोगे तो भी उसको फायदा नहीं होगा. Actually, nothing is going to be done. Now, the patient daughter insists on pursuing all the possible life-prolonging measures, including ICU admissions. Yes, the daughter is emphasizing on this particular point. Now, what is the most appropriate next step for the physician in the managing this case? Tell me, dear. What is the answer? Convene a family meeting and consider the patient values, preferences, and goal of the care. Okay. Admit the patient to ITU and initiate aggressive life prolonging treatment. Discharge the patient and shift to the home-based palliative care and start a placebo treatment. Yes. Tell me. Tell me. Placebo to decrease anxiety? No, beta. No. No. Yes. Here, what is the best answer? I'm telling you. It's actually what I'm telling you. It is an emergency condition where no consent is needed. Here it is an emergency condition. No consent is needed. That is a 30 BNS. That is 30 BNS. Now tell me. Yes, anyone. Discharge the patient and shift to the home-based palliative. Actually, C option नहीं था. Mac is saying C option नहीं था. देखो डॉक्टर साहब, जो बच्चे बोल रहे हैं कि if the patient C, the option C was there, अगर पेशेंट के अगर इसमें बोलते हो कि डिस्चार्ज द पेशेंट, अगर ऑप्शन सी था, देन द बेस्ट आंसर विल बी ऑप्शन सी. ओके, द डिस्चार्ज द पेशेंट शिफ्ट टू द होम बेस्ड पैलिएटिव केयर, दैट्स अ हॉस्पाइस केयर. बट if option C was not given in option, then we can go for option A. But according to many students, the answer is option C, because in emergency condition, we don't require the consent. We can shift to the, yes, we can discharge the patient and home-based palliative care or hospice care can be given. So if this was the option, this was the right answer, option C. So my dear friend, this is all about the recall session. Okay. Instead of C, it was convince attender. No, my dear friend. Actually, we already tried to convene the attender, but they are emphasizing, they are insisting on pursuing all the possible life prolonging measures. That means A is not the best answer. The best answer will be C. That is a palliative care. That's a hospice care. But if C was not in option, then we can go for convene a family meeting. Okay. So if only discharge was given, then that is not the right answer. Only discharge was given, that is not the right answer, but palliative treatment or hospice care was given, that will be the best answer. So dosto, anyways, because the condition is very simple, in emergency, we don't require any consent, my dear friend. So we can go for this treatment. Anyways, my dear friend, आपका लंबा सेशन नहीं लूंगा क्योंकि आप अभी बहुत थके हुए हो. बेस्ट विशेस फ्रॉम माय साइड फॉर द एग्जाम रिजल्ट. और बेटा सब पास हो जाओ. हाँ, ए बी हो सकता है सर. हाँ, अगर ए हो सकता है, सी इज नॉट गिवन इन ऑप्शन कन्वीन, बिकॉज palliative care is given, that's a hospice care is given, that is the best answer, C. But if C is not given as a palliative treatment, then we can go for A. Okay. Acha, I don't think this is an emergency. Actually, it's a multiple meds and everything is done, my dear friend. Mechanical ventilation would not improve her condition. So placebo, no, placebo is not required, my dear friend. Okay. So anyways, yes, hospice was there. The palliative care was there. Then the best answer will be C. Admit the patient to ICU and initiate aggressive. No, dear. Actually, the one line is written, that is ICU care and mechanical ventilation would not improve her condition and may cause harm. ये देखो एकदम साफ लिखा हुआ है. These condition can cause harm. So that's why we don't require B1. Okay. Anyways, if palliative care or hospice was not given, the answer will be A. Otherwise, the answer will be C. Anyways, my dear friend, 8 questions were for forensic medicine, and we can go. These are some like lengthy question, but very, very easy one. Okay. So good luck, goodbye for your exams, result, and best wishes, my dear friend. Every question was directly from PrepLadder notes. Okay. Best wishes, my dear friend. Good luck.
live.
Hi guys, welcome to this session. I heard that the paper was good and you people really did well. And most of the questions were there from surgery. And topics were previously was PYQs and PYTs. So let's straightforward start the questions. And please give your feedbacks. First question, a 43 years old female presents to OPD due to changes in the breast and a lump in breast as given below. What is the diagnosis? So guys, can you tell me what is the diagnosis? Yes. So what is the diagnosis? Right. So everybody is correct. You can see here in this image, you can notice that this patient is having purity orange, right? So if there is only purity orange, it is T4B, right? And if the patient is having redness also, inflammatory changes are also there in the breast. Inflammatory changes are involving more than 1/3 of the breast skin or more than 33% of the breast skin. In that case, it is T4D. So here, there is only purity orange. This patient is having only what? Purity orange. So since patient is having only purity orange, so this is what? T4B. So this is T4B. So options were T3, T4B, CD. Okay. So T3, it was T3, T4B, T4C, T4D. Guys, can you tell me what is T4A? Whenever there is involvement of, yes, chest wall. And you know chest wall means ribs plus intercostal muscles plus serratus anterior. याद करने का तरीका क्या होता है? T4A, A का मतलब होता है अंदर, B का मतलब है बाहर. So whenever there is involvement of breast skin, there is ulceration, there is edema including purity orange, satellite nodules, this is T4B. And what is T4C? When both T4A and T4B is there. And what is T4D? It is inflammatory breast cancer. So T4D is inflammatory breast cancer. Why this is not inflammatory breast cancer? We discussed that. We discussed that what? There is no redness. So what is the correct answer, guys? It is T4B. Clear? Next question. Easy question. It is one of the easiest question and it's a repeat question. You can notice that here. What in this chest in this X-ray, you can notice that there are multiple bowel loops on the left hemithorax. On the left side of hemithorax, there are multiple bowel loops. You can see the question. Neonate was brought to the emergency with severe respiratory distress. Severe respiratory distress. Severe respiratory distress. Clear? And shortly after birth, admitted to ICU within 24 hours. Chest X-ray shown below. What is the most likely diagnosis? Okay, somebody wants to say Abhijit Muhammad that sir, breast was inflamed. So easy, guys. See, if there is redness or there is inflammation of the breast and it is involving more than 1/3 of the breast skin, obviously it is T4D. I explained. Agar inflammation hai, it is involving more than 1/3 of breast skin, then it is inflammatory breast cancer. तो T4D हो जाएगा. And if inflammation is not there, उस केस में क्या हो जाएगा? उस केस में हो जाएगा T4B. Nipple retraction was there. Okay. Retraction of nipple was there. Let me tell you, nipple retraction doesn't affect the stage. तो nipple retraction है, नहीं है. Pectoralis major का involvement है, नहीं है. Involvement of pectoralis major, minor, nipple retraction, this is not going to affect the stage. So it's not going to affect the stage. Clear? So here, जैसा question आया होगा, अगर redness है, it is inflammatory breast cancer. नहीं है, it is T4B. So here you can notice that there is herniation of small bowel in left hemithorax. आपको दिख रहा है multiple bowel loops in left hemithorax. So obviously, what's the diagnosis? The diagnosis is congenital diaphragmatic hernia. So here, what is the diagnosis? Diagnosis is CDH. And all of you know that what is the most common type of CDH? The most common type of CDH is Bogdanic hernia. So one easy question for all of you. One easy question, guys. Can you tell me what is the most common bowel herniated in Bogdanic hernia? Yes. Sumaya, Smile a Day, Anmol, Velmurgan, Raksha, Darshan, Niharika Jaiswal. Everybody is correct, guys. So can you tell me? Can you tell me what is the most common bowel herniated in congenital diaphragmatic hernia? XYZ, Rushil, doctor. Okay, I will discuss faster, Aditi. Don't worry. It is small intestine. So there is herniation of small intestine. That's the most common organ herniated. And you know that there is another congenital diaphragmatic hernia that's known as Morgagni hernia. And in Morgagni hernia, you know that in Morgagni hernia, there is herniation of which colon? In Morgagni hernia, there is herniation of transverse colon. There is herniation of transverse colon. Transverse colon. Easy? So there is herniation of transverse colon. Doesn't matter. Retraction of nipple is not going to affect the stage. Okay. Next, a 32 years old male presented with difficulty in swallowing and regurgitation. Barium swallow image is given below. What is the gold standard for diagnosis? Guys, I know that you people are tired, so we will be just discussing question and answer. Don't worry, right? What is this? You can see here, this is rat tail. And if it is rat tail, guys, tell me the diagnosis. Yes, okay, yes, we are doing faster. Tell me the diagnosis. This is achalasia cardia. So you can see on barium swallow, there is rat tail, pencil tip appearance, bird beak appearance. This is achalasia cardia. And for achalasia cardia, you know what is the investigation of choice? What is the gold standard investigation? The gold standard investigation is manometry. The gold standard investigation, that is manometry. Clear? So here the correct answer is B. Okay, correct answer is B. That's manometry. Now see this question. Easy question. Multiple times this question was asked. Identify the fistula according to Park's classification. So what are the types? Intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. Inter means in between sphincter. Trans means through the sphincter. Supra matlab above. Extra matlab outside the sphincter. तो इसमें देखिए which one. If you see this one, which is between, ये किसके बीच में travel कर रहा है? This one, this is between internal and external sphincter. So if it is between internal and external sphincter, तो क्या होगा? It is intersphincteric. So if it is between sphincters, intersphincteric, above sphincter, supra, outside sphincter, extra, और अगर sphincter को traverse करके जाएगा, yes, traverse करके जाएगा, that is transsphincteric. So here जैसा image दिया हुआ है, according to the image, it will be obviously, it will be intersphincteric. So it is intersphincteric. Okay, next. Guys, see this question, easiest. A 30 years old female was brought to the emergency room after fire. On examination of lower limb, full thickness burns and deep partial thickness burns were present, involving it circumferentially. Procedure was performed as given below. Identify the procedure. First, you tell me, what is the problem here? ये कौन सा degree burn है बोलिए? Almost whole skin is involved. So which degree? Almost whole skin is involved. Okay, ऐसा थोड़ा मिलता जुलता question था. So whenever there is involvement of almost whole skin, this is third degree burn. And if it is circumferential burn, what you have to do, you have to prevent compartment syndrome. And to prevent compartment syndrome, हम लोग क्या करेंगे? To prevent the compartment syndrome, we will perform escherotomy. So to prevent, ये trunk दिया हुआ था. Okay, somebody is saying that, sir, trunk दिया हुआ था. Doesn't matter. Trunk है, chest है. What is the problem? If circumferential burn is there is increased risk of compartment syndrome. So escherotomy is done to prevent compartment syndrome. So what we are going to do? Escherotomy is done to prevent compartment syndrome. To prevent compartment syndrome. Circumferential burn was there. Okay, ठीक है. Now see this next question. Identify the knot. Guys, tell me the knot. कैसे identify करना? You can easily identify. Can you tell me how many wraps are there in first throw? In the first throw, there are 2 wraps. How many wraps are there in the second throw? 1 wrap. Or crossing occurs in each throw. इसको क्या बोलते हैं? What is the name of this knot? All of you know, this is surgeon's knot. This is surgeon's knot. What happens in reef knot? There is 1 wrap in each throw and crossing occurs. Granny's knot को हम लोग बोलते हैं pseudo square knot. Granny's knot को हम लोग बोलते हैं pseudo square knot. Here, crossing doesn't occur. Here, crossing doesn't occur. Clear? Okay. So what is the correct answer here? This is surgeon's knot because there are 2 wraps in the first throw, 1 wrap in the second throw. Crossing occurs in each throw. Crossing occurs in each throw. So correct answer is D, that is surgeon's knot. Next, easy question. You can see here varicose vein. So here you can see the varicosity. 56 years old man presents with following pathology. Which of the following is correct? Now the question is related to varicose vein. Now you guys tell me. Yes, this is a bit tricky question, but easily you can mark the correct answer. Guys, waiting for your reply. Yes. देखिए, sclerotherapy is best treatment. No, it is not the best treatment. Can anybody tell me what is the gold standard treatment for varicose vein? What is the gold standard treatment? The gold standard treatment for varicose vein, you know, that is endothermal ablation. This is endothermal ablation. So the gold standard treatment, that is endothermal ablation. So obviously, first option is incorrect. Telangiectasia, yes, it's not rare. It's common. It's common. No possibility of venous ulcer. No, there is venous ulcer. So what is correct answer? The correct answer is lipodermatosclerosis, eczema. These are the complications. These complications can occur. Yes, one option was there related to C6. What is C6? C6 में क्या होता है? C6 में होता है open ulcer. So whenever patient is having open wound or ulcer, that is C6. ठीक है? So that is C6. C5 क्या होता है? Healed ulcer. C4 is C4A, C4B. C4A में क्या होता है? Pigmentation. C4B में क्या होता है? Lipodermatosclerosis. Clear? So pigmentation and eczema was there. कुछ लोग बोल रहे हैं. That is also correct. So even if pigmentation and eczema is there, that is correct. So correct answer यहाँ क्या होगा? The correct answer will be yes, option B. Somebody wants to tell कि sir compartment syndrome का एक दूसरा question था. History of fracture lower limb, pain not decreasing on analgesics. Option was fasciotomy. Yes, there was one question related to compartment syndrome. And you know that in compartment syndrome, what happens? It is seen in closed lower limb injuries, usually fractures. So closed lower limb fracture or injury, there is pressure more than 30. And what is the treatment, guys? We go for fasciotomy. So what we go for? We go for fasciotomy. So there was one question related to this. Okay. Next question. What is correct regarding this suture? Guys, can you tell me this is PDS, polydioxanone. PDS. PDS कैसा suture है? It is absorbable, synthetic monofilament. This is absorbable. This is synthetic. So it is absorbable, synthetic. This is monofilament. Clear? Absorbable, synthetic, monofilament. Can anybody tell me in how many days it is absorbed? It is absorbed in 180 days. Absorbed in 180 days. Now you can easily see the options. Polyfilament bhi option mein tha, koi baat nahi. So non-absorbable, it is absorbable. It is not multifilament. It is not collagen derived. Kya hai? Monofilament. So it is monofilament. It is monofilament, right? So this is PDS polydioxanone. Now see the next question. A 3-year-old child was brought to the OPD with complaints of dysuria, ballooning of prepuce during micturition. You know that dysuria, ballooning of prepuce during micturition. ये किस में देखने को मिलता है? यहाँ आप notice कर सकते हैं. This is phimosis. So what is this, guys? Patient is having phimosis. This patient is having phimosis. So what is the diagnosis? Phimosis. Okay. Paraphimosis. What is paraphimosis? देखिए, when there is formation of a tight ring of prepuce around the glands. So there is formation of a tight ring क्योंकि prepuce में edema हो जाता है. After that, if there is edema, what happens? That's paraphimosis. Paraphimosis is acquired. ये congenital या acquired दोनों हो सकता है. So what is the correct answer, guys? This is true phimosis. So this is true phimosis. Hypospadias भी था. Option में hypospadias भी था. Okay. So there was hypospadias. Hypospadias भी था. Paraphimosis भी था. Paraphimosis भी था. So hypospadias was there. Paraphimosis was there. Okay. Clear? So correct answer will be phimosis. Guys, it is phimosis. Right. So it is phimosis. कुछ लोग बोल रहे हैं true नहीं था. Doesn't matter. It's phimosis. Next. You can see here typical appearance. A carotid angiography है. On this carotid angiography, this typical appearance is there. All of you know what is the name of this sign. There is splaying of carotid. It's known as Lier sign. So you can see there is mass in the neck and this mass is pulsatile. So there is pulsatile mass in the neck. This is the vascular swelling. The swelling was not filling on the carotid compression, but it was refilling on the pressure. इसको बोलते हैं compressible swelling. So what kind of swelling? Compressible. And guys, you know, it is carotid body tumor. What is the other name of carotid body tumor, guys? Carotid body tumor का दूसरा नाम क्या है बोलिए? Carotid body tumor. This is chemodectoma. So what is this? This is carotid body tumor या chemodectoma. Correct answer is B. Lier sign, chemodectoma. Yes. Next. This question easiest. 30-year-old male patient presents to OPD with complaints of recurrent headache and nausea. MRI brain, you can see this tumor, and this tumor is having this sign. इस sign का नाम बताइए. What's the name of this sign, guys? Okay, recurrent phimosis was there. That could be correct. Meatal stenosis was there. ठीक है? Somebody wants to say, sir, इसमें recurrent phimosis था. Recurrent phimosis. So there was recurrent phimosis. Meatal stenosis. So correct answer is क्योंकि ballooning of prepuce आपको कब होगी? Ballooning of prepuce is seen when the patient is having phimosis. One option was meatal stenosis. One option was meatal stenosis. Clear? Next. So this is dural tail sign, and all of you know dural tail. So this is dural tail, and you know that this dural tail sign, it is seen in meningioma. So dural tail sign, this is seen in meningioma. Clear? Meningioma. Okay. Next. 25 years old patient had a road traffic accident. Patient was initially conscious but later became unconscious and subsequently died. On post-mortem examination, you can see multiple petechial hemorrhages were seen in the corpus callosum. You know what is the diagnosis? It is diffuse axonal injuries. क्योंकि इसमें होता क्या है? There is widespread axonal damage. So straightforward question. It is diffuse axonal injuries. You know that. Here NC-CT is normal. और यहाँ investigation के लिए investigation of choice क्या है बताइए आप लोग? What is the investigation of choice, guys? The investigation of choice for diagnosis, it is MRI. Okay, so it is MRI. So this is B, diffuse axonal injuries. Clear? After that, there were other questions. A question था carcinoma thyroid related. So there was one question related to thyroid, in which what? There was amyloid stroma. One of the feature was amyloid stroma. So can you tell me, guys, what was that malignancy? कौन सा? Yes, CT was given. CT was normal. यहाँ पे लिखा था NC-CT was normal. Amyloid stroma. Yes, obviously it is medullary carcinoma. So amyloid stroma, it was normal. It was there. So it is medullary carcinoma thyroid. ठीक है? Another. There was one question on Strasbourg classification. So there was one question on Strasbourg classification. और Strasbourg classification में क्या था, guys? Can you tell me what was there in Strasbourg classification? Some student told me that sir, ये था cystic duct stump. Cystic duct stump से leak था. There was leak from cystic duct stump, or leak was there from subvesical duct of Lashka. So cystic duct stump या subvesical duct of Lashka से अगर leak है, obviously it is type A. So this is type A. Type A. Clear? So this is type A. Okay, somebody is saying that sir, leak from aberrant right sectoral duct. अगर aberrant right sectoral duct से leak होगा तो type C है, और सिर्फ ligation है aberrant right sectoral duct का तो type B है. Somebody wants to say that there was leak from aberrant right sectoral duct. So there was leak from aberrant right sectoral duct. If there is leak from aberrant right sectoral duct, ये type C हो जाएगा. This is type C. Type C. It was type C. There was one question related to carcinoma head of pancreas. Question में क्या था? Patient was having palpable gallbladder. So what happens? Patient was having palpable gallbladder. साथ में there is obstructive jaundice, and obviously this patient is having carcinoma head of pancreas. Anybody remembers anything else about this question? CA head of pancreas. CA head of pancreas. Okay. अगला question था, there was carcinoma anal canal. Can you tell me, guys, in carcinoma anal canal, which lymph node is involved? So in carcinoma anal canal, the most commonly involved lymph node, that is inguinal. So carcinoma anal canal, the most commonly involved lymph node, that is inguinal. So that is inguinal. Carcinoma anal canal, most commonly involved lymph node, that is inguinal. Clear? That was another question. Okay. There was one candidiasis, oral candidiasis, and the question was asked related to some drug. Oral candidiasis. This was one question. Okay. Right. After that, stab wound related clinical question was there. There was stab injury related question. So stab injury related clinical question was there. Clear? There was one investigation related question, ureteric stone. Ureteric stone. You know that what is the investigation of choice? That is non-contrast spiral CT. So it is non-contrast spiral CT. एक FNH का क्वेश्चन था जिसमें इस तरह से व्हाइट कलर का स्कार था. So what? Focal nodular hypoplasia. This kind of scar was there. Focal nodular hypoplasia. This kind of scar was there. There was one question related to GERD criteria, fat embolism, One question related to GERD criteria. Craniopharyngioma related question was there. Question related to craniopharyngioma. Right, guys? So craniopharyngioma related question was there. There was one question related to oral cancer risk factor, जिसमें base of cancer था. Base of cancer. ठीक है? So oral cavity related cancer. Base of cancer था. And there was one angular dermoid. There was one swelling here. Angular dermoid. Angular dermoid related question. Angular dermoid. Clear? Okay. So these were the questions, guys. Anybody remembers anything else? Okay, one question was related to thyroidectomy complication. What was the complication? Shayad some students were telling, sir, the patient were having signs and symptoms of tetany. Okay. Okay. So one, thyroidectomy complications. After thyroidectomy, there was complication. Guys, anybody remembers? Yes, carpopedal spasm. Can you tell me on which day it is seen? Carpopedal spasm. So there was one question related to carpopedal spasm. Carcinoma pancreas हो गया, yes. Painless progressive jaundice, carcinoma head of pancreas, ये भी सही है, सीट ठीक है. Okay, carpopedal spasm. Total thyroidectomy specimen was there, carpopedal spasm was there, ठीक है. Okay. Okay, guys. So these were questions. Please, anybody remembers? If you remember any other question, TNM staging हम लोगों ने डिस्कस कर लिया. Balanitis, xerotica obliterans. BXO में क्या होता है? Balanitis मतलब इन्फ्लेमेशन, xerotica मतलब व्हाइट, और होगा क्या? Xerotica मतलब ड्राई, और obliterans मतलब उसमें भी फाइमोसिस होता है. उसमें होता क्या? देखिए, दिस इज द पेशेंट, ये इसका ग्लांस पीनिस है, इस तरह से इसका प्रीप्यूस होता है. क्लियर? बट व्हाट हैपेंस? प्रीप्यूस में कलर चेंज आपको दिखेगा. दैट्स ड्राई. Okay, there was one question related to stab injury. Okay, guys, if you remember, please. If it was written white dry, see, guys, it depends on the question language. तो यहाँ मैं डिस्कस कर रहा हूँ, इसका मतलब ये नहीं कि आपका एकदम गलत हो गया, राइट? वॉट एवर लैंग्वेज वॉज देयर, उसके हिसाब से क्वेश्चन का आंसर होगा. क्लियर? मैंने आपको बता दिया, अगर सिर्फ फाइमोसिस है, ऑब्वियसली इज फाइमोसिस. ऑब्लिटरेशन है, वहां ड्राई अपीयरेंस है, स्किन का कलर चेंज है, व्हाइटिश है, देन ऑब्वियसली इट्स बीएक्सओ. डिपेंड करेगा क्या लैंग्वेज थी. Okay, it is superficial inguinal lymph node, so there is involvement of superficial inguinal lymph. There is stab injury, hypotension. अगर hypotension का patient है, stab injury है, patient is unstable. In this case, we are not going to waste time. We are going to take the patient for exploratory laparoscopy. So patient who are having penetrating trauma, patient is unstable, straightforward. Stab injury का patient है, stab injury, patient is having hypotension, patient is unstable. If patient is unstable, we are going to take this patient for exploratory laparoscopy. So guys, we are going to take the patient for exploratory laparotomy. Cricothyroidotomy picture was given. Very good. Very good. Thank you, guys. It was cricothyroidotomy. Cricothyroidotomy. And whenever, guys, we are going to perform cricothyroidotomy, especially it is done in which patient? The patients, especially it is done in which patient? The patients in whom there is maxillofacial trauma, emergency airways cricothyroidotomy. इसका next step क्या होगा? The definitive treatment is tracheostomy. So emergency treatment, it is cricothyroidotomy. Definitive treatment is tracheostomy. Tracheostomy was one option. Yes, it was correct. Subhash Dara, building collapse. A question building collapse with her. Can anybody remember? And there was one question related to crush injury. Building collapse, crush injury. So question was related to building collapse, crush injury. Building collapse and crush injury. Okay, after stab injury, if patient develops peritonitis, what is the next management? Peritonitis है, इसका मतलब there is injury of the bowel. और अगर bowel का injury है, what you do? Just go for straightforward, you go for exploratory laparoscopy. So patient is unstable, peritonitis, we take the patient for laparoscopy. Total laryngectomy, pics were given. Okay, it will be discussed in ENT. Okay, guys. Phimosis हो गया, building crush. Okay, building crush was same option, right? So guys, I think ultrasound was given. ठीक है. So I think we discussed the questions and there was quite overlap of question. A question testicular tumor ka tha. I think it was discussed in pathology, in which slide was given. It was seminoma. So testicular tumor was there, seminoma. Okay, blunt trauma abdomen, unstable patient, step in management. If blunt trauma abdomen is there, patient is having blunt trauma abdomen, patient is unstable, in that case, straightforward we take for exploratory laparoscopy. Exploratory laparoscopy. Right? Okay, foramen of Winslow. There was one question related to foramen of Winslow. Shubh, do you remember the question? Foramen of Winslow? Foramen of Winslow, epiploic foramen. Kya question tha? Anybody remembers foramen of Winslow? There was one question related to foramen of Winslow. Foramen of Winslow. Okay, clinical staging related question bhi tha. ठीक है guys, I think you guys are tired, right? Please send the questions. हम लोग इसको compile करके very soon we are putting the exact questions with exact options and we'll be discussing it later. Till now, yes, participate in this analysis and after that you can take rest, guys. I hope that you really did well in the exam. Best of luck and I hope that you're going to crack this exam with flying colors. All the best. All the best, guys.
Hi everyone, good evening. I hope you're doing well. And this has been an extensive recall session happening since quite some time. And now we are at ENT. And I hope all of you did your exams well. We will recall the most, the questions that we've got from the students. And if there are any changes, please do let us know in the chat box so that we can make appropriate changes and then upload the final version on the app. So without wasting any time further, let's begin the class and let's start with the first question here, where we have a 2-year-old male with a history of recurrent epistaxis. So you can see here, this is a recurrent epistaxis. There is male patient, but what is not so good looking is 2 years. Right? And this child is having nasal obstruction for past 1 year, and the examination shows you nasal mass, and on investigating, you're seeing that there is bowing of the posterior wall of maxillary sinus. So what is the probable diagnosis? So with this history, everything else, like if you leave alone the age with the history of male, recurrent epistaxis, nasal mass, and there is bowing of the posterior wall of maxillary sinus, we know our answer is JNA. There is no doubt to it. Angiofibroma has to be your answer. The only thing that doesn't fit into this entire history is the juvenile age group. So we have an infant who's presenting to us. So here I see that some of you are telling it was a 20-year. Okay, for them, perfect. So if it is 20, then the answer is JNA. There is no doubt about it. There is no other answer to it. Antrochoanal polyp will not present to you with bleeding. Rhinoscleroma again won't present to you with bleeding. Rhinosporidiosis can present to you with bleeding, but it is not a common entity. It is a rare entity. So with this, we know the answer is angiofibroma. Let's go to the second question. Here we have a 72-year-old female who's a smoker and has a long history of hoarseness and difficulty in swallowing. Laryngoscopy is confirming to you that there is laryngoscopy and biopsy showing to you that there's a squamous cell carcinoma involving both the vocal cords, extending into subglottis, and because it is going to thyroid cartilage, it becomes T3. Right, this tumor is not amenable to radiation therapy alone. We've read that T3, N0, M0. They haven't given you the N or M stage, but if it is a T3, N0, M0, we know that it is a stage 3 disease. And for stage 3 disease, the first line of treatment is nothing but your chemo-RT. Now, because this patient cannot go for radiation. So what is the next step that we do? If a patient cannot go for radiation or if the tumor is not amenable to radiation therapy, then the next answer has to be total laryngectomy. Yes? Okay. So, yes. So now I think everyone is answering this, total laryngectomy. Yeah, so ma'am, this question was not there, image was there, just the image, fine. So even if there was an image of vocal cord growth going into the subglottis and involving the thyroid cartilage, you have to just answer it as total laryngectomy. Tracheostomy is not the answer in the initial stages because you are not going to treat by just doing a palliative tracheostomy when you have a option of doing total laryngectomy, and they have given you that you have to remove the complete tumor with adequate margins to control the disease. So we are not thinking of palliation. So if you think of palliative treatment, then yes, you can do tracheostomy, but yes, whenever you're doing a definitive surgery, it has to be total laryngectomy. Okay, so next question. 30-year-old male presents to the clinic with a history of recurrent ear infections and a recent popping sensation in the left ear. Otoscopic examination shows to you that there is a central perforation of the tympanic membrane. So you can see here there's a central perforation. Now, based on this, they have given you the pure tone audiometry findings. Right ear is showing to you AC and BC thresholds are normal limits, which mean the right ear is normal. Left ear is showing to you that there is an air-bone gap that is present and bone conduction thresholds are within the normal range. So whenever BC is normal, AC is abnormal, we know the diagnosis has to be conductive hearing loss. Air-bone gap further tells us that there is a conductive hearing loss for sure. The disease is present in the left ear, so we are going to mark it as left conductive hearing loss. In SN loss, there is going to be no air-bone gap at all, so we are going to rule out that. Right-sided AC and BC are in normal limits, so it's not a conductive disease. So we know the answer is left conductive hearing loss, right? Next question. A patient presents to the emergency department with significant nasal trauma after a fall. Examination reveals a deviated nasal pyramid and palpation shows to you that there is crepitus and mobility of the nasal bone. A lateral nasal bone X-ray confirms to you that there's a displaced nasal bone fracture. Which instrument is designed for closed reduction? So whenever we're thinking of a nasal bone fracture, we think of Walsham's forceps. This is an image-based question which we have learned, instruments which we have learned for Walsham's questions. Walsham's forceps is used for reduction of nasal bone. So there is no other answer for this. Yes, so nasal bone fracture, X-ray was given, image was given, right? So you need to understand the name of the instrument is going to be Walsham's forceps. Okay. Okay, next, a 45-year-old female presents to you with a 2-year history of progressive unilateral hearing loss, tinnitus, and unsteadiness. MRI shows to you that there is a well-defined tumor in the cerebellopontine angle. A surgical resection was performed and a subsequent histopathological examination of the tumor tissue is given below. So we know that in the CP angle, whenever there is a tumor, the most common tumor in the CP angle is going to be vestibular schwannoma. Yes, so it's going to be vestibular schwannoma, right? Also called as acoustic neuroma. So this comes from the Schwann cells of the vestibular nerve. So we call it as vestibular schwannoma. Again, this is not something that is new. Yes, we can see Antony type A, type B cells, which are spindle-shaped cells, Verrucke bodies, which are very specific histopathological features. So we know the diagnosis is nothing but your schwannoma. So there's nothing that is surprising to us over here. Next question. A patient presents to the clinic with a history of chronic ear drainage and hearing loss for several months. Otoscopic examination shows to you that there is a central perforation of the tympanic membrane. Pure tone audiometry is showing to you conductive hearing loss. Based on these findings, what is the most appropriate next step in the definitive management of this patient's condition? Right? So when we're talking of a patient who's having a chronic ear disease, we know that it is CSOM. Along with that, the patient is having central perforation of the tympanic membrane. What are we going to do next? It's the question. Even we know that there is a conductive hearing loss. Now, I want to see that most of you are answering either A or C. Now, look at the word. Is it tympanostomy or was it tympanotomy that was given in your exam? Okay, atticotomy also could be given, right? So I want first thing that what was the question? Was it asking to you about tympanotomy or tympanostomy? What was there? It was a large perforation, fine. So even if there's a large perforation of the tympanic membrane, which is occupying all the quadrants of the pars tensa. So if I take this as the tympanic membrane, and if there's a perforation which is occupying all the quadrants, and even if there's a large central perforation, if there is a chronic ear disease, if the word was tympanostomy, then that is wrong. But if the word was tympanotomy, then that can be the right answer. Tympanostomy is making an opening in the tympanic membrane, making a hole in the tympanic membrane and examining the middle ear also. So if it is only tympanostomy, then I am not sure if that will be the right answer. It has to be tympanotomy. Myringoplasty for a large perforation can be not the first option, but you'll take it as a second option. MRM is not done for a safe disease. Whenever you have a pars tensa perforation, it indicates to you that it's a safe disease. It indicates to you it's a tubotympanic disease. Even if the perforation is small or large, it indicates to you that it's a safe disease. So in a safe disease, you're never going to do an MRM. Atticotomy is also indicated if there's a pars flaccida perforation. So these two are definitely not the answer. But if you had to choose between myringoplasty and exploratory tympanotomy, then exploratory tympanotomy will be the right answer. Yes, so exploratory tympanotomy, Akash is saying 1000% sure, then that is the right answer. But if there is an image showing cholesteatoma, so if the word was cholesteatoma and if you saw an image showing to you keratin flakes, keratin debris in the pars flaccida, then of course you have to go for MRM. Then there is no doubt at all. So then you have to think of MRM. Now, what was the question? If you can give me a clear understanding, was there a pars tensa large CP or a pars flaccida cholesteatoma? Based on that, your answer will change. Right? So if there's a pars tensa, then you will go for exploratory tympanostomy. If it was a pars flaccida cholesteatoma, then your answer will be MRM. As simple as that. Okay? Chalo. Which anatomical structure is depicted in the image shown below? So if you look at the image, first thing that you look at is this. This is nothing but your hyoid bone. Just below the hyoid bone would be your epiglottis like this. So this is not at the level of epiglottis. Is it at the level of your larynx? They are not pointing to you at a specific structure. So is it larynx or is it thyroid cartilage is the question. So you can mark larynx in broader terms, but if you had to specifically answer, I would say thyroid cartilage is also a right answer because the largest framework of the larynx is formed by the thyroid cartilage. Okay, ये question नहीं था, no such question. Fine, so we ignore this question and go forward. Pyriform sinus का image था. So you mean pyriform fossa in the when you do a hypopharyngeal imaging or endoscopy is what you mean? Yes. Okay, so if it was a barium swallow with pyriform, then that's okay. The pyriform fossa, then that's understood. That is a completely different image from what was shown. So we will correct this question and put up the final one in the app later. But I think then if that's not there, let's ignore that question for now. Don't take it, you can just keep this question on the side and maybe we will refine this question and come back to you later. Okay, a 40-year-old patient presents to you with recurrent and severe nosebleeds from the anterior nasal septum. Whenever we think of anterior nasal septum, we are going to think of Kieselbach's plexus, right? So if there is a bleeding from Kieselbach's plexus and it has been refracted to nasal packing and chemical cautery, and you have decided to do the surgical ligation to control the bleeding, which of the following artery is the primary target for ligation in the management of this patient's anterior epistaxis? Okay. So I see some people are giving that hypertension tha, 75-year-old male diabetic hypertensive, posterior ethmoidal artery option tha. Okay. So, okay, first, if they gave you hypertensive, diabetic, this is fine, but I need to understand that did they mention anterior epistaxis or did they just say epistaxis? Because then the answer will change. If they mentioned anterior epistaxis, you're going to think for bleeding from the anterior part of nasal septum, and we know anterior part of the nasal septum superiorly supplied by anterior ethmoidal artery and inferiorly it is supplied by superior labial artery. Right. So if we are thinking of the anterior nasal septal bleeding, your answer will be anterior ethmoidal artery. But if they did not ask you specifically about anterior epistaxis or the word was just epistaxis, then you have to answer artery of epistaxis. Artery of epistaxis is sphenopalatine artery and you are ligating the sphenopalatine artery. Now this again, some students are saying, some people are saying they mentioned anterior, some are saying not mentioned anterior. So agar anterior mentioned tha, then your answer will be anterior ethmoidal. Nothing was mentioned, only epistaxis was mentioned, then your answer will be sphenopalatine. Okay. Yeah, so Alok is saying anterior tha. Okay. So no, just epistaxis, ma'am, then your answer is for sure sphenopalatine. Right? So with this, I think I have finished the recall of the questions that were from ENT. If you think there were more questions, please do write down to us in the chat box below. We will come back with the final version on the app, and this was just to get an understanding of the overview of the ENT question. Okay, so pyriform fossa, ma'am, I agree. Let's review that one question for later, and I will come up with that later. So whenever we talk of epistaxis, Dr. Ram, the first thing is either you control directly with cautery or you do packing. If both of them fail, then you go for ligation. We've learned the order of ligation, which is spinopalatine artery, which is the first artery that you ligate, followed by your internal maxillary artery, and then your anterior ethmoidal artery. So we know the order of ligation also. So we are not jumping that gun and going to anterior ethmoidal artery in the first place unless they have mentioned that it is anterior epistaxis, right? So if they just said epistaxis, go for spinopalatine. That will be your answer. But if they said anterior part of the nasal septum, then you have to go for anterior ethmoidal artery. Okay. Okay, so needle cricothyrotomy was done, and next step, supplied ventilation for 6 hours or has to be followed by tracheostomy. So Shruti saying whenever there is a needle cricothyrotomy that is done, that's only a temporary method of securing the airway. The definitive method of securing the airway has to be a definitive tracheostomy, and you have to do as early as possible, 2, 3, 4, whichever was the earliest hour mentioned in your option, you have to answer that, because needle cricothyrotomy only gives you a window period for a few minutes to few hours until you're able to secure the tracheostomy, right? So I hope I've answered your question there. Yes, Niharika, option was to maintain for 6 hours. Yes, you can do tracheostomy before 6 hours also, but tracheostomy has to be the definitive management. You can't leave a patient on cricothyrotomy for a long time. Okay, thank you, Rahul, for your appreciation. And I hope all of you have done all the subjects well. Now just relax and, you just have to wait for your results. And I'm hoping that all of you would have done extremely well. So take care, guys, and all the best for your results. And we are here to welcome you on the other side. Take care and bye-bye.
Hi, everyone. Good evening. Welcome to the recall session, biochemistry part of recall session of NEET PG 2025. I know you're all exhausted, so let's take a moment to understand the fact that you have done your part, right? So the pressure, the paper, everything is over. So just relax for now. Yeah. Take a deep breath, relax for now. And all that we are going to do in this session is to analyze how the paper was, what kind of questions were asked, and what possibly you can expect as marks out of it. Okay. So I hope I'm audible and visible. Yes, okay. So let's start with the exam analysis. Based on the inputs that I've got from students so far, the paper has been moderate to easy, and most of the questions were conceptual, case-based, and even in biochemistry, 15 out of the 15 MCQs asked in biochemistry, 13 MCQs were case-based, and 7 were based on inborn errors of metabolism. Biochemistry totally 15 MCQs. Yeah. So 7 was on inborn errors of metabolism and 3 on vitamins. Okay. So this is an overview, and let's start discussing MCQs. You don't worry. I will not get into the details of the explanation here. I will just tell you the right answer and I'll explain why others cannot be the right answer, right? So quickly we'll finish all 15 MCQs probably in 15 minutes. Okay, that's the target. So this is the first question that I got. A child presents with history of fractures, multiple petechiae, perifollicular hemorrhages, and gum bleeding. So which of the following enzyme defects is involved, all of you? Yes, the answer is prolyl hydroxylase. The answer is choice B, because all these are classical of scurvy, right? Gum bleeding, starting from gum bleeding, history of fractures, it is scurvy, vitamin C deficiency, and we know prolyl hydroxylase is dependent on vitamin C. Okay. Okay, no problem. We know this is the right answer because lysyl oxidase is not vitamin C dependent. It is copper dependent, right? So this definitely cannot be the right answer. The right answer is prolyl hydroxylase. Let's go to the next question. Something similar to that based on bleeding. A person with jaundice presented with history of bleeding and symptoms normalized after giving vitamin K injection. The probable causes, right? So after giving vitamin K injection, if the bleeding is arrested, it is vitamin K deficiency. And then there is jaundice, which means it is obstructive jaundice. So what is the right answer? The right answer is biliary obstruction. Okay, 1 second. Many were based on LRR. Thanks. Good to know. So the answer here is choice A, biliary obstruction. The next MCQ. A man is trapped in a tunnel for 5 consecutive days. This also we discussed in LRR. Remember what happens in starvation? If it is 5 consecutive days, the primary source of energy will be dependent on ketosis. Because I've already told you 12 to 18 hours, it is glycogenolysis, after which it is gluconeogenesis. From day 3, brain becomes dependent on ketone body. So the answer is ketosis. My pleasure, all of you. Yes, answer is ketosis. The next one, this also we discussed. A patient has elevated phenylalanine levels, right? The exact similar MCQ was discussed. High phenylalanine levels, but phenylalanine hydroxylase enzyme levels are normal. Which cofactor deficiency is most likely responsible for this condition? We know for phenylalanine hydroxylase, we need tetrahydrobiopterin. So the answer has to be tetrahydrobiopterin deficiency. Okay? Yes. So remember, this is what we discussed. This is the NEET PG 2024 MCQ. Again, in NEET PG 2025, a similar MCQ has been asked. And that is why you're supposed to learn all previous year MCQs. A patient presents with anemia, positive Romberg sign, and other neurological findings suggestive of vitamin B12 deficiency. So B12 deficiency causes high homocysteine levels, because B12 is responsible for converting homocysteine to methionine. So whenever there is B12 deficiency, homocysteine levels will be high and methionine levels will be low. Right? Very good. Excellent. So this was also discussed in LRR session. The answer here is choice B, methionine. And this is what we discussed in LRR session. There are 2 fates of homocysteine. One, it can become cysteine. The other, it can become methionine. For it to become methionine, it is dependent on B12. So in B12 deficiency, methionine levels will be low. Okay. No, coenzyme was not asked. The answer is methionine. And in LRR session, we discussed this with respect to B6. The next one, a neonate presents with seizures and is found to have a cherry red spot on fundus examination. Enzyme assay reveals deficiency of hexosaminidase A. So all of you give me the right answer. If hexosaminidase A is defective, we know it is Tay-Sachs disease. I told you multiple times in LRR session that Tay-Sachs disease is otherwise called as GM2 gangliosidosis. So exactly the same concept was discussed. Answer is choice B. Smile a day. You don't have to be so anxious. Yeah, so cut down on the anxiety. We are going to finish it in 10 minutes. Okay. So the answer here is choice B, GM2 ganglioside. This is what we discussed. A patient on long-term hydrochlorothiazide therapy presents with features of neuropathy, heart failure, and symmetrical tingling sensation. Which of the following nutrient deficiencies is most likely responsible? Yes, hypertensive, right? Okay, hypertensive on hydrochlorothiazide. So diuretic causes thiamine loss. So what is answer? Thiamine has to be supplemented. The answer is choice B, all of you. It is thiamine. Because thiamine deficiency causes dry beriberi, neuropathy, symmetrical tingling sensation. It causes wet beriberi, which presents itself as heart failure. That is why the answer is thiamine. This is definitely not vitamin B12 because B12 deficiency has got nothing to do with bilateral pedal edema. Right? This was given in the question, bilateral pedal edema and heart failure. That is why it is not B12, it is thiamine. The person need not be alcoholic. Okay. So alcohol is not the only cause of thiamine deficiency. Even diuretic, long-standing diuretic treatment can also cause thiamine deficiency. Remember, we discussed this. Dry beriberi is caused by thiamine deficiency. Wet beriberi is caused by thiamine deficiency. So the answer is choice B, thiamine. A frame shift mutation occurs due to the insertion of a new nucleotide at the fourth position. Whenever one nucleotide gets inserted at any place, right, it is going to cause frame shift mutation, irrespective of how many ever nucleotides the mRNA has got. And whenever there is frame shift mutation, there will be a complete change in protein production. So what will be the right answer? The right answer will be choice C, because from there, the entire frame gets shifted, and that is what they want to verify here. So the answer here is choice C, complete change in protein production or complete change in biological function. Yeah, whatever it is, that is the right answer. Yes, very good. If you need to diagnose a syndromic illness such as meningitis, right? When they say meningitis, if you're trying to find out the cause, right? We know that can be infectious causes, non-infectious causes. And infectious causes, there are viral causes, bacterial causes, and even fungal causes. Whenever you're trying to detect the presence or absence of multiple microorganisms in a given sample, the answer has to be choice A, multiplex PCR. Do you all understand this? What is the right answer? It is multiplex PCR, choice A. No, it is not nested PCR, okay? Because I see some of you answering it as nested PCR. Nested PCR can only increase the specificity, right? So after you find out it is Neisseria, if you want to find out which subspecies it is, in that case, you can go for nested PCR. It is not to find out the cause of meningitis. Do you understand this? So the answer here for sure is choice A, multiplex PCR. Sadam Ali, I hope you have understood this. It's a very straightforward question, though it looks like a case-based MCQ. They've given you one fact, shows mutation in adenosine deaminase gene. They've told you that there are low levels of B and T lymphocytes, right? So what is the right answer? The right answer is severe combined immunodeficiency, right? So answer is choice C. How did I exclude other choices? If it was X-linked A-gamma globulinemia, only B lymphocytes level should have been low. T lymphocytes would be normal. Had it been Dye-George syndrome, there should be a decrease in only T lymphocytes. B lymphocyte level should have been normal. In common variable immunodeficiency, B lymphocyte levels will be normal. Even B lymphocyte levels will be normal. Only antibody levels will be low. So for all these reasons, the answer is choice C, severe combined immunodeficiency. Okay. Thanks all of you. The next one is a patient presents with skin cancer. We exactly discussed this MCQ, remember, causing a person presenting with cancer, hyperpigmentation. So what is the condition? The condition is, yes, xeroderma pigmentosa. Xeroderma pigmentosa, I asked you to remember it as excision. So the answer is nucleotide excision repair. Okay, the answer is choice A, nucleotide excision repair. Remember, this is what we discussed. I also asked you to remember xeroderma pigmentosa nucleotide excision repair mechanism. Yes. And this we discussed in FMGE recall session, right? So hypermobile joints, long limbs, high arched palate. And then there is aortic root dilatation, which means the person lens subluxation. So what is the diagnosis? The diagnosis is Marfan syndrome. If it's Marfan syndrome, what is the right answer? The right answer is fibrillin 1. Okay. So the answer is choice A, all of you, fibrillin 1. How about choice B, collagen 4 mutation? Yeah, that causes Alport syndrome. And Alport syndrome presents with lenticonus. It does not present with lens subluxation. And then collagen 1A1 mutation causes osteogenesis imperfecta. That presents with multiple bone fractures, right? And then they present with blue sclera. They don't present with subluxation of lens again. Elastin mutation causes Williams syndrome. Right? Williams syndrome does not present with aortic root dilatation. It presents with supravalvular aortic constriction. Okay, so the right answer is fibrillin 1 mutation. Did we discuss this? Orange color tonsils, right? So how did I ask you to remember? Orange is the famous flavor of tang juice. So orange color tonsil is classical of Tangiers disease. We also discussed that in Tangiers disease, HDL level will be low. It is hypo-alpha lipoproteinemia. So the answer here is choice B. Okay. So this is what we discussed in LRR session. So most of the MCQs were discussed in our LRR session and an image-based MCQs. So all those who are watching, right? So and I'm sure you won't be attending the next exam because you're done with the exam. I'm sure you will come up with flying colors. You will get the PG seat of your choice. And this is for all upcoming PG aspirants. Do watch LRR session. Do watch image-based questions discussion. Yeah, the other question also I'm going to discuss, Sahana. A patient presents with elevated level of elevated total cholesterol, subcutaneous xanthomas, and a positive family history of similar findings, right? So what is it? Triglyceride levels are normal. We discussed exactly a similar question, right? So it is type 2A, which is familial hypercholesterolemia, right? Answer is type 2A, familial hypercholesterolemia. It is not type 3. Had it been type 3, triglyceride level should have been elevated because triglyceride level is normal. It is not type 3. Organomegaly in Hurler syndrome is because of the accumulation of, right? So Hurler syndrome is because of the defect of which enzyme? L-iduronidase. If L-iduronidase is defective, any mucopolysaccharide with iduronic acid should accumulate. What are the mucopolysaccharides with iduronate residues? It is heparin sulfate and dermatan sulfate. Right? It's heparin sulfate and dermatan sulfate. Answer is choice C. Yes, subcutaneous xanthomas, tendon xanthomas, and all these cases, it is familial hypercholesterolemia. Okay. So the answer is choice C. And these are the MCQs in biochemistry. Most of the MCQs we had discussed. I'm sure you would have written most of the answers correctly. And my best wishes for now. Please spend some time with your family today. Don't become anxious, right? So it is time for you to relax. You have done your part and the rest is with the, with the supreme power, right? So thank you all. Is there any other question that... yeah, from Thoothukudi Medical College, Gopi Krishna. Happy to see that. Glucose surge and insulin. If somebody can type that MCQ, I will be able to explain that to you. Phrenoderma. Yeah. So the question on phrenoderma, ocular examination needs to be done, right? Was it an image-based question on phrenoderma? In that case, it is ocular examination. Thank you all. Thanks, everybody.
Hi guys, hope you're doing great. Well played, boys, is what I can say at the moment. So let's do a post-match analysis regarding how things went about for today. And let's focus on those questions and answers. I'll not take too much of your time. I know you are like planning to go out for dinner. And yeah, I would love you guys to go and have your favorite food items for today because you have really gone through an exhausting session. Now those 210 minutes are like the career deciding and fate deciding movements. So well played, boys, once again. And yeah, I know that there was no ECG based question, but they can sometimes put up PSVT and stuff like that, ask you regarding prophylaxis. So I think we can go ahead and start our discussion. So the first question on the screen at the moment was regarding osmotic demyelination syndrome. And this particular question that you can see, the sodium initially was like 98 and then has gone up to 110. So that's a substantial amount of increase. Normally we should not be rising by like 6 to 8 millicoulomb on a daily basis. So he said, what is the test that should be done for osmotic demyelination? And the answer in this question would be option number A, that would be a MRI head. Do give me a thumbs up with respect to the audio and the visual part, guys. Sorry, I did not go into that formality and I straight away started chatting with you guys. So Yes, guys. The basic point is any patient of chronic hyponatremia, we need to go for need to go in for like a gradual correction and not a quick correction. Okay, fine. Okay, brain evoke potential. Fine. I'll just note it down, doctor, for a brain evoke potential. Otherwise, like I think we are sorted for this question. Pretty straightforward one for osmotic demyelination syndrome. Then is a patient of COVID-19 pneumonia is admitted with severe respiratory distress. He mentioned regarding ARDS. I mean, the word ARDS was not given in the question, but PO to FI2 ratio is turning out to be less than 100. And considering that, okay, I'll just have a quick look at the options that somebody commented. Okay, stroke risk is more pre-systolic accentuation, absent AVIB and RHF, right heart failure. Okay. Okay, so the characteristic would be right heart failure in that, basically because initially we're talking about atrial fibrillation, everything is left-sided. So going by the options that you are mentioning, guys, so there would be a manifestation because there's atrial fibrillation, so absent AV would be there in the case. So like, initially because he's talking about everything related to left, that's why the answers would be there. Okay. Okay, got it, got it. That would be right heart failure in those circumstances. That's primarily because initially the manifestations that are being discussed are all related to the left-hand side. And then is a case of acute respiratory distress syndrome. If ARDS is given in the options, that is great. And he says, what will you do? So we go for a low volume ventilation, the low tidal volume, because we want to minimize the risk of barotrauma. And at the same time, we also want to go for there's a low tidal volume and there would be a high PEEP. Okay, so low, I think the options would be low tidal volume and a high PEEP. Okay, fine. I'll just rephrase the options in this case. One would be low tidal volume. And the second one would be that the PEEP has to be kept on the higher side. There are like 4 combinations, permutations that are given in a question. Yeah, I think this fits the bill. Option number B, that's a high PEEP and a low tidal volume. Value of 5 and value of 6 approximately would make it easier. Equal to 100. Okay, fine, not a problem. But that remains acute respiratory distress syndrome. Okay, fine, great. Yeah, I think ARDS, I don't think so you'll ever get it wrong on the basis of things that we have discussed it. Fine. Moving to the next one, we have another patient of irregular pulse atrial fibrillation, 2 hours of symptom onset, and he says there's no history of diabetes and comorbidities. What is the initial management? Quickly let me know any blood pressure values given in a question. We are talking about an acute onset atrial fibrillation in this case. Any blood pressure values given in a question with respect to crushing patient? Okay, 4 hours. Fine, I'll change that, 4 hours. Okay. If the patient is if the patient is stable, we'll go in for a rate control. The rate control part would be verapamil. If patient is unstable, then I'll go for cardioversion. So I think in these circumstances, considering that there was no value blood pressure that was given, control the ventricular rate is the correct answer. Yeah, control rate control. And the way the question was framed was control the ventricular rate of the patient. So I think we'll go with option number C for this particular case. Okay. See, the main presentation is an acute onset atrial fibrillation. So unless and until he says the word crashing or he says hemodynamic instability or he mentions like outrageously low blood pressure value, 70 by 50, 60 by 40, something like that, I'll not go for cardioversion in a patient. So controlling ventricular rate is like the best way for the patient. I'll just keep it little in my eyesight line so that I can see the chart better. Okay, yeah, I get your point. Verapamil is not in the options. It is controlling of the ventricular rate, and then is another option is going to be transesophageal echocardiography. And with transesophageal echocardiography, we need to plan an anticoagulation for a patient. But the algorithm is raised no. So yeah, the algorithm is raised only, no? That is rate control, anticoagulation, chemical cardioversion. So you are right in your point that the patient would be requiring a need for anticoagulation. We'll calculate the CHAD-S2 VSC score. But initially, like what we need to do is कि यार किसी को palpitation हो रही है तो उसका पहले heart rate stabilize करेंगे ना. We'll make him feel relatively better and prevent any further deterioration because sometimes AFib can deteriorate into VFib if there's an excitation or a pre-excitation pathway that is present. So considering that the patient is symptomatic for a couple of hours and he's having those so-called panic attack, we'll go by the rate control for this question. Patient is having a PSVT, sudden onset palpitations. I think there was no mention of any ECG per se, but he said like, how would you prevent it for this particular case? So for prevention, we use verapamil for the patient. The answer for this was option number B. No, the question is not on hemosiderin-laden macrophages are not seen, and it is like hemosiderin. Yeah, even then, right. I mean, I get your point. What you're trying to say is hemosiderin-laden macrophages are not a feature of right ventricle failure. But then the question is framed in such a fashion that which is not going to be related to the development. So pulmonary venous constriction or pulmonary is not a consequence or a manifestation that would be present. Okay, the answer for this one would be verapamil. Then we have salt wasting, salt craving, and hyperpigmentation with hyperkalemic metabolic acidosis. So if I look at the manifestations there for especially the concomitant metabolic acidosis component coming in, it would be Addison disease in this patient. So answer for this question is option number A. Adenosine is the treatment of choice, guys, and not for prevention in this particular case. Cons will be presenting with hypokalemic alkalosis, no? If I say Conn syndrome, then Conn syndrome would be presenting with a hypokalemic alkalosis. Okay, fine. Let's move on to the next one here. Patient is having type 1 diabetes, blood sugar is 799, sodium is 128, chloride is 88. There are signs of dehydration. So we did not mention the word diabetic ketoacidosis, but we will use saline, we will use insulin potassium monitoring to be standard done. Hypertonic saline, sodium is pretty decent. There is no hyponatremia dangerous enough to contribute to development of seizures. So the answer in this case will turn out to be option number B. That would be 3% saline. Okay. Then another one which I want to know is, did he ask you for this particular condition, which fluid will be given or whether fluid was given in this complication is developing? Because the input that I got was that patient was given IV fluid in the hospital setting. And because of the IV fluid, the patient is developing a hyperchloremic metabolic acidosis. Considering that the patient is having a hyperchloremic metabolic acidosis occurring in the patient, in those circumstances, it is excess of normal saline that has been given to the patient. Yeah, what is cause? Then the cause would be given a normal saline because normal saline will cause excess of negative charges in the body. And because there are more negative charges in the body, to maintain the electron neutrality, what the body will do is that it will try to curtail the negative charges. So bicarbonate, that is negative charges, will be lost in the urine. And because negative charges will be lost in the urine, therefore, like there would be a metabolic acidosis that is occurring. So excess of fluid intake is the reason why for development of hyperchloremic acidosis. If I interpret this question in this fashion that he says, what is the treatment for metabolic acidosis? Then answer will obviously become ringer lactate. So that is why I said asked in the beginning, like if the framing is how do you treat metabolic acidosis? Cool. But if he says like a fluid was given and person is having metabolic acidosis, then it is normal saline, the side effect of that, which is contributing to this manifestation. Okay, this question I think has already been discussed by multiple people. So I'll consider that as an overlap in the 28 series that I have: chronic low backache, morning stiffness, ankylosing spondylitis. In the diagnostic criteria, I've explained MRI of the pelvis is basically done. So MRI pelvis spine will help in diagnosis in this case. Okay. Okay, कौन से में बच्चे hypertension होती है इस वजह से नहीं होगा. Then is the patient of fever, headache, nuchal rigidity, and there were two questions of meningococcal meningitis. I think one is discussed in pathology where they mentioned regarding complement deficiency, that is C5 to C9, the standard membrane attack complex, C5, C6, C7 like that. And second is like, what will you give for prophylaxis? So there are two drugs we can be using in family contact. One can be fluoroquinolones. Now, I had a chat with a lot of my students and they said there is no fluoroquinolones in the option. If we do not have fluoroquinolones in the option, then you go by standard PSM data. That is what Park says, rifampicin. So the efficacy of this is not going to be like very, very significant. I can say that there would be like rifampicin is not very effective, but then fluoroquinolones, if it is not given, then okay. So I think okay, fine. Let's move on to the next one. This is the one that people are talking about, and irregular pulse again. This time they had some kind of an association with atrial fibrillation, right-sided weakness, speech deficits, and then symptoms of 2.5 hours. CT scan shows no hemorrhage, BP is 160 by 100. So a classical presentation of acute ischemic stroke. I'll wait for 15 seconds. Let me know if the presentation was AIS or was it a transient ischemic attack. Yeah, DNS, but then the most common side effect that we see, I get it. One of the fluid is 5% dextrose also there with, and dextrose normal saline also, but then the higher probability will be with normal saline only. Okay, so if the presentation is of acute ischemic stroke, cool, will go for intravenous thrombolysis. And what I was looking for was the blood pressure value. If you can quickly comment if that is okay. I mean, my question is value may not be matching, but I hope it is not more than 185 by 110, or there is no mention of any patient being on warfarin, and there is increase in the value of anti-CCP antibody is for rheumatoid arthritis. It is not for ankylosing spondylitis. Okay, so as long as there is no contraindication present, we'll proceed with the thrombolysis. I mean, this question looks too surreal, you know. कई बार लग रहा है twisted, सब कुछ तो twisted आता है. So I mean, I am like in a state of, you know, dilemmas to say that okay, really, were they having a straightforward thought process? Okay, fine. Yeah, we need to demonstrate a CT angio. We need to do a CT angio in a patient, but then it is okay. Okay, look for thrombus. Okay, yeah, look for thrombus. That is okay. Fine. Transesophageal echo to look for presence of a thrombus in the left atrial appendage. That is perfectly fine. That would be subsequently done, doctor. And then starting low molecular weight heparin is another option. Okay, fine. Got it all. Fine, let's move on to, I'm on the 15th slide of mine, so I think another 14 more to go. Patient is having anti-CCP antibody positive morning stiffness, then I'll go for rheumatoid arthritis, and there would be a pannus formation with erosive joint damage present. Okay. Low molecular weight heparin for thrombolysis. No, for arterial stroke, doctor, you don't use heparin. No, heparin is for venous now. If it is arterial stroke, I think it is arterial stroke only given. It's not a venous stroke. If it talks about empty intestine, woman, post delivery, hypercoagulable state, then I'll think in terms of a low molecular weight heparin. Okay. Then is I think this was a super easy question. That would be hyperpigmentation Addison. Doctor, in my sheet, that will be like about 15 done, 16. So one was an intro sheet, so 15 done. Okay, so then it's gonna be ACTH, hyperpigmentation Addison disease. This was a one-liner, pretty straightforward. Pro-opio melanin cortins that would be present. Fine. Patient is having chest pain and tightness after taking sumatriptan. I have included this question because what I wanted to know was that there was history of coronary artery disease. Was there metabolic syndrome also described? Because that changes the perspective. I understand that in this particular case, he's asking about like what will you do for prophylaxis because patient is having coronary artery disease. So what we can do in this case is we will be using propranolol. But I just want to say that if there is metabolic syndrome also described, like if there is diabetes mellitus also, then we cannot give propranolol because propranolol causes blood sugar to be elevated, triglycerides to be elevated. So, I mean, propranolol is a standard answer. I am saying if there is a twist present, then it is okay. Then we have to think in terms of possibility of even topiramate. But considering propranolol will be the single best answer to reduce the chronic stable angina manifestations. Okay. No, Ankit sir went for topiramate if there is mention of any metabolic syndrome. There is no mention of any metabolic syndrome. Otherwise, he would have also answered it as propranolol only. Okay. Okay, there is only a family history of coronary artery disease, no? So we'll have to go. Fine, guys. No metabolic syndrome, so we'll go by standard answers. This question again I've incorporated because there was mention of caseating granulomas. Quick chat regarding caseating versus non-caseating. Patient is having Dresnia stridor. I know that you want to give answer as sarcoidosis for this one, considering that lamellated concretions. My question is only one, that if there is a mention of any caseating versus non-caseating granulomas given in the question. Okay, so if it is non-caseating, then it is sarcoidosis, guys. Otherwise, even TB can be having concretions present. So if I'm thinking in terms of, you know, patient with low-grade fever, dyspnea, stridor, and caseating granulomas, my point is simple. Diagnosis is not based on the basis of lamellated concretions on histopathology. The diagnosis will be made on the basis of caseating versus non-caseating granulomas. Okay. Okay, so there's a stellate word in the question. Okay. But still, I think he would have still mentioned regarding, okay, giant cells with a stellate granuloma. Fine, guys. Okay, so no mention of any non-caseating granulomas. I'll just delete that, guys. It is stellate granulomas with giant cells and concretions that would be present. Okay, yeah. Okay, so I'm having that input of case rating and non-case rating that is given anyway. Got it. There's a granuloma, there's a giant cell. So I first initially I thought I should think it answer as, but there is no manifestation for like, tuberculosis given in a question. So, and especially if there's dry cough also given in a question. So there could be like a enlarged lymph nodes pressing on the chest. Male, female given quickly, guys. Any male or female? Okay. Moving to the next one, anti-SCL70 antibody in systemic sclerosis. This would be association with interstitial lung disease. Calcinosis cutis is feature of C. Now that is that crest syndrome that you get this, and that is associated with centromere antibody. Raynaud's phenomenon is a non-specific finding. It is seen with patients who are having even SLE. So ILD would be the answer in this case. Then we are having a patient with pheochromocytoma, and he's having a headache with diaphoresis. Metanephrine is elevated. Drugs that can be used both pre and intraoperatively. Phenoxybenzamine will be having a long duration of action because of the fact that it is having a long duration of action. Therefore, it can result in a post-operative hypotension in case it is used intraoperatively. So my only concern is that if I use it intraoperative, it can deteriorate a patient. So I have to use a alpha plus beta. And if I have to use alpha plus beta blocker, I can use labetalol for management of this patient. Yes, the correct answer for this one will turn out to be option number B, that is labetalol. And the bottom line is, if we are talking about phenoxybenzamine, esmolol, giving it pre-operatively would be too cumbersome how to give it intravenously. So considering that, yes, 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 yes. I think it's alpha plus beta blocker that we need to use in this patient. No, no, guys, it is not phenoxybenzamine because phenoxybenzamine is long acting, no? So the disadvantage would be that it can cause a post-operative hypotension. So we cannot be using it intraoperatively. It's only a pre-operative drug that would be used in the patient. Okay. भाई इंट्राऑपरेटिव तो था वदा तो क्वेश्चन प्री ऑपरेटिव होता तो मैं सीधा ही बोल देता यार phenoxybenzamine is the answer for the question. Otherwise, it is intraoperative that would be used in a patient. Okay, myositis in the option. Fine, doc. I take that point. Myositis. But the main manifestation would be interstitial lung disease only because presentation is like that only, no? That systemic sclerosis causes fibrosis, so the lung involvement can be present. Okay. Okay, guys, so we can move on to the next one. I'm having multiple inputs, like one I'm saying CCP, then there's a clonidine that is present. Okay, चलो भाई, मैंने पेपर नहीं दिया, पेपर तुमने दिया है, तो आंसर तो मतलब आंसर मैं बताऊंगा, बट द ऑप्शंस हैव टू बी पिटी appropriate to the kind of questions that are being framed there. Okay. Okay, fine. I get that point there. Like it is CC. Okay, labetalol. What you're saying is not in the options, और उसकी जगह पे clonidine present है. Fine. हाँ तो यार देखो, बेसिक सा पॉइंट है ना कि मैं सीसीबी तो रिफ्लेक्स टैकीकार्डिया करता, अगर मैं चार ऑप्शंस अभी भी कंसिडर करता हूँ ना, फिर भी मैं फिनॉक्साबेंजामिन आंसर नहीं करके आऊंगा बिकॉज वो पोस्ट ऑपरेटिव हाइपोटेंशन करेगा. सो आई स्टिल गो बाय ऑप्शन नंबर डी इन दिस पर्टिकुलर केस. There is a patient of bronchial asthma, and this particular chap is having SAMA and SABA and SAMA being used. तो साबा और सामा से यूज नहीं हो रहा है, तो एक ऑप्शन जो था, यस, लाबा एंड आईसीएस. ओके, सो आई थिंक दैट वुड बी द मोस्ट अप्रोप्रिएट थिंग. स्टेरॉइड्स तो देने ही होते हैं एस्थमा में क्योर करने के लिए, और साथ में व्हाट वी नीड टू डू इज वी नीड टू गिव ब्रोंकोडाइलेटर, व्हिच इज वी हैव टू चेंज फ्रॉम साबा, क्योंकि साबा का तो आजकल रोल ही नहीं है. फॉर एनी पेशेंट विद परसिस्टेंट एस्थमा वी हैव टू स्विच इट ओवर टू द यूज विद लाबा इन अ पेशेंट. बाकी साल्बुटामोल बढ़ाने से कुछ नहीं होता बिकॉज साल्बुटामोल बढ़ाने से टैकीफाइलैक्सिस हो जाता है. सो ऑप्शन नंबर बी इसलिए बाहर हो जाता है. और बाकी थियोफाइलिन आजकल यूज नहीं होता, और प्रिवेंशन हमने करना नहीं है. इट इज लाइक परसिस्टेंट एस्थमा, वी नीड टू मैनेज द symptoms accordingly in the patient. Okay, the answer would be option number A. Then is another question which I'm having issues, जहां पर APTT was initially diagnosed to be increased in factor 9 deficiency, and then we gave vitamin K to the patient, and after this vitamin K was administered, okay, after this vitamin K was administered to the patient, there is an improvement in the coagulogram, like 27910 वाला जो patient है. Yes, doctor, that's what I'm trying to say. Salbutamol नहीं देते हैं because salbutamol से tachyphylaxis होता है, तो उसके जो dose है उसको increase नहीं करेंगे. ओके जी, हेपेटाइटिस ए हेमोफिलिया इन द ऑप्शंस। बेसिक पॉइंट मैं समझा देता हूँ। क्वेश्चन का कंसेप्ट ये होगा कि पेशेंट में एपेटाइटिस डिरेंज्ड आ रहा है, तो एपेटाइटिस डिरेंज्ड है तो हमें लग रहा है कि फैक्टर 9 डेफिशिएंसी है, लेकिन जब हम विटामिन के दे रहे हैं तो 2, 7, 9, 10 का करेक्शन हो रहा है, जबकि वो तो होना नहीं चाहिए। व्हेन यू गिव विटामिन के टू अ पेशेंट, द करेक्शन शुड नॉट हैपन, सो दैट मींस द पेशेंट इज एक्चुअली हैविंग अ इशू वेयर देयर इज अ डेफिशिएंसी ऑफ फैक्टर व्हिच इज vitamin K dependent, and that vitamin K dependent factor cannot be 8. 8 is not a factor which is dependent on vitamin K. So among the options here, the only thing that was, yeah, apatite is not mentioned, doctor. I agree that apatite word is not given, but then the word is factor 9 deficiency in a patient. What I'm trying to say is the rationale behind this is कि there is going to be a deranged coagulogram, and that is why the person was diagnosed with factor 9 deficiency. लेकिन अभी इस पर्सन में विटामिन के से ठीक हो गया, तो वो ठीक कैसे हुआ? क्योंकि एक्चुअली में उसको फैक्टर 9 था ही नहीं. It is like bilateral obstruction which would be responsible for this. Okay. The answer for this one, guys, the way it is framed would be on option number D. Then patient is having increased head size. सिर का size increase हो गया. So I think one question is on acromegaly in a child, and second is for this adult male, old man with the increase in the head size. All the parameters like calcium, phosphate is present to be normal, but then the PTH values in the patient are PTH values are also normal, but in these patients you are having serum alkaline phosphatase which is disproportionately increased. Considering the disproportionate increase of serum alkaline phosphatase, that would be a Paget's disease of the bone. The answer of this question would be option number A. Yes, and there's a separate question on a 13-year-old boy with acromegaly. So both were having that increase in the head size and increase in the job. Head size increment is present in both of them. And the investigational choice in that particular case would be answered as glucose tolerance test. Other options were like insulin, like growth factor 1, etc. But I was not sure whether there were two questions of that increase in the height. So I decided to include only one only. But considering your chat, I get the point that one was acromegaly, the growth part, and second is the Paget's disease manifestation that is present. Okay. Fine, guys. Moving to the next one, we are having a patient with positively birefringent rhomboid crystals, and there's a knee pain joint that is described. So that would be a presentation of pseudogout. If you want to differentiate in this one, let me know in the options. Okay. Yes. Yeah, oral glucose tolerance test is the main test to be done in a patient, and failure to suppress growth hormone levels. It is not IGF. IGF is only a screening test. It is oral GGT that is the main test to be done in a patient. No, it is not IGF elevated. Yes, doctor, that is what I'm saying. In glucose tolerance test, it is failure to suppress growth hormone level. It is growth hormone that would be elevated. No, it is not IGF that would be elevated. In glucose tolerance test, after doing the test, we don't check for IGF level, we check for GH level. So it is increase in the growth hormone levels in a patient. Okay. Then we have this ABG question. I understand there were two questions on ABG. I could figure out only one at the moment, where I can notice that the patient is having acidosis, and that too a metabolic acidosis, because PCO2 is normal, but the bicarbonate value is turning out to be 16. And in this patient of metabolic acidosis, the anion gap is also easily calculated. That is 130 minus 84 plus 16. So what I can work out is that the anion gap in this question is gonna be, yeah, metabolic acidosis, and then we have to differentiate between acute versus PCO2 was 45. Okay, doctor. So it is anyway in a normal range, and that means that the patient is having uncompensated situation. Because the patient is uncompensated, okay, base deficit is also given to be 12. But the point is, considering that my patient is having a PCO2 value 45, this means that the person is having uncompensated metabolic acidosis. That would be an acute respiratory acidosis. Yes, doctor, there's a separate question in which the pH was 7.2 and the PCO2 was 66. That was a question on respiratory acidosis. But in this particular case, like the way the question is framed with the anion gap of 30, it was acute respiratory acidosis and a chronic respiratory metabolic acidosis given. I think, can you just quickly comment in the options whether these terms were given? Because traditionally we use the word acute and chronic for respiratory acidosis and respiratory alkalosis. So can I just have a quick comment with respect to whether these terms were given or not? Acute respiratory acidosis and then was chronic respiratory acidosis. Yes, the term was there. Okay, chronic. Okay. Okay, still, doctor, we'll go by like, if the options are like acute or chronic फिर तो है ही नहीं ना. Basically, it is just a metabolic acidosis which is present in a patient with a 9 gap of 30 is what we need to go in this particular situation. And the remaining option would be for. Okay, so I think we are mixing up the two questions here. One is going to be a chronic respiratory acidosis. So I did not have the mathematical value for the bicarbonate in that question, but it's okay. Still, I got it. pH is 7.2, PCO2 66, and there would be a bicarbonate value which has to be elevated. If the bicarbonate value is normal, then we'll say it is acute onset. If it is elevated, then we'll say chronic. So for those of you who are saying that that question is on respiratory acidosis, that is primarily for the statement on the right hand side. But if I mention the word or description for metabolic acidosis, that's gonna be like the standard one for high anion gap. Hagma is the presentation in this case. Okay, fine. Then was a question on a patient who's having HbA1c of 8.2, low ejection fraction. So standard anti-diabetic medicine, which has a cardio-renal benefit, and we will be using is empagliflozin for management of these patients. For this one, I would like to just mention that he's asking next step in the management of this patient. If he says best treatment, then it is obviously, I agree, that would be darbepoetin alpha. But in patients of CKD, there will always be an iron depletion present because of anemia, chronic disease. In these patients, iron levels are low. So we need to initially give in these patients iron supplementation. It is intravenous iron infusion that would be given initially. And then subsequently, after the intravenous iron infusion has been administered, that we can go ahead with darbepoetin for the patient. So because it is saying next step, therefore it will turn out to be intravenous iron infusion. Otherwise, for normostatic normochromic anemia, chronic kidney disease, we'll have to answer this as darbepoetin alpha. Okay, so I think we had 26 on our slides at the moment, if I include the 2 introduction slide and the thank you slide in this particular case. So these are inputs from my side at this moment, guys. And yep, it was I really appreciate this post-match analysis, I can call it. We can just laugh over silly mistakes, and we can just, I mean, not continue ruminating over it, though you will wake up every single day and you will be, in your dreams, you will be recalling that options for next few days, and that happens with all of us. But I can say at this moment that you have crossed over to the other side finally, and now you will be having like issues with how to spend your time. Now, initially it was all study, study, study. Now suddenly there's a vacuum that you tend to face, and one is always in that dilemma, like, should I still study? I mean, because there's a habit that we have. So I think with a couple of days passed over the next few days, I can say these are going to be like the most important few days of your life where you can enjoy before the result comes in. And yeah, PS4 will fill the vacuum, Arun Negi. That's perfectly fine. Watching movies or cooking or whatever you feel like going out, that would help you out. So I think we are sorted for this discussion. Thank you so much for the inputs here. And I think we can move on to the next subject. That would be anesthesia at the moment. Okay. Atrial fibrillation, Dr. I have discussed already, and thrombolysis, what we have done for that 2.5 hour symptoms of acute ischemic stroke in a patient. Okay. Fine, guys. Thank you so much.
Hello. Hello, good evening, guys. Yeah, we are starting with the anesthesia session. Right. Coming to the first question. The first question was, after a building collapse, a patient presents with airway obstruction and mouth filled with concrete debris. BP is 90/60 and heart rate of 105. The given procedure is performed, which is shown in this image. Right. Which of the following statement regarding this procedure is true? So basically, what is being performed in this procedure? It is needle cricothyrotomy, right? And which is true regarding the procedure? Remember, option A, it provides adequate ventilation up to 6 hours. That is totally a false statement. This is only done in emergency, dire emergency situations, right? Such as CICO, that is cannot intubate, cannot ventilate. You can go if you don't know how to do a scalpel cricothyrotomy. Okay? It will just provide ventilation for 10 to 30 minutes. With this needle cricothyrotomy, you will be giving jet ventilation to the patient. Okay? Next, we'll just rule out the wrong options. It allows the removal of the large foreign bodies. No, it doesn't allow. Okay? Option D, it can be safely used for prolonged airway management. No, never. It is only used for emergency purposes. Once you do emergency cricothyrotomy, this one, then you have to convert it into a scalpel cricothyrotomy, or scalpel tracheostomy, or you have to go for an open tracheostomy. Okay. What is going on over here? Wet gangrene, tenosynovitis, what is it? So anyways, so the right option over here is it must be followed by a formal tracheostomy. Right. Chalo bhai, next. A 35-year-old male undergoing abdominal surgery under general anesthesia suddenly develops muscle rigidity, rapid increase in the body temperature with tachycardia, shortly administration of sevoflurane and succinylcholine. His EtCO2 is also high, despite controlled ventilation. Which is the most appropriate immediate management? First of all, we need to understand what they are telling. Temperature is increased, muscle rigidity is occurring after receiving sevoflurane, which is an inhalational agent, and succinylcholine. These are the triggers for triggering a thing which is called as malignant hyperthermia. Malignant hyperthermia, right? Malignant hyperthermia. Going back to our LRR slide where I told you malignant hyperthermia, there are many triggers, guys. Scoline, all inhalational agents. But once malignant hyperthermia develops, what is the next best management that we need to give to the patient? It is IV dantrolene sodium. IV dantrolene sodium. Okay. Right. Next question, guys. A patient undergoing surgery receives a muscle relaxant and soon develops flushing and rashes over the neck and anterior chest. Remember, guys, after using muscle relaxant, developing allergic reaction, it is common, but common with some muscle relaxant. What muscle relaxant? We are having depolarizing as well as non-depolarizing. Depolarizing can also cause these flushes. Okay? But in the option, there is no depolarizing. In the option, they have been given us 4 non-depolarizing drugs. So in the non-depolarizing, there are 2 categories, guys. One is benzyl isoquinoline, other is aminosteroid. Benzyl isoquinoline are the drugs which will cause allergic reaction, which I taught you in the LRR session also. Benzyl isoquinoline examples are atracurium, cisatracurium, mevercurium, doxycurium. They all will release histamine that will cause allergic reaction. Okay, so over here, basically we can rule out vecuronium, pancuronium. They will not cause allergic reaction. Which can cause allergic reaction? Atracurium and cisatrac. But remember, which releases histamine most? Most histamine is released by atracurium. Cisatracurium releases less histamine. So this would be the answer for it. Okay. Chalo. Next. ठीक है. Which intravascular fluid in excess can cause hyperchloremic metabolic acidosis? Right? Which intravascular fluid can cause hyperchloremic metabolic acidosis? Come on, guys. Ringer's lactate, normal saline, DNS, and colloid. Directly from our notes, not from LRR, but from the notes, guys. I told you normal saline. Okay? Normal saline, when used in excess, the terms are also same. When used in excess, will cause hyperchloremic metabolic acidosis. Okay? So the answer over here is what? Normal saline. Okay, right. A 3-year-old child presents to the casualty in an unresponsive state after consuming peanut. So basically, unresponsive after consuming peanut means he has choked up on the peanut. If he was responsive, we will go for a Heimlich's maneuver. But as he's unresponsive, that indicates that you have to start your CPR, that is chest compression. Okay? 3-year-old child means you have to, if he's responsive, you have to go for Heimlich's maneuver, right? If it was an infant, responsive infant, then you have to go for back slaps and chest thrust. Okay. Unresponsive was not mentioned. Okay, chalo, theek hai bhai. Agar if unresponsive was mentioned, then you have to go with chest compression. If unresponsive was not mentioned and 3-year-old child was mentioned, then you have to go for abdominal thrust, that is Heimlich's maneuver. Okay, chalo. Next, a COVID positive critically ill patient who's on mechanical ventilator with his PaO2 by FiO2 ratio showing 100. 100 is severe ARDS. Mild ARDS is usually below 300. Moderate is below 200 and more, like equal to or 100 of ratio of FiO2 by PaO2 by FiO2. That indicates severe ARDS, which is the most appropriate ventilatory strategy to manage this patient. So guys, again, for ARDS, I have showed you something. Bhai, back slaps and all infant को देंगे आप. Infant को you will go for back slaps, ठीक है? Followed by 5 back slaps देंगे, followed by 5 chest thrust. वो infants को देते हैं. अब 3 साल का बच्चा तो infant नहीं होगा ना. ठीक है? चलो अभी ये देख लो. So what you will do for this ARDS patient? Remember I told you, whenever the patient is in ARDS, will you use a high tidal volume or a low tidal volume? In the LRR also I told you, if a patient is having ARDS, you will go for a lung protective strategy. Okay? That is giving a low tidal volume and a high PEEP strategy. Low tidal volume and a high PEEP strategy. Right? So over here, what is the option? Low tidal volume and high PEEP. Option C, right? Basically, if you give a high tidal volume, it will further damage the inflamed alveoli. Okay? And PEEP is usually given as a recruitment maneuver. Okay? Is it clear? Any more questions that you remember, guys? I just came across this 4 to 5 questions. 5 or 6 questions, I guess we have done. Sir, 2 साल का बच्चा is also not a infant ना. 2 साल का बच्चा भी है तो you can give abdominal thrust. If he is responsive, unresponsive कोई भी साल का रहने दो. Unresponsive means what? You need to give chest compressions. While giving chest compressions, you need to think in your mind that he has choked upon a peanut. Okay, don't do a blind sweep, but if you see something inside the mouth while giving compression, just remove it. Okay, चलो ठीक है भाई. If at all you are feeling that these questions were like some other questions came from anesthesia, you can connect with me on the Instagram ID. Right? Okay, guys. So these were the questions. Questions still missing, many repeats. Number of questions till now, what I got from anesthesia. Okay, you're not, I think you're asking total number of questions which have been discussed. I don't know. But from anesthesia, it is 6. Okay. चलो ठीक है भाई, ठीक है. With this note, We'll conclude the session. Right. Patient unconscious means you have to go for chest compression, nothing doing. Tracheostomy means it's not tracheostomy. I think it was this thing, needle cricothyrotomy. Why did you mark endotracheal intubation? Dekho, unresponsive child is there. First give chest compression. Unresponsive means what? He might have land up into cardiac arrest. Give chest compression. After giving chest compression, in between, you have to go for endotracheal intubation. But again, the first thing would be chest compression. Okay. Needle procedure, needle cricothyrotomy. Needle cricothyrotomy. Okay, in cannot intubate, cannot ventilate scenario, you can go for needle cricothyrotomy. Okay, chalo guys. All the very best, all the very best. Right? Take care. If you are having any questions, again, you can just post me on the Instagram ID. Is it clear? हाँ, उसमें डेब्रिस था, वो हमने किया है. ठीक है, चलो, all the very best. Thank you.